we wish that we'll have an academic feast in the coming 2 days. So please give a big round of applause for Dr. Alpesh Gandhi and an entire incessant support team for this wonderful event that they have given to us. And Neeta Thakre ma'am is with us. With this, we kickstart the program for today. And may I start, ma'am, the session 1? Yes, so we start with session 1. That is our chairpersons for the first session are Dr. Jagruti Desai. May I have Dr. Jagruti Desai on the dais, please? Yes. Dr. Sanjay Shah. Thank you, sir, for being with us here. Dr. Aarti Gupta. Do we have Dr. Aarti? Yes. Thank you so much. We have all the chairpersons right on time. And our first speaker for today's morning. Introduction of Jagruti.
और ये पॉइंट मैडम कोई वीडियो है? हाँ।
So first chair for today's session is Dr. Jagruti Desai. Ma'am is a private practitioner at Udna Hospital Private Limited, and she is Foxy recognized lab training center, Dr. Paul's Institute, Kochi. She has numerous awards and papers to her credit. She is a life member of various societies like IAG, IMS, and presently she is the vice president of Udna Medical Association 2018-22. Welcome, ma'am, to this prestigious conference. Our second chair for the session is Dr. Sanjay Shah. Sanjay Shah, sir. Sir, CV is not here. Sir has been associated with so many institutes and so many prestigious conferences all over, and we are so much pleased to have Sir amongst with us. And Sir, thank you for giving us this honor to chair this session today. And we have our third chair for today's session is Dr. Aarti Gupta. She is Consultant Director, Pulse IVF, Maninagar, Ahmedabad, and she has special interest in clinical genetics and genetic counseling. She has her recent publications in epigenetics in pregnancy. And ma'am, we are welcoming you to this prestigious conference. Thank you for giving us that honor of welcoming you all. So can we have our first speaker on dais, Dr. Beenal Shah? Yes, Dr. Beenal Shah, can I request one of our chairpersons to please introduce Dr. Beenal Shah. Dr. Beenal Shah's topic is how to tackle single fetal demise in twins. Welcome, Dr. Beenal.
Hello. A very happy morning to one and all, and this is an excellent start with Dr. Beenal Shah. She is a consultant gynecologist and laparoscopic surgeon, gold medalist at MD. She has done diploma gynec endoscopy and past president of BOTS, presently president of Menopause Society, Baroda. To her credentials, she has won many awards at IAG conference, Aurangabad, with best video presentation at ISG. And she is the Wonder Woman of Vadodara, awarded by Radio City 91.1. Awarded Inspiring Gynecologist Award also at West India, Economic Health India. And she is a pride of Baroda and pride of Gujarat Gynecological Society, and I may say of all over India also. So welcome you, madam, for your discourse.
Yeah. Thank you so much, ma'am. Thank you for the kind words, and good morning, Ahmedabad. I bring greetings from the cultural capital of Gujarat, Vadodara. And today, to be the starting batsman, the topic which is given to me is single fetal demise. How to tackle a single fetal demise in twins. Yes, this is something which, we obstetricians who are tackling high-risk pregnancies, multiple pregnancies, and as you know, that the number of multiple pregnancies is increasing with the increasing IVF rate. And 98% of multiple pregnancies are twins, and they are associated with higher risk of perinatal mortality when compared with singleton pregnancies. Intrauterine death of one fetus considerably increases the risk of morbidity and mortality of the surviving co-twin right? So egg free is not always good. And it is always like rather than 2 lives, like the mother and the fetus life, we have right now 3 lives in tandem. That is the mother and the twins, and one is dead and the other one is alive. The overall incidence of this situation where there is a single fetal demise after 20 weeks is between 3 to 6% of all the twin pregnancies. So what could be the reasons of single fetal demise? Intrauterine reasons could be maternal and fetal. Maternal side hypertensive disorders like eclampsia, thrombophilia are the common ones, leading to abruption also. And fetal complications like infection, chromosomal abnormality, any structural abnormality, even cord anomaly like entanglement of cord, filamentous placenta insertion, twin-to-twin transfusion, and selective IUGR. These are the causes from the fetal side which could lead to a single fetal demise. Now what happens, like what are the theories which put the surviving co-twin into risk? One is the hemodynamic fluctuation which is going to happen. The theory is proposed by Fusey et al. And it is hypothesized that the death of one twin leads to transfer of blood from the surviving fetus to the dead fetus. This is called the back bleed. This leads to hypoperfusion, hypotension, and fetal anemia in the surviving fetus. This in turn results in tissue hypoxia, acidosis, and damage to all the fetal systems, including the CNS. So that is the most vital thing. The second thesis which has been put forward is the Trans-Chorionic embolization and coagulopathy. It has been hypothesized that the passage of a thromboplastic material, like all of us are aware that whenever there is some dead tissue, it acts as a thromboplastic agent. From the dead twin, when it passes to the co-twin, it can, because via the placental vascular anastomosis, this can lead to DIC in the surviving twin. DIC can cause infarcts and cystic changes in all the vascular systems of the surviving co-twin, including the neurological system. So surviving co-twin is potentially at a risk of same pathophysiological condition as the one which died. Okay, so obviously we can understand the surviving co-twin is in danger. And what are the main 2 factors which are of importance whenever we consider the outcome? One is the timing of fetal demise. Like when did the fetus die, that co-twin, and the chorionicity, right? Because that is going to indicate what is the vascular anastomosis between the 2. Fetal demise between the first trimester is the most common, and the risk to damage to the survival is very significant because structural abnormalities are seen in the survivors, which are like neural tube defects, optic nerve hypoplasia, hypoxic ischemic lesions in the brain, and hydranencephaly, porencephaly. Fetal demise in the late 2nd and the early 3rd trimester. Now this is a scenario which puts the obstetrician to most dilemma and most confusing situation. Because we are worried about the surviving co-twin, at the same time we don't want to deliver it early because it will be a premature delivery, right? So this is the most difficult choice, and there is the most potential dilemma, what to do, whether to conservatively manage or whether to put risk morbidity and mortality of the survivor as the pregnancy advances. Because premature fetuses are more susceptible to insults leading to neurological and long-term complications seen in the surviving fetus. So they may seem intact. Like for example, in this ultrasonography, they may seem intact, the growth is going fine, but most of the clinicians will not intervene. And as the synergistic effect of the prematurity and low birth weight will superimpose upon the potential damage to the co-twin. So the timing of fetal demise, the first trimester loss is not known to result into adverse outcome, although this statement is controversial. However, single fetal demise in 2nd and 3rd trimester puts the co-twin to risk, and mainly more common in monochorionic and diamniotic pregnancies, resulting in extreme prematurity, fetal death, hypoplasia, and necrotizing enterocolitis. So I can very well give the statement that survival of the co-twin is inversely related to the gestational age of the single intrauterine fetal demise. So it is inversely related, and opposite sex twins, obviously that will be dichorionic, are associated with more survival rate. Same sex twins are associated with less survival rate. Monochorionic pregnancies are at a greater risk due to the shared placental circulation. This was a recent systemic review which showed that following the death of one twin, the risk of death to the co-twin was 12% for monochorionic and just 4% for dichorionic. So now we are faced with 2 options, whether to go for a prompt delivery of the surviving twin or whether to just have close surveillance. Once conservative management is chosen, close surveillance of the survivor is performed, including NST, sonography. Most of us now go for the Dopplers, along with the growth assessment. Sonography with or without MRI should be done to see the end organ damage. Normal fetal surveillance is not a guarantee of good outcome. So this is what you need to remember. Like some mishap has already happened and you don't want to, increase the, worsen the outcome still. So just fetal surveillance, you have to always counsel the couple that keep this in mind that something may go wrong at any time, and neurological damage may occur in the surviving twin with normal ultrasound findings. And a reactive CTG tracings as an intact brainstem as detected by the postnatal CT. So prompt delivery versus close surveillance, we have these references from the Australian Journal, British Journal and the fetal diagnostic team that delivery, some prefer that you should be waiting till 37 weeks and keep the surveillance very strict. The others are suggesting that if you have a good NICU backup, it is better to deliver the co-surviving twin by 32 or 34 weeks. Obviously, you have to see for the lung maturity, give betamethasone. But if you have we are very confident of our NICU backup, it is better to deliver. So this is a simple algorithm, management of a single intrauterine fetal demise in twin pregnancies. Suppose it is dichorionic, and you have to also see the maternal environment. If the maternal environment is hostile, it is better to deliver, right? If the maternal environment is not hostile, you can go ahead with the conservative management. In monochorionic, if the pregnancy is almost term or near term, it is very obvious, it is better to deliver, right? If it is preterm, go ahead sometime with the conservative management, give steroids and then later take on a decision. Preterm but ongoing death, consider intrauterine blood transfusion because there is a chance of hypoxia, right? So betamethasone we have discussed. No other factors are intervening, then you can wait till 37 weeks. In monochorionic, mainly the more debate is in the monochorionic, that whether to wait till the 37 week or whether to, just deliver if you have a good NICU backup by the 34 weeks. Mode of delivery, again, vaginal delivery is not contraindicated, but as all of you here are experienced obstetricians, you know that sometimes it may be obstructed labor, especially if the dead twin is presenting. In monochorionic twins presented with single intrauterine fetal death, cesarean section may avoid the risk of acute TTS, which can happen due to the vascular anastomosis. So mode of delivery I leave to the obstetrician, but you have to always, keep in mind that what complications may occur. Again, post-delivery, just don't forget the fetus once you have delivered. Post-delivery, the couple needs to be counseled about the post-mortem of the dead twin, right? You don't need to forget that, okay, it's dead and gone, because you need to find the cause of death. Placenta should be examined with the injection study to confirm the chorionicity. Full examination of the surviving neonate, especially the neurological examination, cranial ultrasound and MRI. Remember I told you that even if the sonography is showing normal fetal development, there may be some intracranial abnormalities which may happen in the surviving twin. And antenatal period, and the pediatricians also need to follow the surviving twin, whether he or she is following normal milestones, right? So this is a simple diagram that co-twin demise, death of one twin. There may be a sudden acute shift of blood to the surviving twin to the dead fetus, and this leads to the neurological damage in the surviving twin. So this is something which you need to remember, need to, counsel the parents for the same. This is again a summary or an algorithm from the Royal Australian and New Zealand College of Obstetricians and Gynecologists, where you need to decide, whether to continue or whether to give a conservative management. So these are the key points in management. First and foremost comes counseling and support. Individualize the management plan, like one size will not fit all. Management in a tertiary sector, obviously with a very good neonatal support. Information on the chorionicity is important. Fetal anomalies, close surveillance is important. Steroid prophylaxis obviously is needed. Vaginal delivery may be possible, but you have to see. Postmortem examination of the stillborn and pediatric assessments. So these are the practice points. Thank you so much. Thank you for this patient hearing. And I welcome you all to Vadodara in February. We are hosting the National Conference of the Indian Menopause Society, and we'll be taking you to the Statue of Unity, the tallest statue in the world. Thank you.
Thank you, Dr. Beenal Shah. As an opening batsman, you have done a perfect job.
Yeah.
And I'm sure and I'm confident that with your opening, with a perfect score, the conference will be a success. So thank you very much.
Thank you very much, ma'am. I wish all the best to the conference. Really very vital topic. I even congratulate Dr. Alpesh Gandhi, sir, Neeta madam and the team. Thank you so much. Thank
Yes.
you, Chairpersons.
Yes, it is not like one pay, one free, you rightly mentioned. And you very well described about all the causes, the management and when to deliver. So excellent job. Congratulations. Thank you.
All right, I'd like to introduce the next speaker, Dr. Priyankur Roy. His topic is prediction of eclampsia, including the gestation score. Dr. Priyankur is the Assistant Professor, Lord Buddha Koshi Medical College and Hospital, and Consultant in Fertility and Gynecologic Endoscopy at Roy's Clinic in Nova IVF, Siliguri. He has been Joint Secretary of Siliguri OBGY Society and the Secretary of IMA, Vice President of WATOG and FIGO, and Joint Secretary of Justices as well. And he is the National Coordinator of Public Awareness Committee, FOXY. He has published more than 70 articles and authored a lot of chapters, as well as he's been a peer reviewer of various journals. Welcome, Dr. Priyankur. We're looking forward to hear from you.
Thank you. Good morning, everyone. It gives me a pleasure to be standing in front of all of you today to talk about predictors of preeclampsia. And I was told to include the gestation score, but considering the time, I'll be talking mainly about the gestation score because I thought predictors of preeclampsia we do discuss normally, and this would be something that we normally don't discuss and would be beneficial to all present here today. So with the permission of Chairpersons, I'd like to begin my talk. So we come across this famous quote by Professor Muhammad Fatullah. Women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. A very appropriate quote when we talk about preeclampsia and gestosis. Hypertensive disorders is the most prevalent medical problem during pregnancy and predisposes the patient to a lot of comorbidities and may even cause maternal or fetal death. Hypertensive disorders are more common in women receiving fertility treatments, regardless of pathophysiologic changes of infertility and hypertension or older age and chance of multiple pregnancies. Higher rate of hypertensive disorders in women who underwent infertility treatment might be due to higher age or as well as in case of multiple pregnancies. We have a recent concept about preeclampsia and IVF pregnancies that also needs to be looked into, but then as of now, definitely multiple pregnancies and older age is an important factor that we need to look into when we're talking about gestosis. Pathologic basis of infertility like polycystic ovaries and endometriosis must be considered as a cause of correlation with hypertension. In these conditions, hypertension may simply occur due to associated obesity or insulin resistance. Now, insulin resistance in infertility is one of the factors that later on can cause hypertension even when the patient has conceived. Chronic hypertension can cause poor quality eggs. Also, hypertensive women suffer from obesity, which is mostly a result of excessive estrogen production. Antihypertensive medications like ARB and calcium channel blockers typically affect male fertility rather than female ones. So when we are taking a history of infertility, please do make a note of the male factor as well, which is also very important, the medications taken by the male as well. Now coming to the gestation score proper. I would like to mention all the points that are over here because I think this is an important thing and that we need to score just because in today's day there's a simple app called the Gestosis app with which we can score a patient in the clinic, and the easier things is once we score a patient we can tell our probably the staff who's working in the clinic to score, and when it's more than 3, we know that the patient is at a higher risk of gestosis, and of course start on ecospirin, etc., which will the staffs will warn us in turn, as well as they will also know exactly what is happening and they know which patient to take care of more carefully. So the risk factors, if you look over here, woman born as small for gestational age, this is probably one of the adult onset fetal disorders fetal onset of adult disorders that we are talking about. Then we can talk about maternal anemia, age more than 35 years, obesity, nulli gravida, short duration of paternity, family history of preeclampsia, family history of cardiovascular diseases, polycystic ovary, interpregnancy interval of more than 5 years, assisted reproduction, and maternal hypothyroidism. If you go through this list, I am sure in our clinic, we at least have 1 or 2 risk factors that we see in every patient. So if you look at the overall picture, a Gestosis score of more than 3 is where we need to start ecospirin, and most of the patients will fall in that category. So this was a question that I initially used to ask myself, then why do a Gestosis score when this is the situation and most of the patients will fall in the category? But then, of course, blanket therapy nowadays do not exist in this medical legal world, and we need to diagnose, we need to categorize, we need to put them exact score on paper so that we can start on whatever treatment and later on cannot be held for any medical legal reason. The other factors that you look at with a score of 1 still continuing, chronic vascular diseases, excessive weight gain during pregnancy, MAP of more than 85, gestational diabetes onwards we have a score of 2. So please see the scores on the other side. It was 1 till now. We start with 2 with the gestational diabetes, obesity, multiple pregnancy, hypertensive disorders during previous pregnancy. Now score of 3. So these are the scores. If one of the factors fall in this category, we know that this patient is at a high risk, for gestosis, and start off with ecospirin directly. So these factors are pregestational diabetes, chronic hypertension, mental disorders, inherited or acquired thrombophilia, maternal chronic kidney disease, autoimmune diseases like SLE, etc., and assisted reproduction technique. So assisted reproduction technique, whenever for a patient we do a ovum donation. See, there's a difference in this. Assisted reproduction by IVF or ICSI treatment is 1. But when we go for a OD, that is a ovum donation, it comes directly to the category of 3. So whenever we do a patient of IVF with ovum donation, the patient is directly in a category of 3, and we need to start this patient on ecospirin. Most of the IVF specialists, I'm sure, already starts the patients on ecospirin and heparin, etc. But then please make a note of this. Any OD patient, ecospirin is a must that needs to be started on. So how do you calculate the gestosis score? As I've already mentioned, the points 1 to 3 is allotted. If any score is more than 3, then that should be at high risk of preeclampsia. Preventive measures in the form of aspirin must be started, and also of course calcium 1 to 1.5 gram as early as possible. Now ecospirin, again, it's aspirin, low dose aspirin. 75 or 150 is a thing of debate which can go on for like the whole day probably. But then yeah, nowadays we usually go on with the 150, and I do not like the debate is beyond the scope of this talk today. So small for gestational age, if you look at, risk of severe preeclampsia is enhanced by having been born or small for gestational age. The risk for both mild and severe preeclampsia is enhanced by the exposure of maternal preeclampsia. Prematurity as well as low birth weight and small for gestational age were significantly associated with increased risk of preeclampsia. Now, if you look at the maternal age and preeclampsia, older maternal age is associated with lower second and third trimester systolic BP, but higher third trimester diastolic BP. Now, this again a category of the hypertensive disorders that we look at. These BP differences seem to be small and within the physiological range. Maternal BMI might influence the association with maternal age and the risk of pregnancy. Pregnancy outcome in adolescent population with severe preeclampsia was similarly adverse. Obesity, another risk factor. A short maternal stature and a high BMI increases the risk of preeclampsia of all severities. The association seems especially strong between short stature and severe types of preeclampsia and high BMI and mild type of preeclampsia. Obesity in young age was found to be a risk factor for preeclampsia. So obviously, as we know, obesity risk factor for most of the things, but at a younger age, it's at a more high risk, so requires more counseling for reduction of junk food, etc. Compliance to folate supplement and adequate food consumption were found to be protective against preeclampsia. Nulli gravida, another risk factor if you look at it in pregnancy, it causes increase in the SFLT1, which we know is nowadays a predictor for preeclampsia, and SFT1 and PIGF ratios that than multiparous pregnancies, suggesting an association with an angiogenic imbalance. The pathogenic role of anti-angiogenic factors in preeclampsia may be one explanation for the epidemiological observation that nulliparity is a risk factor for the development of preeclampsia. Looking at PCOS next, women with PCOS have an increased risk of preterm delivery compared with the background population. Thus, the incidence of preeclampsia was significantly higher in patients with PCOS than in controls, which was mentioned in the gestosis score in the first couple of slides that I talked about. Now looking at the ART IVF pregnancies, nowadays we have a lot of patients who are on ART IVF pregnancies. Now remember on the score we talked about two categories. One was the ART IVF ICSI population where the score is 1, but when we are going for a OD, that is ovum donation, the score directly moves to 3 and directly falls into the high gestrosis category. Okay, this one other point that I need to mention in the ART IVF category is patients with azoospermia and oligospermic partners have an increased risk of developing preeclampsia. ART, particularly IVF, is associated with hypertensive disorders. We all know it. The association between ART and severe PE suggests that abnormal placentation may trigger a more severe systemic phenotype of preeclampsia. Now, this is a thyroid disorder which has recently come into the ESHRE guidelines as well and is one of the factors which we need to investigate when we are talking about preeclampsia. A positive association was found between thyroid hypofunction and preeclampsia. Sometimes a thing that we do not mention much, but this is something that we need to definitely look at. With regards to results of a study, the measurement of serum levels of FT3, FT4 and TSH can be suggested as a criteria for prediction of preeclampsia. Next, looking at GDM. GDM is associated with gestational hypertension. We all know it. The risk is almost as high as 1.5. Multiple gestation. Twin pregnancies have an almost 3-fold increase in the risk of preeclampsia. Egg oocyte donor, as I mentioned, recipients with multiple pregnancies might face a very high risk of preeclampsia. And in twin pregnancies, the ratio of SLFT1 and PIGF ratio was twice as high and is a cause of preeclampsia. Now, the last factor I'll talk about is the mental health. A diagnosis of schizophrenia or bipolar disorder conferred a 5-fold increase in the likelihood of having preeclampsia in one study and 3-fold increase in the other. So it is definitely a high risk factor. Now, to conclude my talk, I would say gestation score should be routinely practiced and it's very beneficial if you look at, it's very easy to do and it's beneficial, even the staffs can mention and do it. The importance of early life programming for risk of developing gestosis in adults is an impetus for preventive measures to secure maternal and child health. Efforts to prevent preeclampsia and GDM are needed, as well as the efforts to improve the treatment of these conditions, and the discovery of new biomarkers may improve early diagnosis of preeclampsia. There is a Gestosis app that is present. You can just put in the risk factors and get a score, and that will be beneficial for everyone. So thank you so much for the patient hearing, and thank you, Chairpersons, for giving the opportunity.
Thank you so much, Dr. Priyankur, for a very succinct explanation of the entire gestosis score. And I think what you very correctly mentioned was the objective importance of the score, where you're able to score a patient objectively so that we know exactly what the score is and we're not empirically just treating patients. Thank you so much.
Thank you so much. Thank you.
Now, may I invite Dr. Charulata Bapaya. She is the consultant gynecologist and endoscopic surgeon at Pune. She is the National Coordinator for Breast Committee Proxy. She is Director of GEMS Hospital and Endoscopy Center and Ashwin Hospital, Pune. She is honorary consultant on so many hospitals in Pune and trained in the gynec endoscopy under Dr. Rakesh Sinha at USA. She is trustee at Bal Kalyan Sanstha, Pune, and she is invited to Israel to speak on endometriosis in India in 2013. So, Madam, please, the stage is yours.
Thank you, Chairpersons, for your kind words, and it's a pleasure to see Dr. Aarti, a product of Pune, doing so well in Ahmedabad and as a chairperson for my session. Good morning to each and every one of you on this bright winter morning, and I would sincerely like to thank Dr. Alpesh Gandhi sir and Dr. Neeta Thakre and the rest of the organizing committee for having me here for this important topic. My topic for today is thrombocytopenia in pregnancy. Well, it seems like a rather theoretical topic, but for each and every one of us as an obstetrician who are very worried about any kind of hemorrhage, we really worry because we know that platelets are an important part of the coagulation system, and if they are going to be less, then what are we going to be facing? Thrombocytopenia? What, when, how? Thrombocytopenia can be defined as a blood platelet count below 1.5 lakhs and is the second leading cause of blood disorders in pregnancy following anemia. We all know that the normal range is between 1.5 and 4.5, and anything less than 1.5, we should be worried, or we should at least have an alarm ringing in our mind. It complicates as many as 70 to 10% of all pregnancies.
A drop in platelet count to 2,50,000 in the first trimester, which further decreases to 2,25,000 at delivery, is considered physiological. It occurs because of hemodilution, increased consumption in the peripheral tissues, and increased aggregation. A very long list of reasons is put forth as the causes of thrombocytopenia in pregnancy. Some are pregnancy related, some are non-pregnancy related. We are mainly going to be dealing with the gestational thrombocytopenia, preeclampsia, eclampsia, the HELP syndrome, and the acute fatty liver of pregnancy, which are probably the most important causes of thrombocytopenia that we need to know about. And we'll briefly be touching upon a few like dengue in pregnancy and the immune thrombocytopenic purpura today. So the gestational thrombocytopenic purpura is a diagnosis of exclusion, friends. It is a benign asymptomatic condition occurring in the second half of pregnancy in the absence of thrombocytopenia outside pregnancy. Accounts for nearly 70 to 80% of all cases of thrombocytopenia. There is only a mild to moderate drop in the platelets in the range of 1.3 to 1.5 lakhs. If your platelet count is less than 50,000, friends, it will exclude gestational thrombocytopenia and you need to look for some other cause for this drop in the platelets. Gestational thrombocytopenia is not associated with maternal or fetal risks, very important take-home message, and does not require any further investigation except for a periodical monitoring of the blood platelets. So as we decided, it generally requires no treatment. How often to do the platelet count depends upon the obstetrician. There are no clear guidelines. But what is most important is that before the woman goes into labor, before there is any kind of surgical intervention, either in the form of epidural analgesia or a C-section, a platelet count is a must. A value of more than 75 to 80,000 is considered safe before giving an epidural analgesia. There's a theoretical concern over the risk of an epidural hematoma with low platelet values, but not very commonly seen. The current guidelines suggest that vaginal delivery is safe when platelet count is more than 30,000 per millimeter cube. For operative vaginal or C-sections, the safe platelet count would be at least 50,000. Spontaneous bleeding may occur with less than 20,000 platelets, and the risk of internal bleeding will increase if they fall below 10,000. But of course, as we just said, if the counts are so low, we're not dealing with gestational thrombocytopenia, and we need to look for some other cause. A spontaneous resolution postpartum and no neonatal thrombocytopenia is the usual outcome. So it's a very benign condition that we are dealing with. We don't have to worry too much about it, but we should be aware of it. Coming to something much more important is the preeclampsia, eclampsia, HELP, and acute fatty liver disorders causing thrombocytopenia. They account for 20% of all cases. And sometimes, friends, a fall in the platelet value may be the only initial sign of the hypertensive condition predating all other lab tests. Important take-home message once again. The platelet count rarely falls below 20,000. The pathophysiology is thrombotic microangiopathy, characterized by endothelial injury, followed by platelet aggregation and thrombus formation in small vessels. Presence of schistocytes, raised bilirubin, along with elevated LDH are going to clinch the diagnosis. Acute fatty liver, not very common, but a very severe condition in the third trimester of pregnancy, characterized by abdominal pain, nausea, vomiting, anorexia. Thrombocytopenia can be rather severe over here, less than 20,000. HELP syndrome, all of us are very well aware of. The hemolysis, elevated liver function test, low platelets, can occur without proteinuria or hypertension, and the diagnosis can sometimes be missed. Again, the physiology is similar. The platelet count is usually less than 1 lakh, and majority of the cases occur between the 27th to the 37th week of gestation, but can sometimes occur postpartum also. The main treatment for this is delivery, and only delivery. A very low platelet count in these cases, please go ahead with the delivery. Aim is to maintain the platelet count above 50,000 as we just discussed. Dexamethasone 12 milligram IV every 12 hours, 2 to 4 doses antepartum and 2 doses postpartum is recommended. Platelet transfusions are indicated only in patients with a platelet count below 50,000 or suspected DIC. But however, these transfusions are less helpful, essentially because the pathophysiology is a rapid destruction of the platelets, and they help to maintain, treat the thrombocytopenia only if there is active bleeding. Once the patient is delivered, the platelet count is going to come back to normal within 4 days and above 1 lakh by the day 6. Coming to the immune or the idiopathic thrombocytopenic purpura, it is an autoimmune disorder characterized by the anti-platelet glycoprotein antibodies which stimulate platelet destruction in the spleen. We are going to deal with the chronic form of the ITP where there is a moderate thrombocytopenia, count is below 1 lakh. Most of these patients are asymptomatic, but some of them can present with bleeding gums, petechiae, purpura. They may present for the first time during any trimester of pregnancy. And how do we go about managing these patients? Well, very important that they can cause an adverse effect on the mother as well as the fetus. But the ITP does not worsen because of pregnancy. Around delivery, the platelets to be maintained above 50,000. I think this is the bottom line for everything. Platelet count above 50,000 is something that we all will be looking at. Spontaneous bleeding is the main maternal risk if the platelet count falls below 20,000. If the platelet counts are less than 30,000 before 36 weeks of pregnancy or a symptomatic patient or an invasive procedure is planned, steroids or IV immunoglobulins are recommended. Usually prednisolone is the first line therapy recommended for at least 21 days, which can exacerbate gestational diabetes, hypertension and weight gain. Of course, the second line of management is the IV immunoglobulins at the dose of 1 gram per kilogram. And the response is faster with the IVIG. Is there any role of splenectomy in ITP? Well, on only very severe cases of thrombocytopenia which are unresponsive to any other therapy can be safely performed in the second trimester. Once again, platelet transfusions are not indicated because of the consumptive nature of the mechanism. In case an emergency C-section is planned, once again, the bottom line, 50,000 is the platelet count that you require along with IVIGs. Neonatal platelet levels need to be monitored in ITP cases. Once again, an important take-home message because you can have hemorrhage in the brain and brain ultrasound is also recommended even if the babies are asymptomatic. Treatment with platelets and IVIG may be required in severe neonatal thrombocytopenia. So the cases which we would like to investigate are those who have had known thrombocytopenia before pregnancy, which occurs in the first and second trimester, and a platelet count below 75,000, and in cases of pregnancy with complications. Most of the times, only a CBC is more than enough. Evaluation of the PBS to rule out pseudothrombocytopenia and bone marrow is very rarely required in pregnant women. Numerous assays are available for platelet-associated antibodies, but not routinely recommended. Well, I searched a lot of the Western literature, but nobody seemed to be talking about dengue in pregnancy, which is so common in our country. I'm sure each and every corner of India has seen dengue, and pregnancy associated with dengue is so common. It is characterized by high-grade fever and a low platelet count of below 1 lakh. A trigger for blood transfusion should be kept at a low level for dengue than in any other BT indication. Fresh blood transfusions are indicated if an overt blood loss of more than 500 cc is suspected. And once again, prophylactic platelet transfusions are not recommended unless delivery is inevitable in the coming 6 hours. And, we need once again the 50,000 mark and the 75,000 mark out here too. Why should we worry about thrombocytopenic purpura? Essentially because you can have stillbirths, you can have IUFDs, you can have prematurity, spontaneous abortions are very high. Plasmapheresis and fresh frozen plasma transfusions are indicated in these cases. And so, to end my topic, I would just like to summarize saying that maternal thrombocytopenia between 1 lakh and 1,45,000 in asymptomatic pregnant women with no history of bleeding problems is usually because of gestational thrombocytopenia. Given the very low risk of serious neonatal hemorrhage, the mode of delivery in pregnancy complicated with immune thrombocytopenia should be determined based on obstetric considerations alone. Consensus guidelines recommend platelet transfusions to increase the maternal platelet count to more than 50,000 prior to any major surgery. Epidural or spinal anesthesia is considered safe in women with a platelet count of more than 70,000 per millimeter cube. Thank you so much for a patient hearing. Thank you.
Madam, very nicely you have covered very confusing topic, because when the patient comes with the gradually reduced platelet count, and always the obstetrician is in dilemma whether it is a medical problem or what to do, and the hemato-oncologist's opinion will be taken up to that level they will go. So very nicely covered. Only one thing, madam, I want to ask. Suppose the patient's platelet count is between 50,000 to 1 lakh, would you investigate thoroughly, or do you believe that this is the gestational thrombocytopenia? Patient has no complaint, no fever, dengue is negative. Do you recommend any higher investigation?
Absolutely right, sir. But we just mentioned that, in gestational thrombocytopenic, it is, between 1.2 and 1.4, 1.5, that is the usual platelet count. So what I would recommend, if that there is no other risk factor seen, a serial monitoring of the platelet count probably every month would be a good idea. In a big city like Pune or Ahmedabad, we have hematologists available very easily. So I would definitely take an opinion of a hematologist in this particular case, but I would definitely would not worry, because we have seen that a cutoff of 50,000 and 70,000 is what has been aptly mentioned time and again in each and every study, which is the dangerous level for any kind of complications, sir. So personally, if you ask me, I wouldn't panic, and nor would I make my patient go into a panic mode. I would probably suggest an institutional delivery for her and not look after her in my small nursing home. That is one step that I would definitely recommend in this particular case, sir.
And madam, any adjuvant do you like to give when the platelet count is between 50,000 to 1 lakh? So you are planning the cesarean section. So would you give the Tenexamic or vitamin K or like that? Any adjuvants will you give?
Undoubtedly, we will give, and all said and done that, we would definitely be looking at, some kind of platelet transfusions will also be kept ready if the count is so low. So that is definitely something that we'll look in.
Thank you very much.
Thank you for your questions, doctor. Thank you very much.
Thank you, Chairpersons. So now we go ahead with the next session. The next session is a very relevant topic for all of us. It is about sepsis, which is an unavoidable scourge in our practice. For that, I request the Chairpersons to come on dais. Our Chairpersons for the next session are Dr. Asha Jain. She is the Director of SMSA Hospital. She is also the Medical Director of NGOs, elected members of Medical Council. She has been the President of Raipur OBGY Society in 2018-20 and 2022. Welcome, Madam. The next Chairperson is our very senior gynecologist, Dr. Sandhya Chasatia. She is the ex-President of Surat OBGY Society, ex-President of Menopause Society of Surat, member of Reproductive Endocrine Committee of FOGSI. Welcome, Madam. And we have Dr. Prerna Kishan. She is our very dynamic East Zone Coordinator of FOGSI for various activities. She is a well-known faculty with various publications to her credit. She has been awarded the Wonder Foxian of 2019, and yesterday itself she received a very prestigious award from Dr. Alpesh Gandhi, which was a champion of Foxy for her work during the pandemic. Welcome, Chairpersons.
Hand over the session.
Please begin the sessions.
Respected seniors and dear colleagues, good morning to one and all. It's a pleasure to be here in this auspicious conference which is taking care of the mothers. In today's era, the maternal health, as we know very well, this ICCOB conference, 7th conference, is really a great meaning on today morning. It's a pleasure to introduce Dr. Niranjan Chavan, a professor and unit chief, ONG, Lokmanya Tilak Municipal Medical College and Hospital, Mumbai. He is a joint treasurer of FOGSI. He is a vice president of OGS, member Oncology Committee, Suffolk, Dean AGAG and Chief Content Director at HIGH and Grand High Grand and FMS courses, and Editor-in-Chief, famous JGAB, Angiography and TOA journal, 54 publications in international and national journals, and with 76 citations too. The editorial board, European Journal of Gynae and Oncology is Italy, is also one of the more feather in his cap. I would like to have Dr. Niranjan on stage.
Sir, yes.
Sir, the stage is yours.
और ये लेजर पॉइंट अगर आपको कोई टॉपिक पे तो आगे जा रहा है
Thank you so much, Chairpersons. It's an honor to be here in the city of the father of nation, Mahatma Gandhi, and coincidentally, Dr. Alpesh Gandhi has invited all of us, and hats off to the AOGS committee who have taken the lead, Delhiwala, Dr. Munjal Pandya, Neeta Thakre. Thakre is synonym to Maharashtra also. But you are a different Thakre, and thank you all of you to hear me. Today I am going to speak something very different and which we come across, that is chorioamnionitis. We have patients. I come from Sion Hospital, which is called popularly as Sion Hospital, and it is in the midst of the largest slum area of Asia, that is Dharavi, and we cater to 14,000 deliveries. Today I am standing because of that. I am not standing as my name is Niranjan Chavan, but the efforts and the work which, the load which we have has made me what I am, and obviously that's why I have been talking today on LACS. So 50% of patients which come to us are transferred, referred, and they are literally coming in ambulances, and they are coming for cesarean sections. Our rate of cesarean section is very high. The commonest indication is usually fetal distress, prolonged labor, and there are certain patients who are having multiple PV examinations. They have undergone oxytocin drip. Previously, 5-10 years back ago, we used to get patients with neglected transverse lie. If you recollect your obstetrics and your hospital and institutes, they used to be on pitocin drip, and when we used to put finger inside and the hand, we used to shake hand with the baby, and it was a neglected transverse lie. So those days are gone. But obviously there are meconium stained liquor, which is a commonest cause, and that all, apart from this, the infections which are causing, the patient has already got subclinical infection, which can worsen to have a clinical or a subclinical chorioamnionitis, and this is the pathophysiology which is seen here in the chart, being very nicely explained, leading to perinatal death and maternal morbidity. 96% of such cases which come to us are because of ascending infection which goes up, and that is hematogenous spread, local spread, maternal septicemia, and it is because of organisms like E. coli, Mycoplasma, Uroplasma, Group B streptococci, and anaerobic bacteria. We have to understand that these are the organisms which are commonly found, and when the patient is examined, she has fever, there is maternal tachycardia, there is fetal tachycardia. You can find out that even though fetal distress is there, you cannot literally make out whether there is actual fetal distress or tachycardia. The pulse is very thready, and the fetal heart sounds are above 160, 180. So this is what, and there is tenderness. So we have to be very sure. Such cases we do get, of course, and it suggests intrauterine infection. Now we are in a dilemma whether to do normal delivery, to prolong it, or to take her for section, because that is a very important decision which we have to take. And the worst scenario, in few cases you find tenderness, pus, also rarely a foul odor. Unfortunately, these cases are not so common nowadays. They are very, very less over a period of time. But what we find is preterm labor. We find premature rupture, and that is subclinical chorioamnionitis. And I already have discussed the vital parameters which are there shown in front of you. But we need to immediately collect the blood, send it for the lab, and try to confirm and correlate that yes, there is leukocytosis, CRP level is high, and further higher investigations are not done in our country but they are to be mentioned here for theoretical purpose, like SICAM1 and interleukin 6. So basically these are the organisms which are found, which I have already told. Apart from this, there could be Gardnerella vaginalis, bacteroids, Escherichia coli, and Listeria monocytogenes which are formed. There is one term I came across as aerobic vaginitis, and that is distinguished from bacterial vaginosis because it is literally found in the vaginal flora, and that also causes ascending chorioamnionitis, PPROM. But we have to remember at the back of our mind that these are the things you can come across. So that is appendicitis, a colicky pain, influenza, renal infection, colitis, and when there is uterine tenderness, remember it could be a concealed type of hemorrhage. So we need to have certain lab investigations, and these are in abroad. They do the amniotic fluid parameters and try to study this, and you find so many parameters being elevated. So the clinical diagnosis is based on tachycardia, fetal tachycardia, maternal tachycardia, fever, uterine tenderness, vaginal discharge, and all these factors are multiplied 2 to 4 times for a cesarean delivery. Yes, in such cases which properly anesthesia reference being taken, immediate medical call being sent, you need to await the blood investigations for some time, and you need to decide whether you would like to go ahead rather than waiting for some complications to occur. FIRS I came across, and that is a fetal counterpart of systemic inflammatory response syndrome. And here you find that there is an elevation of cord blood, IL-6, and funicitis and chorionic vasculitis. So these are different terms which can affect the fetus. And of course, we have the worst scenario with periventricular leukomalacia and cerebral palsy. And that is also something which is found because of an exposure to genital mycoplasma. And you can land the fetus with the fetal and neonatal systemic inflammatory response syndrome and pneumonia. Well, to cut it short, we need to have appropriate antibiotic therapy to be immediately started, antipyretics to be given. Ampicillin, clindamycin is the preferred choice. You need to give it pre-operatively and also continue with metronidazole. So that is an added anaerobic coverage which needs to be given, and a single intravenous dose would also suffice to a certain extent. But yes, whether now to go it for a cesarean or a vaginal delivery, the pros and cons have to be weighed together, and you need to understand the condition, discuss with the neonatologist. You need to go ahead and terminate this pregnancy so that the fetus is not jeopardized. There is no fetal acidosis to that extent, and it doesn't land up with encephalopathy. So we had to give her antibiotics, antipyretics. There are various studies which also have been done in abroad, and they find that most of these cases land up with cesarean section, and that is the fact of life. And you need to expedite as early as possible. However, you have to understand that there are also other studies that it does not cause that much difference to the fetal and the neonatal morbidity, and it does not improve the outcome. And this is a paper which I would like to tell you that when you give antibiotic therapy, you give antibiotics, antipyretics, deliver her, shorten the time, but still there is no improvement in the outcome. Well, this is another paper which tells us that you need to recognize, you need to implement, and you need to take essential steps and minimize the morbidity and the mortality of the woman and the newborn. Timely intervention is very important. Appropriate neonatal health care call has to be sent so that they can evaluate, and empiric antibiotic treatment should be started so that you don't land up further with problems. And this is also one more paper of Royal College which is there, and you need to have all these parameters as I discussed with the situation. So to conclude, chorioamnionitis is the worst scenario which come across to us in our routine obstetric practice. It causes preterm labor, it causes premature rupture of membrane of, the fetus, of the mother's amniotic fluid, maternal fever. We need to also send the culture if you have the facility, send the lab investigations. Well, histopathology is supposed to be done, but in our routine scenario, it's not possible to that extent, that of placenta and umbilical cord. You need to reduce the maternal infection, fetal infection, preventive strategies, antibiotic, antipyretic properly has to be given. And cesarean section is the option, but it does not improve the outcomes. These are my references, and I would like to thank the organizing committee, the chairperson, and the delegates to have a patient hearing. The forum is open for any questions. Thank you so much.
Thank you so much, Doctor, for a lucid talk on a really problematous problem of chorioamnionitis. Any question?
Yes, madam.
Sir, I will like to have one question. In case of PPROM, how long you will like to continue antibiotics post-delivery, because you have to intervene, and after that, how long you will like to continue?
I recollect during my residency days, in your days also, probably we used to be told to wait for 6 hours. But I think that that is not to be done now. You give one IV shot and you can take her within, say, half an hour to 45 minutes. It depends. Where is the situation? Where is the fetal head? What is the PV examination? Is it properly, going to deliver, or it is a deep transverse arrest, or it is a prolonged labor, or it is occipital posterior? So all these obstetric factors have to be taken into consideration. Yes, antibiotic needs to be given, but we don't wait for 6 hours.
No. How long you continue later on?
You have to continue. The same antibiotic course has to be continued 3 times a day.
More.
We usually give IV, madam, for at least 3 days.
Okay.
And we need to give anaerobic as well as aerobic and gram-negative consideration.
That is.
So that should be fine. Thank you, madam. Thank you so much. Thank you.
Thank you, sir. And it is my pleasure to introduce our next speaker. Dr. Tor Lee Halscott from USA. May I have his CV on display, please? Has he joined in? No, he'll be joining online. Online. The topic is management of septic shock. So, after the management of maternal sepsis. Sorry, Dr. Gita will be speaking on the next topic, septic shock. So, management of maternal sepsis. Right. Dr. Tor Lee Halscott from USA. She said no. She said yes and then she said no.
Hello, everybody. I'm Tori Halscott. Can you guys hear me?
So would you please introduce yourself?
Yes, I'm Tori Halscott. I'm a maternal fetal medicine and critical care medicine physician in the United States at Johns Hopkins Medicine in Baltimore, Maryland. And thank you very much to my esteemed colleagues from across the world for inviting us to speak. It's an absolute pleasure. And so I will share my screen and then go through my talk on the management of maternal sepsis. Okay. Can everyone see that okay?
Yes.
Yes.
Okay, great. So what we have to look at first is what we define as sepsis. And we utilize the Society for Critical Care Medicine, which is essentially the critical care analog of the Society for Maternal Fetal Medicine.
Excuse me, sir. Would you please make it a full screen?
Let's see. Let me try and change it if it's not
Slideshow.
properly.
bottom right corner of your screen. Yeah, thank you. Thank you.
Okay, you can see the slides now. Okay, yeah, thank you for pointing that out. I appreciate it. All right, so as I was saying, the Society for Critical Care Medicine has come with the definition that we utilize for sepsis in general being a life-threatening organ dysfunction due to a dysregulated host response to infection. That's a very specific, but I think complex definition. While accurate, I think we can simplify that to just infection leading to organ injury, and then how we can assess that going forward can tell us the severity of sepsis, both in pregnant patients as well as patients who have recently delivered or patients who are not pregnant at all. It impacts obviously a significant portion of patients, and that's why we're talking about it, including our pregnant patients. It has about almost a 30% mortality rate in patients in the ICU in general. This is not just pregnant patients, this is all ICU patients that have sepsis. And about 10% of global maternal deaths are attributed to sepsis as well. Here in the United States, we see it uncommonly for a patient to have critical illness from sepsis, about 0.04% of deliveries. But when we do see it, it causes a significant maternal mortality burden. Up to 23% of maternal deaths in the US are related to sepsis. The unfortunate aspect, as some of my colleagues alluded to in the prior discussions, is that a vast majority of these are probably preventable. And obviously that's why we're here to talk about it today. And for every one sepsis-related death, maybe as many as 50 other women have significant morbidity related to sepsis as well. How do we define it for our maternal patients? Well, it remains the same, essentially. There's no need to overcomplicate things and make a special definition for pregnant patients who may be septic. And the challenge in pregnancy, as well as in the immediate postpartum period, is that there can be a significant overlap, as we all know, in the physiology of pregnancy with some of the common early warning signs we see in other patients presenting for sepsis. So baseline tachycardia, relative hypotension, and a lot of times we will see patients present with pregnancy common complaints that can mimic some of the initial complaints that patients who have sepsis may present with as well: urinary tract infection symptoms, respiratory symptoms, either viral with COVID. We've had obviously a tremendous amount of that here in the United States, and I know you guys have had a tremendous amount there as well. But even more vague symptoms such as just fatigue or rashes that we see in pregnancy can also be presenting signs and symptoms for sepsis. So it can be difficult to discern which is which in some of these patients. Is the causes of maternal sepsis necessarily different, however? And this is from our review article in the Green Journal, which came out last year. And this looks at the most common causes for maternal sepsis. So genitourinary, as my colleague just alluded to in the last talk, intrauterine infection falling within that is the vast majority, but also respiratory. And that has increased and will continue to increase as COVID unfortunately persists. GI and other soft tissue infections are roughly 17%. And then we have kind of this grab all category, unfortunately, of unknown, where a patient will present with some sort of sepsis, and we're not quite certain what the etiology is, even if we do get a definitive diagnosis from blood cultures. We're not always sure where that came from. Some of the risk factors that are important to be mindful of, and some of these we have a tremendous amount in the United States. The burdens of some of these risk factors may be different in other areas, and may be different in India. Obesity, we certainly have a significant problem with the United States. A lot of our patients, about 30 to 40% present with obesity, and that obviously is a significant risk factor. Immunosuppressant therapy or compromised immunity in general, anemia, and some of these, other history of pelvic infection, history of other infections, including Group B and Group A strep, older maternal age over age 35. In the United States, we have significant healthcare disparities with our socioeconomic statuses for a lot of our patients, and that's a risk factor as well, and then other chronic diseases. And as alluded to, cesarean delivery, as we all know, increases the risk for infection, as well as prolonged rupture membranes, retained products, any sort of thing that can be a nidus for infection, including cerclage or diagnostic procedures like amniocentesis or wound and hematoma repairs can be a source in ongoing maternal sepsis. This is looking at the worldwide burden over the course of approximately 30 years. And the one thing we can glean from this quickly is that the burden seems to be decreasing significantly. And this seems to correlate well with greater access to care and greater standardization of care. So this is a win for us as we take care of sick moms, but we still have progress to go. This demonstrates this just kind of on a color graph throughout the past few decades throughout the world. And we can see the relative levels of maternal sepsis and the burden of maternal infections leading to significant adverse outcomes. So how do we recognize it? The Society for Critical Care Medicine, which, like I said, is kind of the guiding body for assessment and treatment of sepsis, recommends rapid bedside evaluation, but they don't endorse one particular scoring system over another. And I think that actually gives us some leeway to work with things. So the common one we're probably all been familiar with for a long time, SIR, Systemic Inflammatory Response Syndrome. However, some newer ones, the SOFA, Sequential Organ Failure Assessment, or QSOFA, which is the short, quick version, or the National Early Warning System and the Modified Early Warning System, all of these do well. Some are more complex than others. This is from our review article in the Green Journal as well, looking at some more pregnancy-specific ones that have been utilized and put forward. Again, similar to the general cohort scoring tools, none of these necessarily perform significantly better than the other. So familiarity with a scoring system and ability to utilize it probably should be the guiding principles for which one a system or practitioner would want to employ. And this receiver operator curve kind of tells us that same story. This is from a different study looking at some other scoring systems, common ones we utilize in the ICU, the Apache scoring systems, as well as the SOFA scoring system. And we don't use these a lot clinically at the bedside, but from a research standpoint, we do. And none of them are really head and shoulders above any other. So going back to the initial statement, whichever I think is the most readily available for us is the one we should probably use to help us objectively assess who may be becoming septic. And in my personal practice, the one that I typically utilize most, even if I'm not consciously thinking of it, would be that QSOFA, since there's only 3 parameters, looking at the systolic blood pressure and seeing if it's lesser than or greater than 100 millimeters of mercury, looking at the respiratory rate on room air and whether that's greater than 22 breaths per minute, and looking at mental status for a Glasgow Coma scale of anything less than 15. 15 is completely awake, alert oriented, totally normal. So even something as simple as a patient not being able to tell us their name, what hospital they're in, day of the week, those sort of things would be a mark against them on a Glasgow Coma scale. And in young, healthy patients like our pregnant patients tend to be, that can actually be one of the most concerning signs is altered mental status if we don't have another reason for it. And as you see, as we get more derangement with more of these parameters, you certainly have an increase in the rate of adverse outcomes, including mortality. How do we assess the severity once we believe sepsis is present? That's a little bit less clear, and that's less clear in not only pregnancy, but in the ICU population in general. So there's not great evidence to say, once we have sepsis, how do we triage different levels of sepsis? We used to discuss severe and just straightforward sepsis, and we've kind of gotten away from that. Everything is now sepsis, and then we treat based on the level of organ injury and dysfunction, as well as ideally we would know what the patient's baseline is. That's a nice thing for us with our pregnant patients. A lot of times we've seen them for many months in the clinic and we know what their baseline is. We have some initial labs to compare to, hopefully. We can see if it's a significant derangement, if their renal function is the same or markedly worse, if their hepatic function is the same or markedly worse. And additionally, as an intensivist, I triage patients based on what interventions do I think they need and where can I provide those? And that helps me kind of, in my mind, decide what the severity of this illness is for them. Maternal sepsis presents a unique issue that not every hospital here in the United States, at least, does obstetrics. So if we have a sick mom who presents to an emergency department, they may not be able to handle the obstetric aspects of it. And they may not be as tuned in to look for the potential maternal causes of sepsis. So having the right resource allocation utilization becomes paramount, and that can sometimes be better or worse in some locales and other nations as well. Additionally, with bed availability, even if we're at a hospital that does have the right teams to assess that patient, they may not have the room to move that patient to the right unit. We've certainly experienced that with COVID in our hospitals here during the initial outbreak and throughout the various waves where we've had very limited bed availability in the ICUs. And that's made very challenging triage decisions, including for maternal critically ill patients. I would certainly stress early consultation with medicine teams or critical care teams, anesthesiology, whoever is the experts in critical care at the institution, And if there are no experts at an institution, reaching out to the nearest institution that has those experts to even discuss via phone the patient's care and what may be indicated, and if that patient needs to be transferred either within that institution or externally to another location. This is our algorithm that I borrowed from the Society for Maternal Fetal Medicine COVID guidelines that Dr. Vaught and I put together. And these are COVID specific. However, I think the bigger picture is it can help kind of triage in our minds who's sick and what do we need to do about that. So for COVID, we looked at specific measures instead of a patient, is not able to saturate well, if they're hypotensive, if they have any evidence of end organ dysfunction. If any of those things are true, on the right side of the algorithm, that was a trigger to consult the intensivist or the critical care expert at that hospital. If none of those things were true, then continuing further inpatient management with frequent reassessment was the plan. And then once the intensivist is involved at that early stage, then they can help determine where does that patient need to go and what sort of escalation of care may be indicated. So I would stress that as well. Don't be concerned about involving somebody too early. As an intensivist, we definitely want to know earlier rather than later who may be sick and what we may need to do for them. Going back to evaluating maternal sepsis, we return to these focusing on the most likely etiologies. We should definitely, a saying that we utilize commonly here is we should look for horses before we start looking for zebras. That's absolutely true. We should look for and treat the common causes. And then once we've eliminated those common causes, then we can escalate further evaluations as needed. I would also stress that any imaging is acceptable in pregnancy if you're trying to assess critical illness, potentially to save a mother and a fetus and neonate's life. The risk with things like CT scan are minimal and certainly much less risk than potential benefit if you're trying to find how you can help this potentially life-threatened patient. How do we treat that once we've determined that sepsis is present, that it's leading to critical illness? Then utilizing the surviving sepsis 3 guidelines is really a great place to start, both inside and outside of pregnancy. So again, using the Q-SOFA is what I would advocate because I think it's quick, simple, and you can do it at the bedside. You don't need any labs. But if you're not going to use the Q-SOFA score, that's fine. But having some screening tool that you can utilize, or at least some objective measures you can assess on each patient. Measuring a serum lactate level is very important. Normal is usually less than 2 or so, depending on the assay at different institutions. And then repeating that every 4 to 6 hours until it does normalize. Obtaining blood cultures of paramount importance, especially before you start administering antibiotics. If for some reason it's taking longer than an hour to get blood cultures, go ahead and start antibiotics. Getting the antibiotics on board is more important than getting blood cultures. But if you can get blood cultures before antibiotics are given intravenously, that's ideal. And it's a little bit different approach with sepsis than some of our other typical infections. We actually start very broad with our antibiotics, and then we narrow as we get further on in therapy, and we have a little bit more to guide us because we want to make sure we take care of all the potentially very bad infectious etiologies, and then we can dial it down as we get more clinical data and culture data to guide that. The rapid administration of 30 milliliters per kilogram crystalloid fluids for any hypotension or just resuscitation in general in someone who's septic is also extremely important. These crystalloid fluids, so lactated Ringer solution, normal saline, those are the most common ones we'll utilize. Some data has shown a survival benefit with lactated Ringers over the other crystalloid fluids, but I would say whatever is a crystalloid fluid at your institution would be the one you should utilize. If the patient has a mean arterial pressure less than 65, then applying vasopressors. And the first line in sepsis, both inside and outside of pregnancy, is norepinephrine. And then all of those things should all be done within that first hour of suspected sepsis, ideally. It's much more important to go ahead and do those things. And if it ends up not being sepsis, that's fine. You can stop those things. But it's much more important to do them rather than to wait and allow the infection to go unchecked. And then there's a concept of source control. So if a patient has an intrauterine infection, as my colleague just spoke about, then removing that intrauterine infection provides source control. If they have an infected appendix, removing the appendix provides source control. So being able to stop the infection or remove it as much as you can. I won't belabor these, but I think we're all very familiar with them. These are some common antibiotic regimens for various...
Excuse me, sir. Would you please wind up?
Yes, absolutely. Thank you. Like I said, these are some common antibiotic regimens we utilize. So this is in our review article in the Green Journal, if anybody's interested in looking at that. And this is just different vasopressors that we utilize in the ICU. Again, norepinephrine, Levofed being the brand name here in the United States, is the first line in sepsis, both maternal sepsis and sepsis outside of pregnancy as well. This is kind of the highlight of this to help assess sepsis, evaluate sepsis, and then begin treatment expeditiously. And certainly thank you all for your time and attention, and please feel free to reach out to me via email. I'm happy to answer any questions, talk to anybody. I'm happy to answer any questions now.
Any questions from the audience? Okay. Thank you, sir. That was a really crisp talk, and thank you for that, for covering the whole of maternal sepsis. And with this, I would like to invite our next speaker.
Our next speaker for the morning is Dr. Gita Balsarkar. May I have Dr. Gita Balsarkar on stage, please? Yes, Dr. Gita Balsarkar. Dr. Gita Balsarkar is Editor-in-Chief of Journal of ONG of India and President Menopause Society Mumbai Branch 2021. She is Professor St. G.S. Medical College and New Jersey Wadia Maternity Hospital. Welcome, ma'am, for this prestigious oration.
ओके चलिए या इसको इसमें डालो ना फुल स्लाइड करो ना फुल स्क्रीन करो.
She'll be speaking on a very pertinent topic, management of septic shock.
Okay. Thank you. At the outset, I must thank Dr. Alpesh Gandhi and Dr. Neeta Thakre and team for giving me this, Dr. Sunil, for giving me this opportunity to speak on this very, very important topic in front of you. And I'm really humbled to speak in Dr. Praful Munshi and Dr. Sanat Joshi Hall. We at Foxy really acknowledge their contribution in the field of obstetrics and gynecology. And after hearing the basics of maternal sepsis and how do we prevent it, prevention is a key. First, how do we prevent it? Early diagnosis, we come here to the management of septic shock. Unfortunately, this patient is already in the next stage and needs the next level of treatment, but let's see what we can do for this septic shock. So to introduce, sepsis remains one of the 4 main causes of maternal mortality. The common causes of severe sepsis and septic shock during pregnancy, we have already seen in the previous speaker slides. They include pyelonephritis, infection during labor and puerperium, and now in this present scenario, the respiratory infections. The Surviving Sepsis campaign is a global effort to improve the care of patients with sepsis and septic shock. This was first published in 2004. What we need is a multidisciplinary approach to treatment of sepsis based on 2 phases: the resuscitation phase and the management phase. We are going to discuss mainly about the management phase here. In a critically ill pregnant woman, birth of the baby also may be considered if it would be beneficial to the mother or the baby or both. So sometimes for the proper resuscitation of the mother, you may need to deliver the baby, or if the baby needs delivery immediately, even then we may need to deliver the baby. So a little bit of definitions, most of which has already been covered in the previous speaker, like what is sepsis? Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. We do not exactly know why only some patients progress and go into septic shock and why some don't go into septic shock even with the same amount of infection. We do not really know as of today. So the main important thing here is in identifying the organ dysfunction. dysfunction. When this patient moves from sepsis to becoming a organ dysfunction. Organ dysfunction can be identified as a change in the SOFA score. The SOFA is a sequential organ failure assessment, and at least 2 points consequent to the infection. Once you have diagnosed the infection, or even if you have suspected the infection, if there is further progress or 2-point increase in the SOFA score, then we need to remember that this patient is going towards a septic shock. Multi-organ dysfunction syndrome is a further progress of this, and the presence of altered function of 2 or more organs in an acutely ill patient, such that homeostasis cannot be maintained without intervention. So when you have 1 organ failure, then you have 2 organ failures, and then what you have is a systemic inflammatory response syndrome, a septic shock, which is sepsis-induced hypotension persisting despite adequate fluid resuscitation. You're going on giving fluids and you feel that this should be enough for the patient, but somehow the hypotension is not getting corrected. This is the time to suspect, oh, this patient has gone from sepsis to septic shock. So we need to remember in the management that the 1 hour, 1 bundle should be initiated within the first hour of recognition of sepsis. This is very, very important to prevent this patient progressing from sepsis to septic shock. The hour 1 bundle is very important. Then the surviving sepsis campaign care bundle say that within 3 hours of presentation, in our country sometimes it may not be possible within 1 hour to send serum lactate levels and get the reports. So we have to measure serum lactate levels, obtain blood culture prior to administration of antibiotics. This definitely we can do, and administer broad spectrum antibiotics. This we all definitely do, and administer 30 ml per kg crystalloid for hypotension, or if lactate is more than 4 millimoles per liter. So as obstetricians, we are not very, sort of confident of doing lactate, but remember, time has come where we need to be acquainted with this also. So whenever you suspect sepsis in any patient, within 3 hours you have to have a lactate level, obtain blood culture prior to administration of antibiotics, give the patient immediately broad spectrum antibiotics, and start IV fluids. Administer 30 ml of crystalloids for the hypotension, or if lactate is more than 4 millimoles per liter. And then what do you do within the next level? That is a 6 hours of presentation. The patient may need vasopressors for hypertension if that doesn't seem to be responding to your initial fluid resuscitation. And we need to maintain a mean arterial pressure of more than 65 millimeters of mercury, as well as urine output. You have to maintain at least 30 ml per hour. In the event of persistent hypertension, if in spite of your fluid resuscitation and your vasopressors, if there is persistent hypertension, or if the initial lactate level is more than 4 millimoles per liter, then we have to reassess the volume status and the perfusion, tissue perfusion, and we have to document the findings and contemplate re-evaluating the lactate levels, re-measure the lactate levels if it is elevated. So coming to the clinical and lab diagnosis of sepsis, there will be fever or temperature instability, tachycardia more than 110 beats per minute, tachypnea, diaphoresis, clammy, mottled skin, cold skin, nausea, vomiting, hypotension or shock, and oliguria or anuria, pain. It could be even locally on the uterine side, or foul-smelling vaginal discharge, and altered mental state, that is confusion or altered alertness. Now, lab findings is positive culture from the infection side. Within 24 hours, you should be able to get the primary smear report. So, if the positive culture it shows from the infection site or the blood, then hypoxemia, thrombocytopenia, metabolic acidosis, increased serum lactate, low arterial pH, increased base deficit, all these you know that your patient is progressing from sepsis to septic shock. Serum creatinine elevated, creatinine is elevated, elevated liver enzymes, hyperglycemia in the absence of diabetes. This is a sure shot indication that your patient is progressing into septic shock, and then of course your disseminated intravascular coagulation. So what is the definition of systemic inflammatory response in pregnancy? Temperature more than 38 or less than 36 degrees centigrade measured on 2 occasions at least 4 hours apart, heart rate more than 100 beats per minute, but mostly it's more than 110 beats per minute, respiratory rate more than 20 per minute, and white cell count more than 17,000 with more than 10% of immature band forms. So on 2 reports you should have a WBC count, total count of more than 17,000 with immature band forms more than 10% of that. So coming to the initial management of sepsis, within 1 hour we have already seen all this. We have to obtain the blood cultures and serum lactate, administer broad spectrum antibiotics and initiate fluid therapy 30 ml per kg of crystalloid initially to maintain the mean arterial pressure more than 65 millimeters of mercury. If the next stage the patient is not responding to this fluid, then we have to start norepinephrine through central line and then try to maintain the mean arterial pressure at more than 65 millimeters of mercury. We could contemplate starting low dose steroids, but of course that is not the initial line. Then we have to achieve early source control. This is very, very important. It may include during a cesarean section, during a check curettage, removing the placental bits, whatever is the source of infection. Source control is very, very important. As soon as you have started your antibiotics, sent your lactate and your bloods and started the resuscitation, we have to consider electronic fetal monitoring up to 24 weeks and steroids for fetal lung maturity. And we have to consider, once the patient has delivered and the situation is slightly under control, early enteral feeding, initiate DVT prophylaxis. These patients are more prone to DVT, so we have to consider DVT prophylaxis and avoid hyperglycemia above 180 milligrams per DL. So the Surviving Sepsis campaign is a global effort to improve the care of patients with sepsis and septic shock. This was first initiated in 2004. It's a multidisciplinary approach, the resuscitation phase and the management phase. So early screening and management is the most important thing. Actually, it has to be talked much more than even management of septic shock, because screening and management of infection is the most important thing. Screening for organ dysfunction and management of sepsis, and identification and the management of the initial hypertension that these patients normally present with. So among the early screening, the first step is identification of the infection according to the signs and symptoms. If there is foul smelling discharge, if there are urinary symptoms, or if there are lung complaints, then we have to identify the source of infection. Once patient is identified, cultures and blood samples is obtained and followed by administering appropriate antibiotics. Remember, septic shock is a medical emergency. You do not have much time. Most obstetricians realize it, but the problem is our patients are very young, and we have to sensitize the intensivist that these patients need immediate attention. Though most of the times there are more sick patients in ICU who apparently look sick. Our patient may not look that sick because your signs and symptoms may not correlate. But remember, our patient need more attention than most other patients. We have to sensitize our medical emergencies. 18 minutes, madam. Yeah, कितना हुआ time?
Another 2 minutes, please.
2 minutes, okay. So the initial we have already seen, and remember we also have to look at the oxygen saturation or a mixed venous oxygen, and we have seen what task we need to perform within 24 hours, administer low dose steroids as per hospital policy, and you have to measure the glucose. Antimicrobial choices and considerations, I won't go much into detail, it's already been covered by the previous speaker. Fluid therapy is very, very important when we are talking about shock. There is a controversial role of corticosteroids. It is it's subject to patient, and some say it can be given, but it should be reserved for septic patients with refractory shock, those who remain hypotensive following initial fluid resuscitation, even after administration of vasopressors. Corticosteroids should be given within the first 7 days and interrupted as soon as patient shows signs of improvement. Otherwise, the infection can further increase. Another benefit of corticosteroids in pregnant women, I don't need to tell this audience, we all know how it improves the fetal lung maturity. Remember, prevention of DVT is very, very essential in septic pregnant patients, as both pregnancy and sepsis are associated with hypercoagulability. Therefore, we have to use compression stockings, intermittent lower limb compression, and the low molecular weight or unfractionated heparin. Vasoactive drugs like norepinephrine, dobutamine, we have to start these with the help of the intensivist, and then there is some role of intravenous immunoglobulin in very severe infection like streptococcal or the staphylococcal infection, and even high dose immunoglobulin has been used in pregnant women as it's effective in exotoxic shock which is caused by streptococci and staphylococci. Now there is this MUOS chart which is available on the WHO website which can score your sepsis depending on the symptoms of this particular patient, and these are all available. The cascade is the MEOS 1, 2, 3, 4 and 6, like how to go about it. It is there on the WHO website. This is a call out cascade when you should involve the other consultants because it is a multidisciplinary. And what are the indications to transfer for ICU? If there is hypotension, if there is pulmonary edema, if patient needs mechanical ventilation, if there needs airway protection, renal dialysis, multi-organ failure, unconscious patients, uncorrected acidosis and hypothermia all need transfer to ICU. Delivery decision, it depends on the patient, and we have to take the decision depending on the mother's condition as well as the baby's condition. And the potential indicators for delivery are either the mother or the fetal causes, so we have to take a decision to deliver this patient. And remember, newborn complications also occur from maternal sepsis. So we have to keep this in mind and involve the neonatologist as well very early in the management of this patient to prevent neonatal sepsis, pneumonia, respiratory distress and long-term neurologic impairment in the fetus. A little bit about anesthesia for delivery. Of course, it depends on the patient, but we should consider multidisciplinary team, obstetrician, neonatologist, microbiologist, intensivist and anesthetist. If surgical intervention is mandatory, the anesthetist has to make the decision whether it is better to give regional or general anesthesia. Of course, regional anesthesia can be given, but you have to remember there can be coagulopathy or thrombocytopenia, the risk of epidural abscess or meningitis. Is small in patient treated with antibiotics, but it should be considered in these cases. General anesthesia is highly likely to be required in a septic patient. With all the monitoring, these patients have to be given general anesthesia. The decision to extubate or to transfer the patient intubated to critical care is judged by the severity of the sepsis and the altered physiology. After operation, oxygen is recommended to meet the increased demand, and analgesia should be maintained. Non-steroidal anti-inflammatory drugs are contraindicated. The normal painkillers that we give following our surgical intervention, they are contraindicated in septic patient because they have deranged renal function and coagulation profile. So post-operative care and transfer to critical care is very, very important because they are hemodynamically unstable. They may need vasopressor support, mechanical ventilation. They may be altered consciousness, so they may need hemodialysis, multiple organ failure or hypothermia. Even extracorporeal membrane oxygenation has been used in refractory sepsis during pregnancy and puerperium. So the WHO in 2018 announced that the global mortality rate shown in many studies is around 55% and 60% in case of septic shock. Therefore, we could lose every alternate patient if we don't stop these patients from progressing into shock. So, this is a new study which was published in 27th April 2020. It is called GLOSS, Global Maternal Sepsis Study. It's a WHO HRP initiative and shows that infection has a larger impact on global maternal mortality and morbidity than what we thought previously. So the results from GLOSS are published in Lancet, and they said that frequency of maternal infections and sepsis across pregnancy and post-pregnancy period in a large number of health facilities around the world is large, much larger than what is actually reported. So there is a WHO and World Sepsis Day in 2017. WHO and HRP joined the Global Sepsis Alliance to hold the World Sepsis Congress Spotlight. So it's a free online congress shining light on those neglected cases of sepsis. So it was attracted more than 8,000 registrations of 152 countries. So we are having an entire conference on sepsis. So thank you very much for a patient hearing.
Thank you, ma'am, for that elaborative and exhaustive discussion on the topic. And it was really, really wonderful, and you have covered every pertinent topic. And this is every obstetrician's nightmare after PPH. And so we are really thankful that you have covered the topic very well. If you have any questions, we are ready to take them up from the audience. Yes.
I think incomplete abortion. And is there a role of he is having fear of
Madam, it has to be individualized. If your patient is very obese, if she is hypertensive and then she has had a abortion and she has retained products and she comes to you with signs of sepsis, then I think you will have to start. If it's a very thin, lean patient, not much of sepsis, has not presented with symptoms, you have done a routine check curettage and she has presented within 24 hours with bleeding, then I don't think it is needed. It depends. I mean, you have to individualize the patient, yes. But remember, but don't forget DVT. Or it's often that we as obstetricians, we forget the DVT prophylaxis. Actually, in COVID period, it has been highlighted in a very big way. Those COVID patients who are receiving low molecular weight heparin prior to delivery, we have to continue them after that. So we have to remember that DVT is a big risk factor in sepsis. If patient has sepsis and pregnancy, these two things are only enough to push the patient in DVT.
But won't that increase the chance of bleeding in case of such patient having incomplete abortion who is already having a risk
so if
of...
patient comes to you with bleeding, you treat the bleeding first and then you start her on heparin at a later stage.
She is in septic shock and then we are waiting for some antibiotic cover for few hours or 24, 48 hours.
So after the procedure you can consider or you can think about
so we can delay it.
Yeah, mildly you can delay it, yeah, no problem. But then you have to decide what amount of sepsis is there and how bad is the patient and how bad she needs the DVT prophylaxis.
Okay, thank you.
Thank you, Madam Gita ji. And now we will proceed for the next topic. That will be by Dr. Ravichandran J. That sepsis, we will not like to go for septic shock as far as possible, but we, in the era of even 21st century, since 500 years, we have found the microorganisms, even though we are not able to combat with the sepsis. So we will like to prevent maternal death, and the topic is maternal death due to sepsis. A Malaysian experience we are going to have from Dr. Ravichandran J. Welcome, Dr. Ravichandran.
Yes, very good morning.
And
Thank you very much.
Sir, excuse me, you will like to introduce yourself.
All right, okay. I see some friends there on the podium. That's nice. My name is Dr. Ravi. I am a obstetrician.
Sir, you're not audible. So can you
hear
just...
me?
Little louder.
Louder.
Okay. Right, can you hear me now? Is it better?
It's a little better, but it's still very soft.
Yeah, because
You
it's
need to
raining.
sort of come closer to your computer.
Okay, I am very close now. Now, the thing is, it's raining very heavily here, so the internet may not be, connectivity may not be the best. Okay, I apologize for that. Okay, I'm an obstetrician gynecologist. I'm a maternal fetal medicine specialist, and I chaired the confidential inquiry into maternal deaths of Malaysia for the last 11 years. And I am the former head of maternal fetal medicine as well as National Obstetric Services of Malaysia for the Ministry of Health. All right.
Thank you, sir. You may please start sharing your screen.
Yeah, I am. 1 minute, yeah. Can you see the slides? Can you see the slides?
Yes. Yeah, we do.
All right, okay, good. Okay, I've been given 18 minutes plus 2, I think, so I'll just rush through, okay? Now, the topic that I was given was actually talk on sepsis. So I thought what we'll do is we'll share the data that we have got from a confidential inquiry into maternal death and focus on the issue of sepsis. This is where I work, a Red Hospital, just south of Malaysia. Now, these are some of the vital statistics we have. We have about 500,000 deliveries a year, very much less compared to what you have in India. And these are our statistics. And this is 23.5 is our maternal mortality ratio. In fact, last year it was 22.5. So we are hovering around the 20s. We have not been able to go below the 20s. And if you look at some of our statistics, we are not doing too bad in terms of perinatal, neonatal, and the under 5 mortality. We are faring quite well. Now, basically maternal death, we know the definition that we all are used to as of FIGO is 42 days of termination of a pregnancy. It is basically divided into direct, indirect, and fortuitous. Now, the way we calculate maternity mortality ratio is the number of maternal deaths as the numerator and the denominator is live births for the same year. And for calculation of maternal mortality ratio, we only include direct and indirect, and we do not include fortuitous. And you must understand MMR is not a maternal mortality rate, but rather a maternal mortality ratio. If you look into Malaysia, we have been doing fairly well, and you can see our rates have been coming down. 2017, we were 25, we have come down to 22. So in 2019, so let's hope we continue to progress. Now, if you look into this, you will find that we have fortuitous death there, and direct deaths are still contributing a significant amount of our deaths. So we used to wonder, was it the traditional causes like postpartum hemorrhage, etc., or something new? And if you look in terms of the ethnic distribution, you find that the Chinese patients are doing extremely well, whereas the Malays and the Indians seem still to be hovering around large numbers. So we need to look into why this is happening. And if you look in terms of place of delivery, obviously the home delivery seems to have a higher incidence of maternal death. And if you look in terms of citizen and non-citizens, you will find that the non-citizens, okay, contribute a significant amount of our deaths as well because they don't access our healthcare as they should. Now, if you look into the stage of pregnancy, you will find the majority of the deaths are occurring in the postnatal period. And now this is interesting. What you need to look at here, you will find that the traditional causes of postpartum hemorrhage as well as hypertension seems to be coming under control. But we have this yellow bar here, which is actually maternal or rather medical conditions. And when we look at the medical conditions, there were two significant causes of maternal death. One was heart disease in pregnancy, and the other was sepsis. Now, we had dealt with heart disease in one of our earlier meetings, so we were looking at sepsis. Now, when we look at the whole quantum of maternal death, we find that almost 70% of them are preventable. That means there's something we can do to prevent these mothers from dying. And when we looked into gross factors, we found that the patient factor and the clinical factors were the prime contributors. Now, this was just the tip of the iceberg. And when we looked into sepsis, this were my trainees who actually helped in the analysis of the studies. You will find over the 2015 to 2019, you'll find the numbers are hovering of the total death. You see the number of maternal death due to sepsis is hovering around the same, about 25, 28, 29. So what is it that we are missing? And if you look into the specific MMR ratio of sepsis causing death, direct as well as indirect, you will find that the direct cause of sepsis of maternal death is actually quite low compared to the indirect. And if you look into the antenatal and postnatal sepsis, you will find the number of sepsis that as shown, and you'll find that the age, as what one of the earlier speakers alluded to, it is actually in the younger population, within the 25 to the 34 age group. Now, the timing of the diagnosis is about the same. We diagnose it as an antenatal and postnatal, but you will find that death can occur in the antenatal and in the postnatal, and you see predominantly is occurring in the postnatal. Now, the place of death obviously is in the state hospital because many of them, the moment they are diagnosed with sepsis, they are referred to the tertiary center. Now, this is by states in Malaysia, and you find Sabah and Selangor and Johor. These are the three states which have the largest population in terms of immigrants as well in terms of delivery rates. So this is where the highest sepsis-related deaths are occurring. Now, if you look in terms of citizenship, why we do this is because most of the illegal non-citizens don't access to healthcare because they're afraid they'll get caught and deported. But despite that, you find that citizens still contribute a significant amount. Now, if you look into the classification of maternal deaths due to sepsis, you find the majority of them are actually non-pregnancy related. So we need to find out what is this non-pregnancy related maternal deaths. And you find the pregnancy related is only about 17%. And the comorbids, you'll be surprised. We always thought that comorbid patient, the most amount of COVID, the one who succumb to sepsis, but no, almost 42% of them who succumbed to sepsis in pregnancy was with no comorbids. And when we looked at it, or the comorbids that we know, diabetes, obesity, and anemia seems to be the commonest. And in the site of infection, what we found strange was the majority of the infections in which the mothers died, the primary source was from the respiratory tract. And if you look at it, if you find pelvic areas, and the genital tract is number 2. So you find that we seem to see more of sepsis due to the respiratory tract. And the organisms, of course, the majority, as we expect, is bacteria. Of course, with COVID now, the deaths would increase because as of March 2020 to October 2021, we have had 260 maternal deaths due to COVID alone. So if you find the microbial distribution, you will find the majority of them, we were able to identify a single microorganism with 27%, about a quarter of them having polymicrobial presence. Now, and strangely again, what we found was that the commonest organism that caused maternal death was actually Mycobacterium tuberculosis. And the ones that are related to the pelvic tract and the genital tract, E. coli, was actually far behind. And polymicrobial, what we found was Streptococcus, yeah? And when we looked into the respiratory part of it, we found that 37% of them had a single organism and 34 polymicrobial. Okay? So it was interesting to find that this was a finding. And we were able, and the majority of them were bacterial in origin. And again, when we looked into the respiratory part of it, again, the number 1 killer was tuberculosis, followed by influenza. So when we look into the maternal deaths of TB, influenza, and dengue, we found that TB contributed the most. And out of the TB related deaths, 78% were pulmonary TB, 11% were extrapulmonary, and another 11% were about miliary TB. So you can see that TB, although we consider Malaysia to be a relatively developed country, nevertheless, TB is still causing hell of a problems for us. And the timing of diagnosis for tuberculosis, the majority of them were diagnosed postnatally, and almost all the mothers died in the postnatal period. Okay, and if you look at it, you will find that the majority of them who had tuberculosis was actually non-citizens. As I told you, they shun away from healthcare, they come to us late. And if you look into the citizens, of 40%, and you'll find that the majority of them who succumbed to tuberculosis did not have any antenatal care at all. These are all government facilities, the one in green and the one in yellow. Orange is a private facility, and this is government specialist hospitals. So you find that the majority of them died where they had no antenatal care at all. If you look at influenza 1, you find again the majority of them were diagnosed in the antenatal, but again, we lost them all in the postnatal period. And again, you will find that the majority of these people actually had healthcare, and in fact, it was picked up in government clinics and then transferred to a tertiary center, but the majority of them deteriorate very, very fast. If you look in dengue, again, the majority of it, all of it was picked up in the antenatal period, and all of them died in the postnatal period. And the majority of them had complications with hemorrhage, especially at the time of delivery and the immediately postnatal period. Again, if you find dengue, it seems to be more of a disease of the citizens, because if you know that dengue is more of a disease in the urban area and there are more citizens there. And then we find that almost all these patients who died of dengue did have access to antenatal health care. So we also looked at what was the highest level of care that these patients received once we had diagnosed them as sepsis in pregnancy. Almost 3/4 of them, or 78%, received ICU care. 3% had HDU. 17% were not available because these people were brought in dead or they died as the accident emergency. And you'll find that the moment we have diagnosed them to have sepsis, the majority of them had escalated care. And again, in terms of citizenship, you will see that 72% of the ICU care was provided for citizens as well as for non-citizens. And you'll find that even the non-citizens who were illegal, okay, the majority of the patients who died without having hospital care were the illegals. So this is very important to know that this is a sector of patients that we have to focus our attention on because they shun away from our facilities. And again, the place of death, the majority of them, of the non-admitted cases died at home. Again, this is in the illegal immigrant population, and some were just brought into emergency because they were really very moribund and they died at the accident emergency unit, and 17% were actually brought in dead. Now, the highest level of care that the septic patients looked after were by 82% of them received consultant or specialist level care. That means there was hardly any compromise in the level of care. And combined care, now this is something that we are looking at it very seriously, because we found only 8% of them had combined care, 40% of them had only pure ONG care, and 51% had one other discipline. And majority of this other discipline was actually the general physician. The general physician came on board to help us in looking after these septic patients. And we say combined care, this would involve the anesthetists, the intensivists, the cardiologists, and the ID physician. Now, what did we find the contributing factor for sepsis? We found patient factor was one, because they came late. The majority of that, we couldn't find a reason as to why. That means there's a lot of work for us to do. Clinical, yes, we found clinical factors. That means these patients developed infections due to underlying conditions, due to problems they encountered during the delivery or getting infected in the antenatal period. Again, you will find the majority of them was in the illegal population. The neonatal outcomes, almost 3/4 of them we were able to save the babies, but 26 of them we lost the babies. Yeah. Now, what is the summary of our assessment of sepsis? We found that 26% of genital tract infections were associated with obstetric interventions, such as cesarean sections and instrumental delivery. That means of the genital tract infections that caused maternal death, 1/4 of them was due to the obstetric interventions. Now, a single case of pelvic abscess caused maternal death, and this was due to a previous cesarean section, and she came in at day 32 with pelvic abscess and succumbed. And 75% of the maternal deaths due to sepsis were in the lower socio-economic group. And in Malaysia, we find that sepsis-related death is about 10%. In the high-income countries, it's about 8%. So we are hovering somewhere there. And the WHO estimate is about 11%. So we are almost on the same page. Stillbirths following sepsis in Malaysia, sepsis-related maternal death is 26%. So if in the high-income countries, about 10 to 25, low middle income is about 50%. So we are hovering somewhere around the global obstetric sepsis rate. So what did our review findings actually tell us? We found that 42% of the patients who died did not have comorbids. Patients had a more severe infection evident by the higher ICU admissions. Only 17 of the 98 cases that were admitted to the state hospital were co-managed by the ID physician. We seem to have not got the ID physician involved, or we did not have enough ID physicians. 75% of the patients with alert organism did not have an ID. That means these are organisms who developed resistance. We did not have ID input. And 70% of mortality cases did not have any home visit. This is to say that we have a home visit program for for our mothers postnatally. There are 5 home visits within the 6 weeks of the puerperium, and 75% of the mothers who died did not have this home visit. So we are now looking into embarking and strengthening that. So what were our concerns? Our concerns were, in the postnatal period, our colleagues in the head side may not have been able to cope and provide care as expected. We need to involve the ID team, maybe earlier on in our management. We had delays in obtaining the culture results. Sometimes the culture results came only after the mother had died. The lack of ID physician has been telling. And we feel that now, just like how we triage antenatal mothers and risk score them for their antenatal care, we have come up with a triaging system for postnatal mothers who will be triaged at the point of discharge as to their level of care and the risk status of this. Okay. And the other thing we found out was that somehow or other, we were not so sensitive to pick up and detect early signs of sepsis. And then we end up doing too much, too late. Now, tuberculosis was the surprise culprit. We found that 13% of our mothers died because of TB. And again, as I told you, respiratory system was the commonest site. 50% of those who died of TB were non-citizens, reflecting that these people did not access care, because tuberculosis treatment in Malaysia is absolutely free, whether you're a citizen or a non-citizen or an illegal. And 45% had no antenatal care. And of those who died, 50% of those who actually accessed antenatal care, we managed to pick up the diagnosis. Now, what is that sometimes sepsis is looking at us. but we are not sensitive enough to see that it is actually lurking there, and we have just not tuned ourselves to pick it up. We need to become more sensitive. So what we thought of the recommendation that we have come after assessing these cases was, we have to educate the patients as well as the families on the early signs and symptoms of sepsis, so that care can be sought as early as possible, and raising awareness against the healthcare providers as to the signs and symptoms of sepsis, and not just at something else and letting them go, and then they only come back when they are really moribund. On the health side, again, as I told you earlier, we are coming up with a system of postpartum color coding, so that now the patient who at delivery, she will have a color coding to risk assess and to make sure that the healthcare looks after these patients appropriately, like just how we are doing in the antenatal care. And of course, optimizing and tailoring home visit that is provided free of charge to the postnatal mother. And in the hospital care, again, as mentioned earlier, our QSOFA scoring is done, and we are trying to make this more available and having training programs in place, which of course COVID has come and disrupted gloriously. Of course, we have our early warning system monitoring that we are emphasizing on. And of course, as all the other speakers have mentioned, we need to have a multidisciplinary approach and early involvement of the ID physician. Okay, so there's a need for screening, diagnosis, and imaging if required. And as we heard earlier, if imaging is required, then saving the mother is paramount. So we will proceed with the imaging. Combined management is there, and now we are in the process of coming up with the CPG on management of tuberculosis in pregnancy, so that we can address these patients with tuberculosis in pregnancy in a much more clear way. Okay, so the conclusion is, from what we found out was, sepsis is a preventable cause. Investigations are available, treatments are available, facilities are available, expertise is available. But what is it that we are missing? I think this is something that we all have to think, sit back and grapple with it. And maybe by the next conference, we'll have more answers looking at this. And we have to be very sensitive and look at the problem properly, because more often than not, the answer is staring at us and we're just not able to appreciate it. And we have to work as a team to save our mothers. Thank you very much.
Thank you, sir. That was really, really great. You have obtained the stillbirth rate very close to the WHO one, though you have maternal deaths, and most of your deaths are in women in the low socioeconomic group, that is 75%. So
Yes.
I think poverty itself is a cause of maternal death, and that needs to be addressed,
Yes.
which is not something that we are going to be able to address.
But
But
the sad thing
there has to be a political will about it. And the other thing is your illegal immigrants.
Yes.
47% who are illegal immigrants, and they are losing their lives.
Yes.
So, something has to be done. Either don't allow them to come in at all, or give them a legal status. Either way, because for us obstetricians and gynecologists, a woman is just a woman, and we don't really want her to die.
Right.
And you've done a really honest job, sir. We congratulate you on this.
True.
And any questions from the
I
audience?
have a comment to make, sir. Thank you, Ravi, sir. It was really pleasant to hear you after so long. Maybe 2 to 3 years back, we had heard you. Because of this COVID pandemic, there was a long hibernation. And sir, one just comment that I would like to make is that you very beautifully summarized that no woman should die because of childbirth, and that is really very pertinent. And in your chart, we could see a lot of maternal deaths due to amniotic fluid embolism.
Yes.
Is there any particular cause in your country? Because in our country, we see very less amniotic fluid embolisms.
What we actually, we have put it together as obstetric embolism. And I
Actually,
think
both embolisms, pulmonary embolism and amniotic, were
yes.
very high in your list.
very high, yes. And I think one of the reasons why it appears high compared to our previous is that now we are actually able to diagnose it. You see, because of the imaging modalities that we have. Those days, if we did not confirm an obstetric embolism death, chances are we'll put it as an obstetric death but unknown. But now we can actually put a label to it as embolism, and hence the number numbers seem to be increasing. So in view of that, we have actually come up with our own thromboprophylaxis treatment, that is to look at pulmonary embolism and things like that. And we have also come up with guidelines on managing amniotic fluid embolism. And I must say that with those guidelines in place, we have managed to save quite a few mothers who have actually had amniotic fluid embolisms. I will present this in some other conference in the next time, because we are just collating the data now, and we can share that view with you maybe in a couple of months.
So exactly what imaging are you doing for that?
Oh, we do CTPA, where we actually do a CT of the entire pulmonary trunk with contrast, and we can actually pinpoint where the embolus is. And sometimes we have got our cardiothoracic colleagues to come in and do actually an embolectomy, and we have saved the patients. And once we know the embolum is there, we actually go very aggressively and treat them. And we have managed to save some, and we have also lost some.
Dr. Alpesh sir is here.
Yo.
So, sir, your comments,
Nice.
please.
Dr. Ravi, thank you very much. Good morning from India.
Good
You are
afternoon from
nearly
India.
a permanent speaker, faculty in all our critical care in obstetric conference. And thank you very much for joining from Malaysia and sharing your experience and study. Thank you.
Thank you very much, Dr. Alpesh. Hope to see you soon, and all of you all as well. Thank you.
Are you coming at Indore?
Bye-bye.
Hello.
Yes,
Are you coming at Indore for AICOG?
I'm trying to. I'm waiting for the government to give me permission to travel. Because we have a huge quarantine problem here, Dr. Alpesh, on our return.
Okay, okay.
Yeah.
If you are coming, we will meet there. Eager to meet you there. See you
Yes,
there.
hopefully I'll see you in Indo.
Yeah, thank you.
Take care.
I will like to hand over your memento at Indore.
Sure, will do.
Personally, physically.
Thank you, Dr. Alpesh. Take care.
Thank you.
That was a very well coordinated session. Thank you, coordinators, and thank you all the participants. Of course.
Thank you, Dr. Alpesh and ICCOB organizers for giving us an opportunity to be with you today. We can have the speakers also. Speakers also, whosoever is here.
The speakers of this session, please.
Yes, the previous section can also come.
Yeah. All are welcome.
Can I tell you one short story? Photo limit in Hey, come, Gita.
Sorry, sir.
That's true. मैडम ने एक स्टोरी बोला, his son, her son, is 4 people have found some company. They had some problem. They both started fighting among themselves. So Sarya madam thought कि वो USA वाले स्पीकर में लेट जाएंगे. So they started fighting and then.
Moving ahead with the next session. Here again we deal with another dilemma of obstetrics, the thrombophilias and the embolic phenomena. For this, we have the chairpersons, Dr. Sangeeta Arya. Madam has come all the way from Kanpur to be with us. She's a very active member of the Motherhood Committee of FOGSI, and yesterday we saw her in action. She is going all over India training the paramedics in the management of PPH, doing phenomenal work under guidance of Preeti Madam and Alpesh Sir. Welcome, Madam. Dr. Rajat Mohanty. Is Sir with us? Welcome, Sir. He's the National Coordinator of Endometriosis Committee of FOGSI. He's also the East Zone Coordinator of Perinatology Committee FOGSI, Chairperson of Midlife Management Committee, Executive Board member of various committees, and a very active member of our organization. Handing over the session to you.
Good morning, everybody. I welcome you all to this next session. First of all, I express my gratitude to Dr. Alpesh Gandhi and his team for inviting us to this intellectual gathering and his excellent hospitality and management of this International Critical Care Conference. Today, in this session, AICC and RCOG session, the topic is thrombophilia and embolic phenomenon, the dilemma. First speaker is Dr. Uma Ram. She speaks on DIC, how to make early diagnosis and how to manage. Dr. Uma. Dr. Uma is the Director and Consultant of Obstetrics Gynae, Sithapati Clinic and Hospital, Chennai, Chairperson South Zone AICC RCOG, Treasurer ATN RCOG, Advisory Member of OGSSI. I welcome to Dr. Ram.
Thank you very much, sir. Thank you to Dr. Alpesh Gandhi and the organizers for this invitation and for an AICC RCOG session as well. The task in front of me is to handle quite a difficult problem in obstetrics, which is DIC, with a focus on how to make an early diagnosis and how to manage. And I'd like to begin with two clinical scenarios. The first is a 28-year-old primary who presented with abdominal pain and minimal bleeding. Her primary OB was away, so she had gone to that hospital and then came referred. When she came in, her heart rate was 100 per minute, blood pressure was 130/90, oxygen saturation was normal, uterus was contracting every 2 to 3 minutes, fetal heart tones were absent, abruption was diagnosed. Because she was clinically stable, labor was induced. There was no response to induction, and so she was taken up for a cesarean section. There was a large retroplacental clot, She developed then atonic PPH, which responded to PGF2 alpha. Her hemoglobin was 7.2, platelet count was 48,000, coagulation profile was normal. The other scenario was a gravida 2 para 1 live 1 with an IVF conception, twin gestation, who was COVID positive for the past 3 days, admitted with decreased fetal movements at 30 weeks of gestation. She was steroided and given low molecular weight heparin. Her hemoglobin was 8.4, platelet count 75,000, APTT was prolonged, LAC negative, fibrinogen was 79. Hematological opinion was sought. She was given FFP and cryoprecipitate. Once she stabilized, she was taken up for a cesarean. Because her COVID status also started worsening. Intraoperative loss was 500 ml. 2 hours later, she developed PPH. Hemoglobin dropped to 5.6. Platelet count was 28,000. Fibrinogen was 78. She needed a fair amount of ITU care with more blood and blood products, but thankfully both she and the baby did well. So disseminated intravascular coagulation is the endpoint of an uncontrolled systemic activation of the hemostatic system. The International Society of Thrombosis and Hemostasis defines DIC as an acquired syndrome characterized by intravascular activation of coagulation with a loss of localization arising from different causes. It can originate from and cause damage to microvasculature, which if sufficiently severe can produce organ dysfunction. So the crux is that there is widespread microvascular thrombosis which compromises blood supply. In addition, there's activation of plasmin which results in organ failure. Additionally, because of depletion of platelets and coagulation factors, there is bleeding. And this is a leading cause of maternal mortality and morbidity equally in the Western as in our kind of populations. So it's a thrombohemorrhagic disorder in the core of which is thrombin, and thrombin can do two things when there's increase in coagulation factor consumption, increase in fibrinolysis, it can manifest as bleeding. If there's a drop in the anticoagulants as well as antifibrinolysis, it can present as thrombosis. In both of these conditions, you will actually see a drop in platelets. I want to spend a few minutes on the mechanism leading to DIC because understanding this is crucial to early recognition and management. So you can have endothelial cell dysfunction and platelet activation, and this happens in situations like HELP syndrome, where there's an inflammatory response with release of cytokines. You can get trophoblastic activation of coagulation when the trophoblastic membrane is breached, and this disruption causes activation of the coagulation cascade and then induces a systemic response, and this is what happens in abruption. When there is hemorrhage, there is a rapid consumption of coagulation factors which can then activate DIC. Or there can be disruption of liver function, which happens typically in HELP and in acute fatty liver. And in these situations, there is reduction in the production of the anticoagulation protein and coagulation factors. So typically, this can be a little more chronic, can be a little more long drawn. And you can see right there, that in somebody who has severe preeclampsia and HELP, who then has an abruption, multiple factors may be playing a role in the presentation of DIC. So we have to keep in mind what are the clinical features situations that can lead to DIC: abruption, postpartum hemorrhage, preeclampsia or HELP, acute fatty liver, amniotic fluid embolism, and the condition which we've heard a lot about in the last session, which was sepsis. So based on what gets activated more, the coagulation pathway or the anticoagulation pathway, you can have a presentation which is procoagulant DIC, which is predominantly thrombosis, or a hyperfibrinolytic DIC, which is predominantly manifest as bleeding, or a very low key activation of both processes, in which you can have a subclinical DIC where you see laboratory changes but the woman is clinically stable. So these are the possible presentations. So making the diagnosis essentially is from understanding the clinical setting and understanding that this woman is at risk of tipping the balance and getting into disseminated coagulation. Obviously, we need lab evidence, and depending on which is your practice milieu, you may get this lab evidence within 15 minutes or it may take 2 hours. And therefore, what you base your management protocol on will vary. Some will be heavily shifted on clinical management and some will be heavily based on your lab evidence, and that is how DIC is managed. So what are the 3 lab parameters that we like to focus on? Thrombocytopenia, so we need to know what's the platelet count. We need to know what is APTT, PT and fibrinogen, because both intrinsic and extrinsic pathways can get activated when there's consumption of coagulation factors depending on what the trigger is, and because there is fibrinolysis, D-dimer. Now, the other thing that complicates, just as in sepsis, they said there are many changes in pregnancy which cause problems. In DIC also, there are some concerns. Thrombocytopenia is the commonest feature, but we all know that in HELP and in ITP, you can have thrombocytopenia without the woman actually being in DIC. Both PT and APTT, the normal ranges are shorter in pregnancy, and so we may not see a prolongation outside what is non-pregnant normal until much later in the DIC condition, especially APTT, because factor 8 is also increased in pregnancy. Fibrinogen in the mother is increased in pregnancy, and therefore low values of fibrinogen may well be within what is considered normal in the non-pregnant range, but the fall in fibrinogen will be faster in a pregnant than in a non-pregnant woman. D-dimer, because it is elevated in pregnancy, is very difficult to interpret. So right there are many parameters which could be very crucial in the early diagnosis of DIC in the non-pregnant state, which become not so reliable in the pregnant state, and therefore it's important that we watch for trends, which means these tests need to be repeated and we look for shift in baseline, and therefore irrespective of the setup, something as fundamental as your clot retraction test is helpful, because in 5 to 8 minutes, it tells you whether this woman's blood sample is able to clot, because your lab test will take a minimum of half an hour for it to come back to you. Now, the other agent or the other test which is very, very helpful in the management of blood products in the established DIC is the thromboelastogram, which essentially will tell us how fast is the blood clotting, how strong is the clot, and how long does the clot last. And therefore, based on what you see, so if this R value is the reaction time, that tells you the significant clot formation. The K tells you what is the achievement of the clot, what is the firmness, and the MA is the maximum amplitude, which gives you the strength of the clot, and the LY30 and LY60 gives you what is the percentage lysis of the clot in 30 and 60 minutes after the maximum amplitude of clotting is achieved. So you can pick what drink you like, and you can pick your glass, and if you remember the glasses, you can kind of keep a memory in your head of what is the product that you will give, because obviously if there is R prolongation, you want to give a different blood product, whereas if you don't have, so basically, instead of going blind and saying 1:1:1, you can choose to give the blood product more appropriate to the stage of DIC and the kind of clotting problem that this woman is having. So you have two kinds of tests, the TEG and the ROTEM, and basically based on the test that you're using, you can use it to guide therapy. So if you have an R prolongation in the TEG, which is the same as a CT prolongation in the ROTEM, because they're two slightly different tests, you can give FFP or PCC. If that's basically asking how fast is the blood clotting. If the MA or the amplitude of the clot is low, indicating a weak clot, then you need to decide whether you want to give fibrinogen factor or platelets, and that you can do based on the platelet count. And if the lysis is too high, then you give tranexamic acid. So this is how you can probably fine-tune the therapy in DIC. Now, if you have a woman who is unstable hemodynamically, then risk scoring doesn't come into the picture. But if you have somebody who is stable and someone who, like the first case of abruption I described, you know is a very strong candidate for developing DIC, then risk scoring systems help. Now, the ISTH risk score is not adjusted for pregnancy because of the fact that our values are changing. And so there is a modified score by Iras et al., which looks only at 3 factors, which is platelet count, fibrinogen concentration, and the PT difference. And they use a cutoff of 26 or more. They say the sensitivity is 88%, specificity is 96% for the diagnosis of DIC, with a very good positive likelihood ratio and a negative likelihood ratio. So this is just something that you may help guide. But as I said, very often you are not going to wait for all these labs to come back. You are starting to manage based on the clinical condition, because you know that you will be chasing these labs all the time. By the time the lab comes back half an hour or 1 hour later, the woman's coagulation parameter has already changed from the point in time in which you have shifted the lab. So this is a condition where you're going to start treating while you're getting the labs. So the principles of management are A, anticipate, then manage the underlying condition, because if you can't just keep chasing her DIC and correcting her products without addressing what is the fundamental reason for her to get into that situation, prompt and safe delivery, because this is a pregnant mother and she will need supportive multidisciplinary care. So if you're in a small hospital, you don't have access to blood and blood products, stabilize and shift, because she's definitely going to need more lab surveillance and more people involved. So this is a management that happens. The principles will be definitely too large IV access, assess her hemodynamic stability, assess the fetal status. If it's an IUD, our approach is going to be completely on the mother. If it's a viable fetus at a gestational age where this baby can be salvaged, then obviously we need to balance how we are going to deliver. measure her blood loss, measure her oxygenation, because if there's microvascular thrombus, she can have other end organ damages that can quickly set in other than just bleeding. Involve anesthetist, intensivist, hematologist as your setup indicates. Talk to the blood bank and to the ICU. So ensure adequate oxygenation, make sure blood and blood products are available, and ideally initiate your resuscitation with blood and blood products. But most often in real life, it's going to take us time to get those blood and blood products, and therefore we would give crystalloids. So give crystalloids to maintain BP, but please remember that if you overuse crystalloids, it's going to worsen your dilution of the coagulation parameters and worsen DIC. So general massive transfusion protocol rule is 1:1:1, and early use of tranexamic acid does help in these coagulation factors. So what are the targets that we're looking for? A hemoglobin that's greater than 7, a fibrinogen that's greater than equal to 300, a platelet that's greater than equal to 50, a prothrombin time and an activated partial thromboplastin time that's less than 1.5 times control. So few pointers, we must be aware that there can be further blood loss. Where does this magic number of 7 come? It comes from cases of trauma. We really don't have outcome data from pregnancy or PPH to say 7 is good enough. So in a woman who's not yet delivered or in whom we are expecting further blood loss, you may want to push that up to 8. And remember that equilibration will result in a drop in HB over the next 24 to 48 hours. With FFP, its low concentration of fibrinogen is useful in PPH, but in established DIC, it's not as effective. It's better to use cryoprecipitate because you can get low volume, high concentration replacement, but it takes time to thaw. You have to order early and you can get transfusion reactions. Fibrinogen concentrates are expensive and it does not address other products and it cannot achieve volume replacement. So the issues that we need to keep an eye on are hypothermia. Because you may be in an operation theater, you may be in a labor ward where there is already a cold temperature. In addition, you're going to be giving massive products, and every time you give a blood product, if it is not warmed to room temperature, you're going to worsen hypothermia, and hypothermia will worsen acidosis. So both these have to be something that we keep in mind. Because we are going to give a large amount of blood and blood products, we need to watch the potassium and calcium, because both hyperkalemia and hypocalcemia can be there, which need to be addressed. And hyperkalemia will particularly get worsened if there's renal dysfunction, and renal dysfunction can very well set in these women because they can have acute renal injury both from the bleeding and from the microthrombi that DIC is happening. So we need to keep all of this in mind, which is why we need more than one head in the room to think through what is happening, and therefore a multidisciplinary approach. The issues around delivery, the mode and the timing obviously depend upon the maternal hemodynamic stability. If you have an unstable woman with a fetus in utero, you stabilize her and deliver. And as I already addressed, that we need to make a decision on section or not based upon the fetal status and whether we are going to try and salvage this baby, in which case we have to balance the risk of taking a woman and giving her an operative delivery versus the chance of losing that baby. Post-delivery monitoring is extremely important because these women will need care going forward. They can get reactions from the massive blood transfusion, and they need monitoring in a HDU unit. Thromboprophylaxis is a tricky issue in these situations. Compressive devices through the point of management, and then after they stabilize 24 hours post-surgery, we can consider and initiate LMWH. And I think that aspect of thromboprophylaxis is something that Bhaskar is going to next address in his talk. So I'd like to end with the take-home messages that in DIC, what actually helps us recognize early and treat well is to anticipate and to be prepared. Be aware of the lab changes in pregnancy. So more often than not, it is clinical judgment that will guide management. And today we have tools like thromboelastogram which can help us fine-tune, but obviously those are available only in select centers. So we need to initiate management while we are parallelly repeatedly doing lab assessments. We need to involve other specialists specialists and transfer early. We need to address the primary trigger. Just as they said, control source in sepsis, we need to control the condition that is triggering the DIC in this woman, plan delivery, and don't forget to continue to give care for her in the postoperative period. So thank you very much for the
Thank
patient.
you, Dr. Uma, for your details and nice, excellent description regarding DIC. Mechanism and early management and treatment. One important thing during management, electrolyte balance, imbalance or balance should be monitored properly. Otherwise, we can lose the patients. So, any queries or any questions from audience?
Sir, I have one, ma'am. Here.
Dr. Uma, please.
Oh, sorry, yes.
Actually, we are giving in some patients, already we are giving aspirin to those patients, 75 or 150. Is this has got any additive role or any beneficial role?
So aspirin, if we are giving, it's for prevention of preeclampsia. So usually, I mean, if it is around...
Is there any role in management of DIC?
No, there isn't a role. And I think that dose, if they come in with bleeding, it's unlikely to be impacting your management. You will still manage based on the lab parameters that you get. It's not going to make it worse.
Any question from audience? Oh, please take the mic. Antibiotics. Please, Dr. Uma.
Primary, from a DIC point of view, I don't think antibiotics have any role. But, if we're going to manage and do operative procedures, then this woman obviously will be at a higher chance of developing an infection. And so whatever prophylactic antibiotic we need to give at the time of deliveries or section is what we would do. And keep an eye out on the fact that she's at higher risk for postoperative infection, and if she develops infection, you treat it.
For prevention of sepsis, you mean to say? Okay. Please on the mics.
Yeah. Experience of factor 7 for DIC. Do you have any experience?
No, I don't. Because our team that I refer to, they don't believe in the use of factor 7. I think there was a phase when it was used, but there's no strong data that it is effective.
Okay, thank you.
Thank you, ma'am, for the wonderful talk. You have completed well within time. Now I have the proud privilege to invite our next speaker of this session, none other than Dr. Bhaskar Palsar. He is the Senior Consultant, Apollo Hospital, Kolkata. He is Chair AICC RCOG, Vice President IAGE, Foxy Representative to Suffolk, and President Bengal Obs and Gynae Society. Vice President Foxy, and he is going to speak on DVT, how to prevent and manage.
Thank you for the kind introduction. Right at the outset, my gratitude to Dr. Alpesh Gandhi and team for inviting me and for inviting AICC RCOG. Although the topic is DVT, how to prevent and manage, if time permits, I'll also look at management of pulmonary embolism, because DVT and pulmonary embolism go hand in hand. I bring you virtual greetings from Calcutta and hope to see all of you in a year's time there for the ICOG in Kolkata. We will use some abbreviations. VTE is venous thromboembolism, which encompasses deep vein thrombosis as well as pulmonary embolism. ACT means anticoagulation therapy. Low molecular weight heparin is LMWH. And when we say UFH, we mean unfractionated heparin. So what we'll look at is preventing DVT, which is prevention of DVT and PE, diagnosis of DVT and PE, and treatment of DVT and PE if time permits. Just to set the context that the incidence of venous thromboembolism in pregnancy in UK is approximately 1 in 500 to 1 in 1000. Pulmonary embolism is a major cause of direct maternal mortality in the United Kingdom. In India, there are studies which have looked at, and the incidence incidence is approximately 1 in 1500 if you look at the case reports. If you use low molecular weight heparin, that reduces the incidence of venous thromboembolism by around 60 to 70%, not by 100%. One study did show a reduction of around 88%, but the important point is that you cannot take it to 100%. The risk increases with gestation. The most of the DVTs and PEs happen in the post-delivery, although it can happen in third trimester, but it can happen in first trimester as well. It is 5 times more common to have it after delivery than before delivery. Now, if we want to do a prevention, we need to have a risk assessment. And risk assessment is dynamic. All women need to undergo a documented assessment of risk factors to venous thromboembolism at booking or before pregnancy. The risk assessment needs to be repeated if any of the condition changes and if she gets admitted to the hospital or develops any other problem, and the risk assessment has to be repeated again during delivery and immediately postpartum. Now, this is a very long list of risk factors which will go into the next few slides. I will try and confuse you and then try to make it concise. Now, please remember that for every point that we say usually carries a risk score of 1, and some of them carry more, which I have tried to put it here. Now, if a patient has got a previous venous thromboembolism, that could be a provoked or unprovoked. Provoked means that because of a surgery, then you give a score of 3. If it's an unprovoked VT, you give a score of 4. If the patient has a heritable or an acquired thrombophilia, the details of which I'll come into later, if it's a high risk one, you give them a risk of 3. If it's a low risk one, you give them a risk of 1. Some medical comorbidities, you give them, we are not talking of medical problems that you develop in pregnancy, the medical comorbidities the patient goes into the pregnancy with, you give them a score of 3. When you talk of age, it is 35 years. When you talk of BMI, if it's more than 30, you give them a score of 1. If it is more than 40, you give them a score of 2. Palliative 3 or more, you give them a point of 1. Then there is smoking, gross varicose veins, paraplegia, or any other cause of immobilization. The obstetric risk factors include multiple pregnancy, current preeclampsia, cesarean section. An elective cesarean section, you give a score of 1, and emergency cesarean section, you give a score of 2. A prolonged labor of more than 24 hours, a PPH of 1 liter or more, or any PPH requiring blood transfusion, a stillbirth or a preterm birth, and mid-cavity or a rotational forceps delivery. Among the new onset or transient are any surgical procedure in pregnancy, except cesarean section and perineal tear repair, which means appendicectomy, cholecystectomy, obstetric hysterectomy, etc. You give them a score of 3. A patient has got hyperemesis or dehydration in the first trimester, you give them a score of 3. For hyperstimulation syndrome in the first trimester, you give them a score of 4. 3 or more days of bed rest, you give them a score. Bone fracture, a long distance travel of more than 4 hours, a current systemic infection which requires IV antibiotics or a hospital admission, and to this you add at the present moment a current SARS-CoV-2 infection, and any ART or an IVF pregnancy, you give them a score of 1. The thrombophilias include antithrombin 3 deficiency, protein C deficiency, and protein S deficiency. These are the high risk ones. The low risk ones are the factor V Leiden mutation and prothrombin gene mutation, and the acquired ones, which are the lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. Now, when you talk of medical comorbidities where you give 3 points, they include a cancer, a heart failure, an active SLE, and an inflammatory polyarthropathy, inflammatory bowel disease, nephrotic syndrome, type 1 diabetes mellitus, any diabetes mellitus with nephropathy, sickle cell disease, or a current IV drug user. And then you use something like this, which I do not expect you to read. This is the nice scoring system, but essentially, I said at the end I will concise, and for those who are taking photographs of slides, I think I'll tell you which of this is one important slide. So if your total score is 4 or more, then you give thromboprophylaxis right from first trimester. And then you stop it. For example, you're giving it for OHSS, the OHSS resolves, the patient goes into the second trimester, you can stop it. If the total score is 3 antenatally, then you consider thromboprophylaxis from 28 weeks and continue it onto the puerperium. If the total score is 2, then you give them only postpartum thromboprophylaxis for 10 days. If And as I said that you have to do the rescoring again postnatally, and anybody who's a score of 2 or more, they need to have a thromboprophylaxis for at least 10 days. If the patient is admitted to the hospital antenatally, you consider thromboprophylaxis. If there is a prolonged admission or readmission to the hospital within the puerperium, you consider thromboprophylaxis. So this is a very important slide. This slide I have put which ones carry a score of more than 1. Everything else carries a score of 1. So previous VT 3 or 4, high risk thrombophilia 3, medical comorbidities 3, OHSS in the first trimester 4, hyperemesis 3, a surgical procedure in pregnancy 3, emergency cesarean 2, and BMI more than 40, very unusual in India, so I didn't put, is 2, everything else is 1. And that is how you do your risk scoring. Now, what happens if somebody got a previous VT, and as we said that there are 2 types of them. So if it is a provoked one, you start it from 28 weeks and give it 6 weeks postnatal. If it is a spontaneous one, then you start it throughout the pregnancy and use it at least 6 weeks postnatal. And woman who's got an antithrombin 3 deficiency and has had a previous thrombosis, giving them a prophylactic dose is not enough. You need to discuss with a hematologist. They might need a 75% or even a full treatment dose antenatally and for 6 weeks postpartum. All other heritable thrombophilias with a previous venous thromboembolism, you need to give them a prophylactic low molecular weight heparin. So please remember, protein S, protein C deficiency, they are high risk, but antithrombin 3 with a previous venous thromboembolism, you need to give them higher dosage. What again, antiphospholipid syndrome without a previous VTE, without a previous VTE, then we know how to treat it. With a previous VTE, you need to do a prophylaxis with a higher dose of low molecular weight heparin, 50% or 75% or 100% of the full dose, and same thing with a recurrent venous thromboembolism. Now, I have already spoke about that heterozygous factor V latent mutation and prothrombin gene mutation carry a risk of 1, whereas if it is a protein C or protein S deficiency or an antithrombin 3 deficiency, then it carries a higher risk, and these women would need to be having prophylactic thromboprophylaxis if they've not had a thrombosis before throughout the pregnancy and 6 weeks postpartum. In the first trimester, thromboprophylaxis hyperemesis, you give them thromboprophylaxis till it resolves. OHSS, you give them prophylaxis in the first trimester. IVF with 3 other risk factors. IVF carries a risk of 1. So you have 3 more scores, then you give them prophylaxis in the first trimester. For patients who are on prophylaxis, what do you do about labor and delivery? You tell the patients that if you have any pain or any bleeding and if you are on low molecular weight heparin, please do not take any further injections. Avoid any regional anesthesia for 12 hours after the last prophylactic injection. Withhold low molecular weight heparin for 4 hours after a spinal or after 4 hours after removal of an epidural catheter. And do not remove an epidural catheter within 12 hours of last dose. So you remove an epidural catheter 12 hours later after the last dose, and don't give any other dose for another 4 hours. Perform an elective cesarean section in between the low molecular weight heparin dosage. And if there is a risk of hemorrhage, then what you ideally do is, we can do an anti-embolic stockings, but they're not very useful. What you do is a pneumatic compression device. And that is something which is very useful. In postpartum, we've said low molecular weight heparin for 10 days. If the BMI is high, 2 persistent risk factors, all cesareans except elective sections who do not have any other risk, and those who have a SARS-CoV-2 infection. A quick word about thromboprophylaxis in SARS-CoV-2 infection. We have to speak about COVID because Alpesh has been our COVID president and taken us through COVID and has been instrumental in our fight of obstetricians against COVID. Now we need to understand that SARS-CoV-2 has a high risk of precipitating thromboembolic events, and it is a transient risk factor. If the patient is admitted, we need to start thromboprophylaxis and continue that till 10 days after discharge. If the patient is already on thromboprophylaxis, we need to continue that for 7 to 14 days after the recovery. In cases of severe disease, decide the dosage of low molecular weight heparin in consultation with the COVID team. If the patient is admitted postpartum, continue it for 10 days and consider 6 weeks if there is an ongoing risk factor. Now, agents for thromboprophylaxis, the price of low molecular weight heparin is come down. So usually we use that, But please remember the dosage is based on weight, and if there is renal impairment, we need to reduce that. A platelet count is not required unless you are using an unfractionated heparin. You know that there is heparin-induced thrombocytopenia called HIT, and there is a type 1 HIT which is idiosyncratic, happens immediately, more so with heparin, and there's a type 2 HIT which is dose-dependent, tends to happen around 5 to 7 days later. Anti-factor 10A levels are not required. Anti-factor 10A levels are required only when you are using a therapeutic dosage, and in spite of that the patient has a thrombosis. That is when you need a factor 10A. Low molecular weight heparin is safe in breastfeeding. If you are using an unfractionated heparin, you use 5,000 units 12 hourly. There are other options which can be used in women who are intolerant of heparin. And this is a very important slide. Most women we deal with will be within 130 kilos. So 50 to 90, you use 40 milligrams of enoxaparin or 5,000 units of dalteparin. If it is 91 to 130, you use 60, and if the patient is under 50, then you use 20 milligrams. Now, obviously, you cannot do a kilogram per body because you get it as 20, 40, 60. So this is a very important slide to decide what dosage you should give. With that, I'll go into the management of DVT as well as try and finish PE. Now, the problem is that DVT signs are very non-specific. The patient can complain of leg pain or discomfort, especially in the left leg, with tenderness, increased temperature and edema, lower abdominal pain, and elevated white cell count. For a pulmonary embolism, patient would complain of dyspnea. They can collapse, chest pain, hemoptysis, faintness, raised JVP with a focal signs in chest, along with symptoms and signs associated with DVT. Now, please remember, PEs can be fatal or non-fatal. A fatal PE, whatever we do, we won't be able to do anything. We won't get time. It is in the non-fatal PE where we can improve the mortality rate and morbidity by treating them in time. Now, 85% DVT in pregnancy is left-sided. Iliofemoral DVT is common. The classical features of swelling, redness, pain, and calf tenderness are unreliable, and clinical assessment would be wrong in 30 to 50% cases. But in DVT and PE, you need to have an index of suspicion. So what you do is, when you make a suspicion less than 50% will be positive on objective testing. And that's very good, which means you have a high index of suspicion. You do a compression Doppler ultrasound, and you have to understand the risk is throughout the pregnancy, although highest in the postnatal period. And the majority of DVT in pregnancy is iliofemoral, and they need treatment. Very rarely you find it isolated below knee. They should be treated, but there is insufficient evidence that whether this DVT can move on to the lungs and cause a problem. On ultrasound, the entire length of the venous system from the external iliac to the popliteal vein needs to be seen with compression maneuvers. If the ultrasound is positive, obviously you continue the anticoagulant therapy. If it is negative and you have a strong clinical suspicion, then you stop the anticoagulant therapy, but repeat the ultrasound in 3 to 7 days. In patients with an iliac vein DVT, you consider an IVC filter to prevent a PE. Yes, I do have time to cover PE. In PE, you do an ECG or an X-ray chest, and if there are signs and symptoms suggestive of DVT, you also do an ultrasound, and if the ultrasound is positive, you start anticoagulant therapy and you need no other investigations. If there is no history of DVT and you have to diagnose a PE, either earlier days we used to do a ventilation perfusion scan. These days most places have a CT pulmonary angiogram. That is what we do. But here there is a slight difference. If you have a high index of suspicion and the patient tests negative in DVT, you stop the treatment and repeat the test after 3 to 7 days. Because a DVT will take time to move to the lung and then cause a problem. But if it is a PE, and if you have a high index of suspicion, and the patient tests negative, do not stop the treatment. Continue the anticoagulation treatment. Do an alternate or repeat test till PE is excluded, and only then stop the anticoagulant therapy. If it is a massive PE with a collapsed patient, you need a multidisciplinary approach, and these patients might need a thrombolectomy. And in a collapsed patient, we always use unfractionated heparin and not a low molecular weight heparin. So a woman with a suspected PE should be advised that compared with CTPA, VQ scanning may carry a slightly increased risk of childhood cancer, but associated with a lower risk of maternal breast cancer. But these are absolute risks are very, very small, and you do not need a pre-treatment thrombophilia screen, and a thrombophilia screen should be avoided in pregnancy because it is unreliable. Protein S levels fall in normal pregnancy. The activated protein C resistance is found in about 40% of pregnancies due to the physiological changes in coagulation systems. Antithrombin may be reduced when extensive thrombus is present. In preeclampsia, antithrombin levels are reduced, and in liver disease, protein C and protein S are reduced. That is why the best time to do it is 6 weeks after delivery and not in the pregnancy. Please never do a D-dimer to diagnose a DVT or PE in pregnancy, because the D-dimer can normally be elevated in pregnancy. So if it is negative, it's great. If it is positive, it doesn't tell you anything. There is no role of a pre-test probability assessment. You baseline test, you need a full blood count, a coagulation screen, LFT, urea and electrolytes. You repeat the platelet count after a week for the risk of HIT2, and pre-treatment thrombophilia screen is not required. Initial treatment is low molecular weight heparin. Do you use a once daily dosage or 2 doses? Earlier it used to say that you should use 1 milligram per kg of body weight twice daily, and that is preferable to 1.5 milligram per kg per body weight, and that is the 1.5 milligram per kg of body weight is the dosage in non-pregnant men and women, non-pregnant women and men. Whereas in pregnant women, it was thought the requirement would be higher, so it will be 1 milligram per kg of body weight. At the present moment, it has been shown that there is no difference. So you can use 1.5 milligram per kg of body weight. I have said that you, in massive collapse, PE in collapse patient, you always use IV unfractionated heparin and do an MDT involvement, because they might need thrombolytic therapy or a thoracotomy or a surgical embolectomy. And this would be your dose. Less than 50 milligram, you use 40 BD or 60 OD. 50 to 70, you need a 60 BD or 90 OD. 70 to 90, 80 BD or 120 BD, 120 OD. It is very important to give it in the correct dosage. And what if you use unfractionated heparin, what would be your dose? You give a loading dose of around 5,000, followed by a continuous IV infusion of 1,000 to 2,000. And you usually start with an initial infusion of 1,000 and do the APTT level every 6 hours. And you go on doing that till you can get it to the APTT level to 1.5 times to 2.5 times to the level of control. And monitor the platelet count every 2 to 3 days. We all know the advantages of low molecular weight heparin: less anticoagulant effect, less thrombocytopenia, less bleeding episodes, less bone demineralization, and once daily administration, and similar efficacy. The only difference, I'll just take 15-20 seconds more. The only difference is there you have to wait for 24 hours after the last dose. Here you will have to wait for 24 hours after the last dose if the patient is on therapeutic dosage. You avoid regional analgesia and anesthesia for 24 hours after the last injection. Withhold low molecular weight heparin 4 hours after spinal or removal of epidural. At cesarean, if you are doing it and high risk of that you have to continue on therapeutic doses, it is a good idea to use abdominal and subcutaneous drain and put interrupted skin sutures. DVT near term, it is always easier to use an unfractionated heparin. If the patient is at a high risk of a thrombosis, then in labor, you can put the patient on unfractionated heparin and stop it 2 to 4 hours before anticipated delivery. And anticoagulant therapy, when you are continuing for 6 weeks, you can move over to warfarin, and then that's not contraindicated in pregnancy. So essentially, risk assessment is the key, and it is much easier to prevent than to treat, and you need a high index of suspicion. Thank you very much. I'll leave you at the court. Thank you again.
Thank you, sir. Any questions from the audience? Yes, ma'am, please come.
Good morning, sir. So, I'm SR from AIMS Lab. We recently had a case where we saw DVT-induced cellulitis, sir. So, the thing is that patient came to us with unilateral leg swelling, and the picture we first thought, because differentially always think of DVT, so we started her on heparin and everything. She had history of leg swelling since 1 month. And also her skin appearance was purely orange appearance of skin, and later on we started LMWH. Later on she developed gangrenous changes in her foot, and unfortunately she had to go leg amputation, below knee amputation also. So how frequent we can be see, like,
Very rare. I think we are talking of a completely different thing. Obviously, people who've got vascular disturbances and venous stasis are more prone to venous thromboembolism as well as peripheral vascular diseases, and this is something possibly this patient had. What we are trying to do here is to prevent a DVT or a PE in a normal patient who gets pregnant. But whenever there is venous stasis or an abnormal blood flow, obviously they are at a higher risk of peripheral vascular diseases as well as thrombosis, as well as a DVT.
I think
that is very rare.
I think it is pre-existing factor, some pre-existing factor must be there.
Absolutely.
So that's why it is a swelling of leg and even on treatment
no, sir,
of
just
DVT.
the thing is that I was wondering that how could we have prevented this leg amputation which she had to go through?
Very unlikely, because hearing this story, this patient possibly had a peripheral vascular disease which already caused stasis, and so that is why she had a DVT.
And cellulitis, sir, which she developed?
Cellulitis possibly she developed secondary to there being no circulation.
Okay.
Secondary to there being no circulation. The cellulitis possibly was a forerunner of necrosis in the evolution because there was no circulation.
Okay, thank you, sir.
Actually, what is your opinion, Dr. Bhaskar? Suppose there is a clot, you will go for aggressive treatment or breakdown of thrombus or slow removal. What is your idea on that?
See,
management of this thrombus.
See, the risk or the risk is you are not worried about a DVT. A DVT is not going to kill the patient. A DVT is essentially might give rise to leg swelling, which will take quite some time to go. What you are worried about the clot going to the lungs and causing the collapse. And if you start her on treatment, on therapeutic treatment, that should be enough. What you are worried about when you already have a PE or when you already have an iliofemoral, in the iliac vessels, you have a DVT. And that is where you possibly need to be more aggressive, because the possibilities already might be on the way to the lung. And that is where I said, that is where you need to talk about and think about, discuss with a hematologist about the need for putting in an inferior vena cava filter. So to answer your question, the higher the DVT, more aggressive would you be.
So another, so where there is a suspicion of DVT in future, so prophylactic treatment is advisable or not?
Yeah, prophylactic treatment would completely depend on the risk assessment. And as I said, if you have a risk factor of 4, then you start the prophylaxis immediately. You have a risk factor of 3, start from 28 weeks. Because as the pregnancy advances, the risk increases.
Okay, thank you, Dr. Bhaskar.
Can I ask just one more?
Okay, please.
All right. I think that is where it is much easier to do a risk assessment and prevent it, because if it is already happened, it's possibly too late. But I think in everything, in a post-operative patient, the first sign, one of the signs of PE would be a tachycardia, low oxygen saturation and collapse. These are the 3 simple things that you are looking at. And DVT would be a leg pain and a leg swelling.
Not every time. Sir, again coming back to cellulitis, actually one more thing, this cellulitis induced DVT also, right? So should we start the prophylaxis in that also if we are suspecting it's a long-standing, the patient is having cellulitis?
In pregnancy?
Yes, sir, in pregnancy.
Yes, of course.
Yes.
Because that patient is hospitalized, the patient has if a patient has got cellulitis, that patient possibly was on IV antibiotics.
Yes, sir. Antibiotic, we should start
this patient, if you do a risk scoring,
Yeah.
and depending on which trimester it is, possibly she would need, at least for the duration of hospitalization, she would require a prophylaxis.
Okay, thank you, sir.
Thank you, Dr. Bhaskar.
Madam has a question.
Madam,
Madam.
Okay, ma'am.
Prophylaxis, she developed HELPS. And it was a tough time and naturally hematologist and all the team came in excellent, even though we naturally lost the baby, but we could survive the mother after a long struggle. So if this thing happens after stoppage, in case of HELP, immediately can we take scissor or could I have waited for some time?
Sorry, I don't understand.
Patient was on thromboprophylaxis. She developed HELPS.
Oh, yes, of course. See, if the patient is on prophylactic thromboprophylaxis, you actually need 12 hours. But if there is an emergency, suppose fetal distress, of course you do not wait. And there you take the same precautions as you will do if the patient is on therapeutic, which means put an abdominal drain so that if the patient bleeds unnecessarily, the blood doesn't accumulate. If necessary, put a subcutaneous drain, and I would always suture those patients with an interrupted suture on the skin.
When
So obviously, yes.
we can drain. Right. Thank you.
Okay, thank you, Dr. Balsarkar. Our next speaker is Dr. Gita Gupta. She will speak on SLE, ensuring safe delivery, and MTP. She is Director and Professor, ONG Department, Maulana Medical College, New Delhi, established Fetal Medicine Clinic at Munshi and LNH, New Delhi, and editor of AOGD Bulletins 2016 and 17, Joint Secretary AOGD 2010 and 11, Co-Chairperson Fetal Medicine Subcommittee AOGD, and Executive Member Society of Fetal Medicine, and Secretary NARCHI. Now please, Madam.
Good afternoon, Chairpersons and my dear friends. First of all, I would like to thank Dr. Alpesh Gandhi and the Ahmedabad Obs-Gynae Society for inviting me here. So today I'm going to talk about SLE, ensuring safe delivery, and NTP. We are all aware that SLE has a high predilection for women of childbearing age. However, with the advances in diagnostic criteria and improved medications, more and more women are becoming pregnant, and the outcomes of pregnancy are also improving. And recently, the EULAR and the American College of Rheumatology has issued guidelines in 2019, which discusses how to, which has given a more objective diagnosis of SLE, though that is not confined to pregnancy, but I thought it needed a mention here. Now, we are all aware of lot of literature available on SLE for pregnancy and for postpartum period. However, when we talk of labor and MTP, very less has been said for the same. So, like when we talk about SLE and pregnancy, we always say that a pre-pregnancy optimization is going to give us favorable results. Similarly, for good outcomes of labor and delivery as well, a pregnancy optimization is going to help us. Moreover, it should be a cohesive multidisciplinary team, which will be a continuum of care from her antenatal period, where a rheumatologist, a nephrologist, cardiologist, pulmonologist play important role along with the obstetrician. However, when it comes to labor and delivery, it is the hematologist, the anesthetist, and the neonatologist who come at the forefront. Hematologist involvement is very important because many of these patients are on thromboprophylaxis therapy, and thrombocytopenia is seen in about 25% of these patients. And neonatologist plays a very important role because there are these are compromised fetuses where preterm as well as growth restriction is very common. And in babies with congenital heart blocks, a neonatologist and a pediatric cardiologist need special mention. And another important thing for the delivery of these patients is that these should be taken care of in tertiary care institutes where the above expertise is available. Now, just like when we do a pregnancy, when we want these women to be pregnant, we do a pre-pregnancy evaluation. So a pre-labor evaluation would be of help, particularly on those patients who were not in the antenatal care during their pregnancy, which is a common scenario in our country. So here the woman should be evaluated for her SLE-related complications, what medications she is on, what immunosuppressive agents, corticosteroids, low molecular weight heparin, or she's on some tacrolimus kind of drugs, her baseline blood pressures, her baseline counts, urinal analysis, KFT and LFTs, and a baseline CTG trace for women who have just come in labor or are being planned for termination of pregnancy, particularly if we want to induce the labor in these women. So timing of delivery is another very important part of labor management. Most of the times SLE per se does not alter your timing of delivery. It is usually determined by the coexisting maternal and fetal concerns. Even a lupus flare is not an indication to terminate the pregnancy prematurely. So most of these women can be delivered by 37 to 39 weeks, though no clear-cut guidelines are available. However, we avoid post-dates as in any high-risk pregnancy. So women who are in remission without any major organ involvement or have only cutaneous lupus erythematosus are likely to have normal pregnancy outcomes which are almost comparable to healthy women. So having said that, preterm labor is a very common complication which is associated with systemic lupus erythematosus. To the order of about 20 to 35% women have this versus 10% in a normal obstetric cohort. These preterm deliveries can be spontaneous, but most of them are iatrogenic, which though exact figures have not been specified anywhere, which are either induced labors or majorly pre-labor cesarean sections. Now, presence of lupus nephritis and active disease are the strongest predictors for a premature delivery, and preeclampsia is another important determinant of a preterm labor. In these women, if need be, magnesium sulfate can be administered for neuroprotection if the gestational age is less than 32 weeks, as we do in any other preterm delivery. And as far as administration of antenatal corticosteroids is concerned, that should be done with dexa or betamethasone and independent of any prednisolone administration already going on in these women, because prednisolone would not cross placenta and dexa and betamethasone do cross placenta. So now coming to the mode of delivery. So the aim of delivery, as far as mode of delivery is concerned, we aim vaginal delivery, particularly in women who go in spontaneous labor. And cesarean section should be reserved only for obstetric indications, though we are aware that there is a much higher incidence of cesarean section in these women to the order of 33% and an odds ratio of 1.7. So that being there because these women have a very high incidence of preeclampsia and may require preterm inductions where a poor biceps may not be the right choice, and particularly with associated FGR babies. Moreover, increased cesarean section rates also predispose these women to a much higher rate of thromboembolism, which Dr. Bhaskar has just talked about, with an odds ratio of about 2 to 6.7%. This is a vaginal delivery. There's a higher risk of bleeding also and infection also. So one must be very careful in choosing the mode of delivery as section in these women. And induction of labor is not contraindicated. Now coming to some specific areas with respect to the antenatal medication going on in these women. We all know that many of these women are already on prednisolone therapy. So if these women are on prednisolone therapy, we must consider whether they would require stress doses of steroids during labor. So the women who require stress doses of steroid during labor are the ones who are on chronic corticosteroid therapy. And this is done to compensate for the iatrogenic anticipated adrenal insufficiency. The route of administration would be intravenous. We use hydrocortisone, which is used in the doses of 50 to 100 milligrams 8 hourly during the course of labor and during cesarean section. And the doses of 50 to 100 milligrams have been chosen when as per 7.5 to 20 milligrams per day was given, or whether more than 20 milligrams per day was given. The other indication of using steroids during the labor in these women is if there is an exacerbation of SLE during labor, and then is the time when you would need an acute administration of steroids. Now, thromboprophylaxis, this has been covered already by Dr. Bhal, but to summarize again, if a woman is on low dose prophylactic thromboprophylaxis, then we have to use the 12 hours interval, and to stop the drug as well as to give regional anesthesia, a 12 hours interval is must. However, if a woman is on high dose prophylactic thromboprophylaxis, then this interval increases to 24 hours. We restart thromboprophylaxis after 4 hours in cases of regional anesthesia, and the epidural catheters are only removed after 12 hours of the last dose of low molecular weight heparin. Now coming to thrombocytopenia, which has an incidence of about 25% in these women, and is further escalated by coexistence of preeclampsia, HELP, and antiphospholipid antibodies. So during labor or if you have to do a cesarean section, a correction by platelet transfusion is must. And the previous speaker has talked about the optimal levels which we need to appear, and regional anesthesia becomes a challenge with thrombocytopenia. Now, Chen et al. In his study of these about 2,000 patients of SLE had compared it to about 8,000 non-SLE patients and had found that APGAR scores at 1 and 7 minutes of less than 7 were significantly more in the women who were having SLE. So needless to say, and we all know that because of the associated FGR or the preeclampsia, distress is more and probably contributes to higher cesarean section. And like any other high risk labor, these women need a continuous CTG monitoring during labor if they are left for vaginal deliveries. Now coming to anesthesia considerations, of course, neuraxial techniques are preferred, but are to be withheld if there are any associated platelet disorders or there are issues with thromboprophylaxis cessation. General anesthesia can again be a problem in these patients because SLE may be associated with vocal cord paralysis, precarotenoid arthritis, or tracheal stenosis, and the anesthetist is the best person to decide that. A videolaryngoscope or a fiber optic intubation should be considered as alternatives to secure the airway. Now, hemorrhage is another concern here. We all would, of course, do active management of third stage. The thrombocytopenia or prior anticoagulation therapy predisposes the woman to this, and particularly women who are having nephrotic syndrome and very high levels of protein loss in the urine are another set of candidates who are predisposed to more bleeding. Sometimes there is a restriction to the use of prostaglandin agents. Like if a woman is hypertensive, then methergin has to be withheld. And if a woman has pulmonary or cardiac involvement, then one has to be very careful or probably not use carbaprost. A word about fetuses with congenital heart block. There were a few reports which would say that these babies, once diagnosed and achieve lung maturity, should be delivered. However, if you talk to your pediatric cardiologist, they're always happy if the baby is brought out at term, because for pacemaking, a term baby is where the optimal results are obtained. Monitoring of fetal heart during labor for these babies is definitely a challenge. Some people have proposed repeated scalp blood samplings, but we all know the practical issues with it. And hence, cesarean section is offered to these women, but after thorough counseling because of the postnatal morbidity and mortality which can be associated. These deliveries need to be planned at centers with appropriate neonatology support and facilities of pacemaking, because these babies sometimes need immediate post-delivery pacemaking. Now, as we talk about pregnancy care, every SLE patient has to have an individualized pregnancy care plan. Similarly, a tailored postnatal plan is required for these women. However, the important issues to be kept in mind are that you have to monitor these women for SLE flares, because in the puerperium, the maximum number of SLE flares would be there. You should restart the pre-labor medications like HCQ and azathioprine and reassure the woman that these are safe during pregnancy as well as during breastfeeding. If the woman was on maintenance corticosteroid therapy, we need to come back to the oral corticosteroid therapy. Women who have prolonged or complicated labor may require higher doses during the early 2 to 3 days of puerperium, and then they can be shifted to the pre-labor doses. And of course, we need to resume the thromboprophylaxis. While you are breastfeeding, one should withhold methotrexate, MMF and cyclophosphamide, because they are secreted in milk and can be harmful to the babies. Watch for neonatal lupus syndrome. And contraception is a very, very important area which should be thoroughly discussed with these women in the postnatal period. The long-acting reversible contraceptives are the ones with choice, but here again, the time would not permit me to go into the details, but copper IUCDs are a good option unless the patient is on anticoagulant and at a higher risk of bleeding. Then next good option is an LNG-IUS with a very minimal risk of thrombosis. So progesterone only contraceptives, though choicest, but still there is a very small risk of thromboembolism associated with that as well. And secondly, if you're using Depo-Provera, then there is a small risk of losing the bone density as well. Barrier is got a very high failure rate, and of course combined oral contraceptives are otherwise also not a favored option in SLE. However, in a breastfeeding woman, we usually don't advise COCs. Now, coming to the part of MTP, these are two reports which I got in the literature about at a gap of about a decade, one published in 2011 and the other in I think 2020. And in both of them, we found that this is a huge area of unmet needs here, because in the first study, 86 women out of 200 were at risk of pregnancy, but about 60% received no contraceptive counseling despite these women being on teratogenic drugs. 53 were using only barrier method, which has a very high failure rate, and only 13% were using IUD. So a minority only received counseling or used effective contraception, and later would become candidates for MTP. Second, study concluded that induced abortion rate in women with SLE on teratogenic drugs were more than 30%, and the rate of unexposed SLE women, suggesting suboptimal contraceptive counseling. So you can imagine that, though not reported in literature about the exact incidence of MTP, but there's a huge woman we are exposing to MTPs, maybe either because of unwanted, unplanned pregnancies or because the woman conceived while she was on teratogenic drugs. So some tips about MTP in these women. These women should receive hospital-based care for MTP and not a clinic-based care. The provider in the hospital can decide whether he wants to take up the procedure on a clinic-based setup where a woman is there with no complications, or no organ involvement, or whether he wants to involve the woman in a OT setup care, particularly women with flare or women on anticoagulation. Now, women on chronic corticosteroid therapy, you need to increase the dose of corticosteroid for a few days if you are planning a medical method of termination, because mifepristone, as we all know, is an anti-glucocorticoid agent. So either you will step up the dose of corticosteroid for a few days, or maybe you will opt for a surgical method of termination. Now, patients who are on anticoagulation, here one should opt for a surgical method because it allows immediate uterine evacuation and lesser chances of delayed hemorrhage. Moreover, it has the advantage of an early resumption of anticoagulant therapy. If there is a renal impairment, then use of mifepristone is contraindicated, and one has to use carboprost, particularly when it's a second trimester abortion, with great caution, because if woman has an active cardiac, pulmonary or renal disease, then there is no role to use this drug. So in the end, I would say that the literature says that maternal illness did not worsen for any patient during MTP. Most of these women who had maternal illness was the determined most of these women where maternal illness was a determining factor improved after termination. However, there is still a lot of gap of knowledge in these two areas, both the delivery as well as MTP, and I think we'll all collate our experience and share with each other for better outcomes in these women. Thank you for your patient hearing.
Thank you, ma'am, for the wonderful talk. Any questions from the audience? Yes, ma'am.
Ma'am, I got many patients, but the last one at present carrying 7th month, and once she delivered very nicely, in spite of advising contraceptives, she did not believe and became pregnant again, and now 7th month. So each and every woman, we understand that at a risk of PPH. Suppose if I won't be able to give carboprost, can I give carbetocin to her now? When she will deliver if required?
I think carbetocin should be safe because that has not been seen to have any effect on hypertension. The choice of your oxytocin drug will depend on the profile of the woman. Whether she has hypertension or she has a cardiac disease, then we withhold methergine. If she has a renal disease, then we have to withhold carbaprost. So what associated complications she has determines your choice of oxytocin. And of course, oxytocin always remains the drug of choice, which is there with any other laboring woman.
But prophylactic use of carbetocin has not been advocated yet, or it can be?
It has not come in the guidelines. It is still in the research area. So as long as oxytocin is available, I think I will prefer oxytocin.
Thank you.
Well,
Ma'am, this PGF2 alpha will be always for the therapeutic dose of this, if the prevention of PPH, if she goes. Otherwise, we will be dependent on oxytocin.
yeah. No, she was asking about carbetocin, not carbaprost. She was talking about carbetocin.
Ma'am, I have another question. If these SLE patients are on steroids, does this have any effect on the baby's brain growth or any ventricular accumulation?
The preparation of steroids which we are giving for management of SLE is either prednisolone, methylprednisolone. So these do not cross the placenta. Most of it is metabolized and not having adverse effects on the fetus. However, the higher doses of steroids during pregnancy have a lot of maternal complications like intolerance to glucose and your development of hypertension and women who, and hypertension. So these are actually the areas of concern here. That is why we want to keep the use of prednisolone to the minimal possible dose. Not even in pregnant, even in non-pregnant patients.
Thank you, ma'am. Any other question? So hereby we end up with this session. Thank you, organizers. Once again, thank you so much for involving us to this great session. Can we come for the group photograph, ma'am?
Yes, sure. So all the speakers of session 3 can come on stage for a group picture, please. That was indeed a very interactive session. Thank you all the chairpersons and the speakers.
कोऑर्डिनेटर्स तो डिफॉल्ट होते हैं मैडम।
तो इसमें निकालता हूं, मैं भेज दूंगा। कोऑर्डिनेटर वो आ रहा है। चल इधर रेडी स्माइल स्माइल आ नहीं रही है। आ गया। Thank you. Well done. Thank you. One more thing. आज पढ़ना सेशन कैसे सर? बढ़िया, ऑल वेल। आपको देख के अभी हम बातें सुजाता भी करेंगे थोड़ी देर में। अब पढ़ना सेशन शुरू हो गया।
ऊपर अच्छा ठीक है, बात में
अपनी टीम को लेके जा रहे हैं।
Yes, yes, she told.
हाँ, दोनों दे दो मेरे। अब लगा दो।
So we move on to session 4. This is again a very relevant topic. It covers the infections in pregnancy with its complete complexity. I would like to invite the chairperson on dais, Madam Dr. Pratibha Singh. Madam has come all the way from Bhagalpur to be with us. She has held various positions in the local and national level, working very actively for our society. She is a recipient of the National Best Teacher Award by the IMA in 2021. Welcome, Madam. Next is Dr. Ajay Mane. Welcome, sir, on dais. He is the medico-legal consultant since 18 years, giving advice for free of cost. He is also a national trainer for Foxy Adolescent Health Committee. He has various publications to his honor. He is also the health advisor for the Sports Authority of India. Such a varied profile. Welcome, sir.
स्पीकर लगाड़ी
फोटो के लिए बोल दिया
हेलो
Thank you. बुला ले मैडम है मैडम इज देयर माधुरी मैडम इज देयर हाँ ठीक है hello yeah good afternoon and it's my proud privilege to welcome our speaker none other than Dr. Madhuri Patel ma'am. She is MD DGO FICOG and she is the Deputy Secretary General FOXY. So I welcome Madam to this forum. Yeah, Secretary General FOXY.
I am so sorry, but finally we have found the missing third chairperson. Dr. Bhavik is come all the way from Gandhidham. Please, sir.
Hello. Yes, come. So, Madam is Secretary General FOXY, and today she'll be talking on pregnancy with malaria, dengue, and chikungunya. We all know that it is so prevalent in India, and she'll be talking about this. And I'll request. No, she'll be talking.
Respected Chairperson, Dr. Pratibha Singh, Dr. Ajay Mane, and Dr. Bhavik. And all my junior and senior, very good afternoon or morning to all of you. At the outset, I would like to thank Dr. Alpesh Gandhi and entire team for giving me this opportunity. There is one correction over here because I was invited, I was told to talk on the dengue and chikungunya, and malaria was not included. So I will start with the presentation with dengue. So today I am going to talk on dengue and chikungunya in pregnancy. Over last decade, the worldwide dissemination of arboviruses such as dengue virus, Zika virus, and chikungunya virus has emerged as an important public health issue. These viruses share a common vector, that is Aedes aegypti, and to a lesser extent Aedes albopictus, and therefore of Kochman co-circulation. Dengue is now considered endemic in most of the tropical region. So the most important today is dengue, and we are seeing so many patients in our practice. We have so many morbidity and mortality. So I will go ahead with dengue in pregnancy. The global incidence of dengue has increased dramatically in the last several decades, with an estimated 40 to 50% of the world population in 120 countries at risk. Today's severe dengue largely affects Asian and the Latin American countries, where it is a leading cause of hospitalization and death. The World Health Organization ranked dengue as one of the top 10 threats to global health in 2019. WHO estimates at least 100 million infections occurs every year, including 500,000 dengue hemorrhagic fever cases and nearly 22,000 deaths. Most of the states in India are dengue endemic. So early detection, access to the proper medical care will reduce the fatality from 20% to below 1%. Dengue fever is a notified disease. Every dengue patient should be notified to the medical officer of the health of your region. Pregnant women are more susceptible to dengue infection, making it a global concern, being a major cause of maternal mortality in recent years. Obstetrician, being frontline physician for pregnant women, should shoulder the responsibility of identifying and managing cases of dengue fever in pregnancy. So why dengue is more dangerous in pregnancy? Because it has adverse pregnancy outcome. It can be like preterm birth, low birth weight, cesarean, more higher rate of cesarean rate. There is a risk of vertical transmission, and dengue impact on at the parturition, because if the patient is in a critical phase, then she is compromised with the coagulation, and then she will have PPH, and then we are really worried about that. And dengue fever does not warrant the termination of pregnancy, because data is not enough to say there are embryopathies with dengue fever in first trimester. Secondly, There are challenges recognizing a dengue and plasma leakage in pregnancy because vomiting, which is one of the warning signs, may be taken as a hyperemesis pregnancy, baseline tachycardia, lower baseline BP and lower baseline hematocrit attributes to the physiological rise in blood volume. And that is challenging in the monitoring and management, so we diagnose in a later stage. And as I already mentioned, if there is inevitable delivery during critical phase, we are going to face severe postpartum hemorrhage. So these are the different concerns which is giving rise us to have a dengue, very, very difficult disease in recent era. So the causative agent is dengue is an arbovirus of a Flaviridin family and Flavivirus genus. There are 4 serotypes of the dengue virus. And dengue 2 is the prominent serotype circulating in India. Dengue infection with one serotype, if a person gets a dengue infection with one serotype, she is likely to get with the other serotype. So don't feel that you are immune because you have got a dengue, because there are 4 serotypes and therefore one has to be careful even though you get once. But if that one again, it gives the long immunity, whichever is infected. So the vector is Aedes aegypti, breeds near human habitation in relatively fresh water pools or collection, and incubation period is 4 to 10 days after a mosquito bite, and it can be symptomatic or it can be asymptomatic. WHO has said that 80% of them are asymptomatic and 20% of them are symptomatic. Now in symptomatic, there can be undifferential febrile illness, that is, you can't make out that this is dengue or this is some other disease. Then dengue fever, then this 20% can go into dengue hemorrhagic fever, what you call is plasma leakage as in hallmark, and compensated or normal tensive shock and hypovolemic shock. So these are the different phases of the dengue fever, that is febrile phase, critical phase and recovery phase. In febrile phase, all of us are aware that acute high-grade fever lasting from 1 to 7 days, skin erythema, conjunctivitis, body ache, myalgia, and I have seen some of the patients, they are having retroorbital eye pain. That is typical of this dengue fever. Then physical examination, you may find some important findings, you may not find depending upon the disease level, which phase it is. And of course, we can see the petechial and mucosal membrane bleeding, liver will be enlarged and tender. And there is something called as tourniquet test, that is you tie a tourniquet with the BP cuff and you keep that BP raised at a level of midpoint of the systolic and the diastolic BP for 5 minutes, and then you remove it. And if you find in a 1 inch area, if you find more than 10 spots, then she is having hemorrhagic tendency. So now we are at the critical phase. After the fevers start settling, then the critical phase comes, and that is lasting for 24 to 48 hours. This is very, very important. If you don't pick up this disease at this stage, critical phase, then there is a higher fatality, and this will be like a plasma leak from the intravascular compartment to the extravascular compartment, leading to the shock, uncompensated shock, and death. That is called as dengue shock syndrome. Then it can be hemorrhagic manifestation, and severe organ involvement may develop hepatitis, encephalitis, myocarditis, and bleeding. So these are the 3 things which happens in a critical phase, and we have to pick up this condition. So what are the warning signs? Warning signs are the abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation like ascites, pleural effusion, etc., mucosal bleeding, lethargy, restlessness, liver enlargement, tenderness, and laboratory finding increase in hematocrit value. In the beginning, what happens, the WBC counts, they go down. Every day the WBC count goes down, but when it is in a critical phase, because there is an extra vascular compartment, the fluid gets accumulated, that's why the hematocrit increases and the platelet goes down. So severe dengue criteria are the leakage leading to shock and fluid accumulation with respiratory distress, severe bleeding, Severe organ involvement like liver, the enzyme will be more than 1000, impaired consciousness, heart and other organ involvement. Now we are with the recovery phase. After 24 to 48 hours, if the patient passes through the critical phase, then up to 72 hours, all the fluid which has been extravasated gets absorbed. Patient improves, appetite improves, and patient is in a good condition. Diuresis occurs and PCV, fluid resorption, WBC and platelet rises. So this is the diagrammatic, clinical course of illness. So we have to remember that it is febrile phase, critical phase, and the recovery phase. And the most common complication is liver dysfunction, significant bleeding, and coagulopathies. So when to suspect a dengue fever? If she is living in a dengue, if the patient comes with a fever, she is in a dengue epidemic zone or travel from dengue endemic area, one should think if the two signs of fever with other signs are present, at least two with any warning sign, you have to suspect her. Now the laboratory diagnosis, we always do NS1 along with the complete blood count. We always do NS1, which is positive, right in the day 2 or 3, and RT-PCR is 95% specific, and dengue IgM is detected after 5 days of fever. And full blood count is essential, so we will know the prognosis later on. So the clinical manifestations are sometimes so difficult and the treatment is so difficult because we are diagnosing in a later stage, because what is happening, they coincide with the other similar conditions like HELLP syndrome, pneumonia, pulmonary embolism, various obstetric causes of vaginal bleeding and other infection diseases. So there are sometimes misdiagnoses of the treatment and we may diagnose late and we may lose the patient. During pregnancy, there will be miscarriage, preterm birth, low birth weight, oligohydramnios, antepartum and postpartum hemorrhage, fetal distress, and intrauterine death. The neonatal complication has been reported as a vertical transmission from 1.6 to 5.6%. And if the perinatal infection, if patient is near the perinatal period, then chances of intrauterine death and the neonatal deaths are high. So as I have already mentioned that during parturition, if she is in a critical phase, we have to worry about the postpartum hemorrhage. So now we are here that it is inevitable, if the patient is going to deliver, means she is in labor, it is inevitable, then we have to still in a critical phase, we have to conduct the delivery. But if she is not in a, she is in a latent phase something, then we can delay the delivery by giving tocolysis. Now tocolysis is controversial, right? But we are giving for 48 hours for the preterm, labor, where, we ask for the lung match steroid, So similarly, we can try this, and there are multiple papers available. They say that you can give tocolysis, and if you can delay 2 or 3, days this delivery, that once the critical phase goes away, then the outcome is very, very good. So there are different papers, there are many available, and they are saying, but you should not use routinely tocolysis. Then of course, we have to use oxytocin. Right, and secondly, misoprostol can be given as a prophylactic or for the treatment of the postpartum hemorrhage. Post-delivery care is very important because there is a vertical transmission, so you have to take care of the child, whether the newborn, whether baby is positive or negative. So now this is a FOXY, a good clinical practice recommendation, which is done by, I think, Dr. Sanjay Gupta, sir, is the head of that, and we have formed good clinical practice guidelines. We don't call it a good practice, clinical, we call it as a good clinical practice recommendation, because guidelines, once you say, anybody can go to the code and we cannot protect ourselves. So we have shifted over as good clinical practice recommendation. So, when we are suspected, as we know that we have to do day 1 WBC, CBC count, and we are suspecting her, so admit the patient. Even she is suspected, you have to admit the patient. Then you have to monitor, which I'm not going to go in detail, but you have to do every day, lab tests just to see what is the complete blood count. And one has to give only paracetamol, and you can give maximum 4 grams in 24 hours. Don't give any other drug like diclofenac and brufen, etc., because they may hamper the coagulation. And only paracetamol if the fever is not getting under control. Then one more thing is you can do the tepid sponging. That is also equally effective, because why I'm saying, my daughter had not in a pregnancy, but she had a dengue fever. She was given paracetamol, it was not getting control. So they were doing tepid sponging, So that really helps it. And of course, when group A is not the dengue fever without warning sign. So she's quite stable patient. So here we have to give her oral fluids, and if she cannot take, then we have to switch over to the IV fluids. And you have to see that she is not with the warning sign. Once she is with the warning sign, then she becomes a group B. And there we have to monitor very frequently. And once she vomits out, if she will keep on vomiting because the extra compartment fluid is getting up. So only thing is that you have to give IV fluids, and that also normal saline. So that will really help, because dengue there is no treatment, no drugs. Only if the WBC goes down below 3000, then to prevent secondary infection, we give antibiotics. Otherwise, there is no need to give antibiotics, only IV fluid, because there is lots of dehydration because of the shifting of the fluid from the intravascular to the extravascular. And dengue shock syndrome, that becomes group C, where she really requires admission in intensive care unit, and therefore we have to take care and we have to transfer the patient to the higher center. But you don't wait for this situation to come. You have to, when the dengue is diagnosed, it is better to, send patient to the higher center. And whenever we transfer the patient, you have to write a complete transfer note with recent WBC count. Of course, now with this, now we are with the convalescent phase. There will be a rise in the WBC, platelet, patient will get stabilized, patient will feel hungry. Then there will be, if there is a sign of fluid overload, she will have cough, wheeze, tachypnea. So you have to be take care of this. And discharge should be after 24 hours once the fever settles without antipyretic. So there is a debatable thing that time and mode of delivery. As I have mentioned, that you have to avoid that particular time of critical phase, right? If you avoid, that is the best thing. And then it is a national guidelines of Sri Lanka in 2019 published that dengue fever infection should be managed by a multidisciplinary team. Induction and elective section should be avoided during critical phase, and you should have platelet minimum of 50,000. And in case if you are, you cannot keep on giving platelets. Suppose you are planning to deliver her tomorrow, by chance, you can't give today. So you have to give a platelet at the time or during the delivery, because that platelet will remain. Otherwise, the platelet will, again, the count will go down. So that is one important thing you have to mention. Then there are other things about this, that American College of Obstetrician and Gynecology say that you should keep the maternal platelet more than 50,000 before major surgery or vaginal delivery. And major surgery, why? Because we have to give epidural spinal anesthesia. So you have to keep their platelet minimum 70,000. So epidural hematoma does not occur. So these are the do's and don'ts. I'm not going through it, and my time is getting up. But one should remember, this is a vector-borne disease. So vector control in preventing water accumulation is of the utmost importance. Use larvicidal agents. Dengue vaccines are available, and which of course you have to give dengue vaccine because it is a live attenuating vaccine, and therefore you should not give during pregnancy. But if it is a high risk, then you can try that, because we want to save mother. So that's why you have to decide, but ideally it is not given. And the mother, when she comes to the antenatal clinic, you have to, train her to keep cleanliness. The water should not be accumulated, so the bleeding does not happen. So these are the most important part, you can say. And we had done a statistic in 2018 where 3 states, Punjab, Maharashtra and Rajasthan, had a maximum dengue cases and they had a maximum deaths. So these are all preventable diseases and we should prevent with all these things. I think, should I say something about chikungunya? My time is up, that's why. 1 minute, okay. So the chikungunya is also same, but it is not that severe. But one thing I would like to mention that it has re-emerged in 2005 and 6 after it was quiet for 30 years. And then it re-emerged as a massive epidemic in the Indian Ocean island, followed by its spread up to the American continent in 2013. So it is, it is again asymptomatic and it's a mild symptoms like fever, rashes, etc. And but it can have a complication of Guillain-Barré syndrome and then hepatitis, myocarditis like dengue. And therefore 15 to 60% of cases of chikungunya infection might result in the chronic sequelae of rheumatism where patient keeps on complaining joint pains. Sometimes we feel why she is complaining, but it is a fact because there are many studies they say they have continuous joint for many years, especially adult patient. And maternal outcome is same as the non-pregnant patient. However, the risk also increases because she may require intensive care unit like other patient. And the fetal, I will say, we are worried about the vertical transmission and it usually occurs at the perinatal period if she is in the viremia stage, and therefore it is reported. I am not going through it because the time is getting up. So we have to, again here, we have to, as I mentioned about the tocolysis, we can give a tocolysis for a temporary phase. And once the acute viremia is over, after 5 days, you can do the delivery or a cesarean section. So this is main thing is with the neonates we are worried about here. So I will just end my talk with the conclusion. Dengue is a preventable cause of maternal mortality in India, and so chikungunya. Public awareness program should be arranged, and antenatal care in antenatal clinic mother should be counseled during her antenatal visit to prevent stagnation of water and local cleanliness. The current situation is complex because there is no vaccine except for dengue and no specific treatment for the 3 above viruses. Vector control is the only comprehensive solution, and this remains a challenge because no measure achieve effectively mosquito control even after the program for dengue control. Until we develop better technologies to control mosquito population, the globalized and the urbanized world we live in will remain vulnerable to the threat of successful arbovirus epidemic. So we have to have some strategies to prevent this, vector-borne disease. Thank you very much for the patient hearing.
Thank you, madam. It was a wonderful talk. You have taken a full journey of dengue and chikungunya. And it is very important. It is a vector-borne disease and awareness is very important. We must tell our surroundings that surroundings should be clean, the water should not be locked. So that all should be told to them. And what you have told about the vaccine, which is important. So you have to outweigh the cases if the patient is in critical condition, and if you require, if you have to give injection, you must give vaccine even in the pregnancy. That is what we could understand. It should be done like that. Although it is a live attenuated vaccine, we should not be giving in pregnancy. Right. And I just wanted to ask one question. For chikungunya, what about the platelet count? Does it also decrease?
Yeah, it decreases. Platelet count decreases. But it is not that, compared to dengue fever.
Dengue. So, any questions?
What is the duration of vaccine?
Yeah, duration of the vaccine.
0 to 6.
0 to 6. So, thank you, madam. It was a wonderful talk. Thank you so much. Thank you. Now,
good afternoon, ladies and gentlemen. Next speaker with us is Dr. Anita Singh, ma'am. Ma'am is ex-professor Patna Medical College, past president of POGS, vice president Foxy 2020, chairperson of Endocrinology Committee Foxy 2014 and 16. She is a member of Governing Council ICCOB 2015 to 2020. She is the chief consultant at JP Hospital and Jan Chikitsa Hospital, Patna. She will be speaking on pregnancy with H1N1 infection. Welcome, ma'am.
First of all, I wish to thank the organizers, especially Dr. Alpesh Gandhi and the whole organizing team for giving us this opportunity to meet physically and attend a physical conference after the last AICOG held at Lucknow. So that's great. Respected chairpersons and the esteemed audience, although the audience is few in number, but I think each one is a very precious one and a very important member of Foxy. Yes, online, yes. But just because I am feeling it a physical conference this time. So it is such a pleasure to be here amongst all of us after a long, long time. I have been given the task of talking something about pregnancy with H1N1 infection in pregnancy. The recent outbreak of COVID has made it simple because it is more or less the same pattern of respiratory tract viral infection. Okay. So influenza infection remains a significant contributor to morbidity and mortality from febrile respiratory illness. It occurs annually and affects all the ages all over the world. Children, adults above 65 years of age, and pregnant women are especially vulnerable to have this infection and also to have a serious outcome out of this. The epidemic with influenza in the last 100 years have been several times. It began in 1918, again in 1957, 1968, and 2009 was the most recent H1N1 influenza infection that occurred. This influenza A virus subtype, H1N1, was a 8A subtype, and it caused significant febrile illness throughout the world in 2008 and 9. WHO declared it a pandemic on June 11, 2009. In recent years, there have been several influenza subtypes which have been reported causing sporadic human infections, including the highly pathogenic avian influenza that was H3N1 and H7N9. If we look at the epidemiology of this infection, the epidemic began in Mexico in 2009 and rapidly spread to other countries around the world and was declared a pandemic by WHO. The novel H1N1 virus carried several gene segments that are descendants from the 1918 Spanish flu influenza A virus. In India, the first case was reported on 13th May 2009. It was first proposed to be a disease related to human flu during the 1918 flu pandemic. The phylogenetic origin of the flu virus that caused the 2009 epidemic can be traced back to 1800s. As of March 2015, 33,761 cases were reported and reported deaths were 2,035 in number. The classical swine flu virus and influenza type A H1N1 virus was first isolated from a pig in 1930. And the states which were highly affected in India were Rajasthan, Gujarat, Madhya Pradesh, Maharashtra, Delhi, and Telangana. Coming to the virology of this H1N1 influenza virus, this belongs to RNA group to the family of Orthomyxovirinae. There are three genus A, B, and C. Type A is further divided into subtypes based on two viral antigens, that is hemagglutinin, that stands for H, and neuraminidase, that stands for N. B and C have no subtypes. H1N1 is hemagglutinin 1 and neuraminidase 1, which belongs to subtype A. Influenza A and B is responsible for causing seasonal viral influenza. Influenza C causes very minor respiratory illness. Dominant strains are included. Each time the strains keep on changing to some extent. As we know, that is true for all viral infections. And the vaccine makers always take care of the recent viral antigen makeup of that season when they start manufacturing the viral vaccine for that particular year. Coming to the pandemic influenza phases, there are phase 1 to 3, when the infection is predominantly animal infection, few human infections are reported. It becomes phase 4 when there is sustained human to human transmission. Phase 5 and 6 is the pandemic, which is a widespread human infection. Post-peak is possibility of recurrent events, and post-pandemic is disease activity which remains at seasonal level, and the H1N1 influenza virus is in post-pandemic stage. In antigenic variation of influenza virus, there can be genetic drift or there can be genetic shift. In genetic drift, there are antigen variants that are similar to the old strains, and there is some immunity from previous strains, which cause seasonal influenza outbreak and small epidemics. Whereas in genetic shift, that is a completely new antigen makeup and no immunity from previous strains, and that leads to major influenza pandemic like novel H1N1 that occurred in 2009. Now coming to influenza and pregnancy, why we as obstetricians are so much concerned for influenza. The risk of morbidity and seasonal influenza is higher among pregnant women. During pregnancy, healthy women have a 4 to 5-fold increased risk of serious illness and hospitalization with this problem. Mortality also appears to be higher in pregnant women, especially if infection occurs in the 3rd trimester. So whenever a pregnant woman develops influenza in 3rd trimester, we should become very careful and take proper care. What are the pregnancy-related complications of this infection? There can be non-reassuring fetal testing in CTG, febrile morbidity, a spontaneous abortion can occur, there are more chances of premature rupture of membranes, and any hyperthermia because of H1N1 in early pregnancy has been found to be associated with neural tube defects and other congenital anomalies. Whereas fever during labor and birth is a known risk factor for neonatal seizures, newborn encephalopathy, cerebral palsy, and even neonatal death or intrauterine fetal death. Risk of pregnancy, but there was a paper published from that says that risk of pregnancy complications and adverse birth outcomes after maternal H1N1 influenza was not very much, they did not find too much of risk. The only problem they got was that there was reduced weight of fetus at the time of birth. So that this paper was quite reassuring, and it was a Norwegian paper, and they had studied this disease on a large number of population. What are the clinical presentations? Symptoms commonly develop within 1 week of exposure. Patients are contagious for approximately 8 days thereafter. Symptoms of acute respiratory illness in the form of cough, sore throat, rhinorrhea, and fever do happen. Systemic manifestations are headache, fatigue, body ache, vomiting. Complications, the patient can develop secondary bacterial infection such as pneumonia. Most pregnant women luckily will have an uncomplicated course, but there have been reports of adverse pregnancy outcomes even including maternal deaths. In the epidemic, lot of maternal deaths occur because of the complications of this H1N1 influenza. In this H1N1 virus infection, the systemic manifestations can come from fever, lethargy, loss of consciousness, running nose, sore throat, coughing, nausea, vomiting, and diarrhea. These are almost swine flu or swine influenza or the H1N1 virus is a disorder of basically of respiratory system that is caused due to influenza virus in pigs with resultant decreased appetite, lethargy, and barking cough. Rest of the symptoms are rare. We should be able to differentiate any respiratory tract infection from common cold. So common cold and H1N1 flu has got several differences. In common cold, the symptoms usually develop over a few days, whereas in flu have rapid onset within 3 to 6 hours. Headache is uncommon in common cold and headache is very common in H1N1 flu. Stuffy nose is common in common cold. It is uncommon in flu. Sneezing is common in common cold and sneezing is uncommon in flu. Sore throat is common, which is uncommon in H1N1. Hacking productive cough is often present, but in flu it is usually present. Fever is rare in common cold. Fever over 100 degree or greater is present for 3 to 4 days in H1N1 flu. Chills are uncommon. Chills are common in flu. Chest discomfort is mild to moderate in common cold. It is quite severe in flu infection. Slight body ache occurs in common cold, whereas there is severe body ache and pains are very common in flu infection. Fatigue after common cold is very mild, whereas in flu, fatigue is moderate to severe most of the time. So we should be able to differentiate between the two because both are quite common, and we should be initially able to differentiate a common cold from flu, and we should become alert if think clinically that the woman is having a flu infection. Diagnosis is basically made on clinical symptoms, but rapid influenza antigen test is commonly used in patients who are suspected of having influenza. It allows rapid viral detection in nasopharyngeal secretion, although sensitivity is low. Confirmation of the case can be done by RT-PCR. Diagnostic tests are best performed within 72 hours of onset of illness, as viral shedding is greatest at that time. CDC definition of novel H1N influenza is confirmed case in individual with an influenza-like illness and laboratory confirmed H1N1 influenza A either by RT-PCR or culture. Probable case is individual with an influenza-like illness who is positive for influenza A by RT-PCR but in whom the strain of infection has not been determined. However, treatment should not be delayed pending the laboratory test. So clinically, if you think it is H1N1 flu, then you should start treating the patient. The general principles of management are, general recommendations are to rest, drink adequate fluids, take adequate sleep and healthy diet. Symptomatic treatment should be given with paracetamol and antitussives. Oxygen saturation should be monitored in moderate to severe cases. Low SpO2 demands oxygen supplementation after hospital admission. Routine blood tests, CBC, LFT, KFT, and X-ray chest may be needed in moderate to severe cases. Antiviral medication should be started on clinical suspicion without waiting for the laboratory reports. Warning symptoms in which the patient needs hospital admission in ICU are temperature above 100 degree Fahrenheit or more, which is persistent. Significant pulmonary sign and symptoms, tachypnea, shortness of breath, oxygen saturation less than 94%, maternal tachycardia more than 100 beats per minute, maternal medical comorbidity like asthma, diabetes, HIV, autoimmune disorders, and any complication of influenza in the form of pneumonia, myocarditis, secondary bacterial infection needs ICU admission. Persistent nausea and vomiting also indicates seriousness of the disease. And all these patients should be admitted in intensive care unit. Antiviral medication, all pregnant women should be regarded as high risk and should be treated with antiviral drugs. The treatment of choice is oseltamivir 75 milligram twice daily for 5 days or zanamivir 2 to 5 milligram inhalations twice daily for 5 days. This is a category C drug, but depending upon the seriousness, this is considered to be safe in these patients. No adverse events have been reported to date among pregnant women who receive these agents. Should ideally be started as soon as possible after the onset of symptoms. Benefit is greatest if started within 48 hours of onset of symptoms. Acetaminophen should be given if the patient is febrile to bring down the temperature. Coming to the isolation, we have learned a lot about isolation in the COVID era. So any suspected case of H1N1 should wear a face mask and be placed in an isolated room. Confirmed cases should be placed on droplet precautions, gowns, gloves, and N5 respirators. And when aerosolization of droplet is possible, like if the patient is receiving a nebulizer treatment or being intubated, goggles should also be worn. So I'm not going to detail all these. All these have been talked a lot in COVID management of the patients. So this graph shows management of a case of H1N1 infection in pregnancy. Place a face mask on the mother, place the mother in an isolated room with droplet precaution, order a direct immunofluorescent antibody to see if the strain, which strain is present. Consider starting empirical oseltamivir therapy, 75 milligram twice daily. If she is H1N1 positive, initiate droplet and contact precautions, use goggles. No need to take the patient in a negative pressure room. Continue the antiviral therapy and isolate mother from infant immediately after delivery. If she is H1N1 negative in her test, then if the exposure is still confirmed, then one should continue the chemoprophylaxis for 5 days. If no exposure is confirmed and she is negative, then the therapy should be discontinued and no further treatment is needed. How can we prevent mother to child transmission? If a pregnant woman delivers while infected with H1N1, she should be separated from an infant immediately after delivery. Close contact of infant to mother should be avoided until she has been on antiviral medication for at least 48 hours. Her fevers have resolved and she can control her coughing and secretions. She should continue to practice good hand hygiene and cough etiquettes and wear a face mask for the next 7 days. Breastfeeding is known to strengthen the neonatal immune response, and infants who are not breastfed may actually be more vulnerable to viral infection, and the risk of transmission of novel H1N1 through breast milk is unknown. Reports of viremia or seasonal flu are rare. It seems highly unlikely that this virus will cross into the breast milk. So they can continue breastfeeding while on chemoprophylaxis, while taking complete care of any droplet transmission, wearing a mask and doing the hand hygiene, and after feeding, the baby should be separated from the mother. Chemoprophylaxis is not a contraindication for breastfeeding. Post-exposure prophylaxis should be considered for pregnant women with close contact to a suspected or confirmed case of H1N1 infection. Zanamivir or oseltamivir should be given for prophylaxis also, and it should probably be continued for 10 days after the last known exposure, and close monitoring for influenza symptoms should be done. Primary prevention should be done by vaccination, and vaccination is the primary method to prevent influenza, and luckily a safe good vaccine is available and it is being given, and it is also recommended by the FOXI, and I think now influenza vaccine is given routinely to all the pregnant women. Efficacy of each year a new formulation of influenza vaccine is formulated, which I just now have talked about, consisting of 2 influenza A subtype and 1 or 2 B subtype. Efficacy of influenza vaccine is variable depending on how well vaccine antigen correlate to the present circulating antigen in the community. Inactivated influenza vaccine is recommended in pregnancy should be given to all pregnant women, can be given in any trimester. Vaccinated mothers also provide passive immunity to the neonate, which is very important. So in H1N1 influenza, prevention is the best cure, and we should try to prevent it by vaccinating all of our women during pregnancy against influenza H1N1 virus. Thank you very much for the patient hearing.
Thank you very much, Dr. Anita ma'am. It was really a wonderful, informative session about H1N1. All the slides were really beautiful, especially the differentiating points between the common cold and the swine flu. It was absolutely fantastic. Thank you very much, ma'am.
Any question? No. Okay, now we'll move on to the next lecture, and the next lecture is pregnancy with pregnancy with chicken pox. Dr. Kalyan Barmade. I present to you an eminent faculty from the field of infertility and from Maharashtra. He is the chairperson, Public Awareness Committee, FOXI. He is a treasurer, IAG, and member, NSR. He is a senior IVF consultant from Latur, Maharashtra, having 2 centers, one in Hyderabad, and chairperson for all Maharashtra State Conference in coming August. I welcome my younger brother, Dr. Kalyan Barmade.
Thank you, Chairperson, for such a nice introduction. All esteemed delegates and faculties, I'm really grateful to talk on a topic in this esteemed conference of ICCOB. So that is pregnancy with chickenpox. Varicella zoster virus is highly contagious DNA virus of herpes family. Why we are worried about chickenpox in pregnancy is if the patient is not infected prior, there are complications during the pregnancy. The complications are more if it happens in the last trimester and during the period of delivery or cesarean section. And secondly, the fetal varicella syndrome is really going to be a problematic for the fetus. Also, it happens during the second trimester, there can be a fetal varicella syndrome. That is why we are going to have a look about this chickenpox in the pregnancy. It is transmitted by respiratory droplets and by direct personal contact with the vesicular fluid. The primary infection is characterized by fever, malaise, pruritic rash that develops into crops of maculopapules which become vesicular and crust before healing. The incubation period is supposed to be 10 to 21 days, and the disease is infectious 48 hours before the rash appears. That is why the screening of the contact people is very important wherever a chickenpox patient is found in the home, which continues to be infectious until the vesicles crust over. Chickenpox or primary varicella zoster infection is a common childhood disease. In this population, it usually appears as a mild infection, and mortality rate in a developed country like United States is just 0.4 per 1 million population. So it is estimated that more than 90% of the antenatal population are seropositive for this infection and IgG antibody, and therefore almost invariably immune to the infection. Because of the high frequency of immunity, contact with the chickenpox among pregnant women rarely results into a primary maternal infection, which is estimated to complicate up to 2 to 3 of every 1,000 pregnancies. So, following the primary infection, the virus may remain dormant in the sensory nerve root ganglia, but can be reactivated to cause vesicular erythematous skin rash in a dermatomal distribution known as herpes zoster or shingles. As shingles in pregnancy is not associated with the viremia and doesn't appear to cause fetal sequelae. So, Everybody knows this. Primary infection is fever, malaise, and pruritic rash. During pregnancy, illness is though rare, but it is very severe if it occurs, and if it has not occurred in the childhood, it can cause pneumonia, encephalopathy, myocarditis, and hepatitis. That is why if it occurs in the late third trimester, there can be a thrombocytopenia, there can be associated hepatitis and cause postpartum hemorrhage. That is why a delivery should be avoided as far as possible during the active infection. So everybody knows this incubation period. The person is infectious 48 hours before the rash appears. That is very important, and it continues to be infectious until the vesicle crust, or typically 5 days. Why we are worried is period of gestation where infection is there. So during 7 to 28 weeks of gestation, it can cause fetal varicella syndrome. 1 to 28 weeks, neonatal or childhood herpes zoster. 2 weeks before delivery, it can cause neonatal chickenpox. 5 days before or after delivery can cause neonatal disseminated chickenpox with septicemia with increased mortality. That is why we are worried of chickenpox in pregnancy. Now these are RCOG recommendation, that is Green Top Guidelines 2015, which says the possible sequelae of varicella infection in pregnancy, we are divided into maternal, fetal. So in maternal, the mortality rate for chickenpox increases with age. Thus in early adulthood is associated with mortality rate that is 15 times higher than the childhood mortality. And the case fatality rate increases from 2.7 per lakh persons aged between 15 to 19 years to 25.2 if the age increases between 30 to 39 years. It is estimated that 5 to 10% of the pregnant women with a varicella infection develop pneumonitis. The risk factors of development of varicella pneumonitis in pregnancy includes cigarette smoking, and if you count the lesions, if there are more than 100 lesions over the body, then it is supposed to be more infectious, can cause pneumonitis, and chances of severe infection is there. So most of the complications of adult childhood, such as pneumonitis, occur on day 4 or later of the infection. On one of the prospective study which is done, 12 out of 21 pregnant patients who were diagnosed with varicella pneumonitis and treated by acyclovir in second and third trimester required intubation and mechanical ventilation. That means if it occurs in the late, it can cause morbidity as well as mortality. The strongest correlation with the maternal death was onset of disease in the third trimester with no deaths among the second trimester of the subject. So now we'll come to the possible sequelae of varicella infection in fetus. Fetal effects can manifest as either congenital varicella syndrome, that is embryopathy, or neonatal varicella, that is no embryopathy but chickenpox infection within the first 10 days of life. So maternal varicella during the first of pregnancy may cause congenital malformation or deformations by transplacental infection or spread. Manifestation may include chorioamnionitis, cerebral cortical atrophy, hydronephrosis, cutaneous and bony and long defects, often presenting as partial limb reduction. Most of the studies, it is found that no clinical evidence of congenital varicella embryopathy if it occurs after 20 weeks of gestation. So, fetal risk is gestational dependent. In the first trimester, it might lead to spontaneous abortions. 3 to 28 weeks, fetal varicella syndrome. 1 to 2% until 20 weeks, and 20 to 28 weeks, rapidly declining incidence of fetal varicella syndrome. And after 28 weeks,
there are no cases of fetal varicella syndrome. So it is totally gestational dependent, and we have to know in which trimester the disease has been caused. So fetal varicella syndrome, it doesn't occur at the time of initial fetal infection, but results from a subsequent herpes zoster reactivation in utero and only occurs in a minority of infected cases. So what is fetal varicella syndrome? They are characterized by one or more of the following, that is skin, eye and skeletal deformities, skin scarring in dermatological distribution, eye defects, that is microphthalmia, chorioretinitis and congenital cataracts, hypoplasia of the limb, and neurological abnormalities like microcephaly, cortical atrophy, mental restriction and dysfunction of bowel and bladder sphincters. So common manifestation to diagnose is limb deformity, microcephaly, hydrocephaly and soft tissue calcification. Sometimes a diagnosis of IUGR can be retrospectively gone to fetal varicella syndrome. Diagnosis is always ultrasound finding with the clinical features of fever and rash in the body. Women with developed chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks of gestation or 5 weeks after infection for discussion and detailed ultrasound examination. There is usually a time lag of at least 5 weeks after the primary infection before the fetal differences are seen. What I mean is, at least after 1 month, you should screen this by ultrasound to detect certain features like hydrocephalus, ventriculomegaly, asymmetrical limb shortening, or even congenital cataract. Ultrasound include musculoskeletal abnormalities seen as asymmetrical limb deformities. Cerebral anomalies with ultrasound can be diagnosed very well by a routine gynecologist or an ultrasonologist, and congenital cataract and microthermus are more common ocular lesions but are not readily visible on ultrasound by a routine scan. That is why a consultation with fetal medicine expert is necessary in these patients. We need to do amniocentesis every time, should not be performed before the skin lesions have completely healed. It can be performed to confirm the diagnosis with PCR identification of VZV DNA, and in the absence of ultrasound findings, positive amniocentesis has a high sensitivity but low specificity for the development of VZV infection. If the PCR is positive but the ultrasound is normal at 17 to 20 weeks, risk of fetal varicella syndrome is low. If repeat ultrasound is done at 24 weeks, also normal, then the risk of FVS is almost zero. So the risk conversely is very high if there are ultrasound features and positive PCR, then only amniocentesis may be recommended. The last is a peripartum exposure. Exposure of the baby to the virus just before or during delivery poses a serious threat to the neonate, which may develop a fulminant neonatal infection, that is neonatal varicella. Rarely these neonates can develop disseminated visceral and central nervous system disease, which is commonly fatal for this fetus. Neonatal infection occurs primarily when symptoms of maternal infection occur less than 5 days before delivery or 2 days after the delivery. This period correlates with the development of maternal IgG and is therefore too short a period to provide transplacental passive immunization to the fetus and neonate. When varicella zoster immunoglobulin is administered to the mother, 30 to 40% of newborns still develop infection. However, the number of complications are reduced. That is why immunoglobulin proves to be beneficial for fetus. Prevention of maternal complication. Oral acyclovir was shown to be more effective than placebo in reducing the duration of fever and symptoms of varicella infection in immunocompromised children and immunocompetent adults if commenced within 24 hours of development of rash. As a result, it is generally recommended that children at a high risk and adults with substantial varicella infection, that means more than 100 lesions on the body and or respiratory cofactors, should be treated with oral acyclovir. Pregnant women with varicella pneumonitis should be definitely treated with antivirals, and if level of illness warrants, they can be treated with IV antivirals also. How we are going to prevent intrauterine infection? For that, definition of significant exposure is important. Direct contact exposure is defined as a direct contact that lasts an hour or more with an infectious person while indoors. Substantial exposure for hospital contacts like health workers sharing the same hospital room with infectious person, direct or face-to-face contact with an infectious person. Brief contacts with an infectious person, that is during X-ray or way, can result in VZV transmission, and person with continuous exposure to household members who have varicella are at a greater risk of infection. The prevention is always vaccine and immunoglobulins. Vaccines are attenuated live vaccine was approved use in 1995. 2 doses given at 4 to 8 weeks apart are recommended for adolescents more than 13 years of age and for adults with no history of varicella. So this results in 97% of seroconversion. The vaccine, however, is not recommended for pregnant women or those within a month of pregnancy. But if accidentally a vaccine is taken, do not do a termination of the pregnancy, because few studies have shown that there are no deleterious effect on the fetus. So comes the most important saver of the pregnant women is immunoglobulins, that is varicella zoster immunoglobulin. As prevention is the most important strategy for the reduction of the maternal complication associated with varicella infection, immunoglobulin prophylaxis is an important objective for susceptible exposed pregnant women. It is shown to lower varicella rates if administered within 72 to 96 hours of exposure. The effectiveness of immunoglobulin when given beyond 96 hours after initial exposure has not been evaluated. The protection is estimated to extend for 3 weeks, which correspond to the half-life of immunoglobulin. The principal indication for use in pregnant women is reduction in the maternal risk of varicella associated complication with the adult disease, and if mother doesn't acquire varicella infection, this eliminates the risk of neonate, but this has been not studied as an endpoint because of the low frequency of cases. The dose is 125 units per 10 kg given intramuscularly with maximum dose of 625 units. It is recommended for all susceptible pregnant patients. So to determine if exposed pregnant woman is susceptible, a history of varicella infection should be taken, and if this positive, the woman is assumed to be immune, there is no need of giving this. If the history is negative and no varicella antibody testing was done in early pregnancy, then you should go ahead with the immunoglobulin. However, in settings where pregnant women might be tested too late or results may not be available quickly in the rural population, using these immunoglobulins before antibody testing results are available might be a more practical approach for these women. The treatment, definitive treatment is antiviral. This is acyclovir, is synthetic nucleoside analog that inhibits the replication of H virus, and it crosses the placenta readily and can be found in fetal tissues, cord blood as well as amniotic fluid. It may inhibit viral replication during the... Which are the patients which need referral? The pregnant women with chickenpox should be asked to contact doctor if there are respiratory symptoms, and secondly, any other deterioration in her condition. That means papules more than 100, fever not residing with paracetamol. These are the patient who needs a care, and these are patient which should be referred to the hospital. Once this patient comes to the hospital, in hospital assessment in area where she will not come into contact with other ANC patients, and there should be always multidisciplinary approach with an obstetrician, ultrasound or fetal medicine expert, virologist and neonatologist. She should be nursed in isolation from other babies, potentially susceptible women or non-immune staff. The delivery, the timing and mode must be individualized. When epidural or spinal anesthesia is undertaken, the site should be free of cutaneous lesion, should be chosen for the needle placement. If maternal infection occurs in the last 4 weeks of women's pregnancy, there is a significant risk of varicella infection in the newborn. A planned delivery should normally be avoided for at least 7 days after the onset of maternal rash. Allow for the passive transfer of antibodies from mother to child, provided that continuing the pregnancy doesn't pose any additional risk to the mother or baby. Mind you, there are so many times with this high fever patient, the NST will be always non-reactive or equivocal. So you need to do obstetric Doppler to decide whether she needs an urgent delivery or not. A neonatologist should be informed at the birth of all babies and should be given immunoglobulin at birth. Breastfeeding, if they wish to and are well enough to do so, an express breast milk should be done if there are lesions on the breast tissue. So to summarize, varicella immunization is recommended for all non-immune women as a part of pre-pregnancy and post-pregnancy care. Level 2 guidelines, varicella vaccination should not be administered in pregnancy. However, termination of pregnancy should not be advised because of inadvertent vaccination during pregnancy. The antenatal varicella immunity status of all pregnant women should be documented by history of previous infection, varicella vaccination or varicella immunoglobulin given or not. All non-human pregnant women should be informed of the risk of varicella infection to themselves and their fetuses. They should be instructed to seek medical help following any contact with a person who may have been contagious. In the case of possible exposure to varicella in a pregnant patient with unknown immune status, serum testing should be performed. If the serum results are negative or unavailable within 96 hours, varicella zoster immunoglobulin should be administered. Women who develop varicella in pregnancy need to be made aware of the potential adverse maternal and fetal sequelae, risk of transmission to the fetus, and option available for prenatal diagnosis. Detailed ultrasound and appropriate follow-up is important. These patients who develop pneumonitis should be treated with oral acyclovir 800 milligram 5 times a day daily, and if they become serious, they can be given IV immunoglobulin. Neonatal healthcare providers should be informed of the peripartum varicella exposure in order to optimize early neonatal care with varicella zoster immunoglobulin. Immunoglobulin should be administered to neonates whenever the onset of maternal disease is between 5 days before and 2 days after the delivery. I'm really thankful to the chairperson and organizers for giving me this opportunity. Thank you so much.
Thank you, Kalyan bhai. Basically, viruses are very mischievous, we know. And in the reproductive age group, the viruses create more problems. I have heard so many lectures from physicians also about the chickenpox, but yours was the best lecture. You have taken all the care of completing each and every corner of the concerned part of the lecture. Thank you very much.
Thank you, sir.
Hello, Kalyan, I want to add something. We never talk about the cosmetic complication of this disease. You must be remembering one name, Chairpersons. That was only because of this varicella. So I would really add that every girl should be like advised about this vaccination, because not only this kind of the complications, but many girls they must be facing, or many boys also they must be facing this kind of complication. I mean the cosmetic complications. Because
so that is why it is being recommended to give vaccination after 13 years of age. Thank you so much.
Committee you should recommend. And one more, that in reproductive age group they create sperm count less. That is again
history of chickenpox in pregnancy. There are some patients we've seen with azoospermia also. Yes, ma'am. Yes, it is available, ma'am. Okay, I'll make the MR contact you, ma'am. Thank you, ma'am.
Very good. So now we have come to the last talk of this session, and the speaker is none other than Dr. Nita Thakre, and she'll be talking on recurrent UTI during pregnancy. Usually, recurrent UTI in pregnancy requires prophylactic treatment, and pregnant women with urinary group B streptococcal infection should be treated so as to receive intrapartum prophylactic therapy. And I am privileged to introduce Dr. Nita Thakre, Madam. She is West Zone Coordinator, FOXY 2020, Chairperson, FOXY Urogynec Committee 2017-19, Honorary Joint Secretary, AOGS 21-22, and has a special interest in urogynecology, high-risk pregnancy, and gynec endoscopy. So the stage is yours, Madam. Now you can start your presentation.
Thank you, Dr. Pratibha.
We on behalf of all chairpersons, I welcome you in your line only.
Thank you so much. So, thank you all the chairpersons, and that introduction was a formality. Of course, you have to do it, but thanks so much. Topic given to me is UTI in pregnancy, and how important it is we need to understand. The common medical complication of pregnancy is very common as UTI, and that's why we need to give due importance to it. During pregnancy, when UTI occurs, it is usually associated with preterm delivery, IUGR, Preeclampsia, and cesarean delivery. So, let us understand the guidelines which are derived. The commonest three types of urinary tract infection are asymptomatic bacteriuria in pregnancy, acute cystitis in pregnancy, and acute pyelonephritis in pregnancy. And these three are according to the graded severity. So if we consider the incidence, asymptomatic bacteriuria occurs in almost 2 to 18.5% of pregnancies. The cystitis is almost 1.3% of all pregnancies, and pyelonephritis occurs in almost 1 to 2% of pregnancies. So asymptomatic bacteria being the commonest reason of UTI, and most commonly during the second half of the pregnancy, this can occur at any stage of pregnancy. So what are the etiological factors? The commonest organism is E. coli, as we all know, due to the proximity of stool area from the genital area, and almost 80 to 90% of the cases which originates from fecal flora, which colonizes the periurethral area and then causing the ascending infection. There can be other pathogens like Klebsiella pneumoniae, Proteus mirabilis, Enterobacter species, Staphylococcus saprophyticus, Group B beta hemolytic streptococci, and Proteus as well. And rarely we do see candidial as well as mycoplasm, ureaplasm, urothelium, and chlamydial infection as well. So what are the predisposing factors? Anatomic and physiological changes that are occurring in the urinary system during pregnancy. That is the commonest predisposing factor. VUR, vesicourethral reflux, increased PFR and GFR, increased uric acid and calcium extraction, maternal urea, creatine and blood urea nitrogen is 25% lower than non-pregnant patient, and occasional patient develops glycosuria and proteinuria. That can be also one of the reasons. And sometimes because of increasing abdominal girth, patient is unable to maintain hygiene. That can be also very commonly found. Risk factors. So what are the risk factors? Frequency of intercourse and sexual behavior of the couple. Intercourse can traumatize the urothelium, and then the distal urethra is affected and vagina can become the reservoir, and from there the infection can be spreaded. So how do you diagnose? When there is a presence of more than 1 lakh colony count in one or more of uropathogens in 2 consecutive midstream urinary sample or 1 catheterized urinary sample, in absence of symptoms which are attributable to the urinary tract infection. So patient is not having any symptoms, but her urinary analysis by culture is showing more than 1 lakh colony count. So when would you screen? According to NICE guidelines, you should be doing screening of all the pregnant women at 10 weeks of pregnancy. So all the pregnant women should be offered culture test at 10 weeks of pregnancy, and all pregnant women must be screened for asymptomatic bacteria in first prenatal visit according to our Indian practices, because you won't find them coming again. You might not be able to find them coming again. So it's good to check. Though we are not doing routine culture examination, but it's always advisable according to grade A level of evidence. And the standard urine culture of clean catch midstream urine is the test of choice. You don't have to catheterize them always. In areas where urine culture, if it is not available, what would you do? So what would you do? You have to have a gram stain of centrifugal urine sample, and if there is more than 6 to 12 bacteria seen per high power field in that centrifugal sample, or if it is positive, then must follow the urine analysis to determine the pyuria. So what is the cutoff value for every woman? Centrifugal sample, gram stain, and if it is more than 5, that is 6 or more, is the cutoff value. So there is now dipstick available which can tell us about the whether the patient is having infection or not, which is cheap, very rapid and easy, but its sensitivity is 50 to 90% and its specificity is 83 to 94%. But still, as per the recommendation, it is not recommended for screening for bacterial UTI at the first or subsequent antenatal visit. But according to me, for all practical purposes, if one doesn't have a facility of culture or if patient is not affording, then you may offer dipstick so as to at least screen in our Indian circumstances. So what are the other tests that you offer? You must do CBC and ESR. If we want to rule out acute pyelonephritis, then go for procalcitonin levels, and of course ultrasonography, just to find out if patient is having any urolithiasis or any other abnormality of kidney or bladder or ureter, so as to guide her properly. In small Turkish study, what was found that the incidences were gradually seen increasing during first, second and third trimester. So it is suggested that those who don't have bacteria in first trimester may develop it during later trimester. So it is always good to screen them in second and third trimester as well. What are the high risk groups? Pregnant women who can have the infection, they are the one who had history of asymptomatic bacteria or recurrent UTI, those who are having renal calculi, pre-existing renal diseases, diabetes, low SE status, and those who are on immunosuppression. And antibiotic prophylaxis is recommended for them, and one must rule out vaginal infection in all of them. So how would you treat her? So antibiotic treatment for asymptomatic bacteria is indicated to reduce the risk of acute further spreading of the disease, like she having acute cystitis or pyelonephritis in pregnancy. And also we must treat them because we want to reduce the risk of low birth weight neonates and preterm infants. So what are the treatment options? Antimicrobial treatment of first choice is nitrofurantoin, which is given 100 milligram 12 hourly for 7 to 10 days. But it should be avoided near term. The second choice, of course, is cephalosporin group of antibiotics, and plain cephalexin 500 milligram 8 hourly for 7 days can do the trick. Phosphomycin, of course, the new molecule in horizon, is very, patient friendly because a single dose can do the job, and that is 3 grams to be given at night time after she voids the urine, and you must tell them that she should hold the urine and she should not void throughout the night. Amoxiclav also can be given, and of course cotrimoxazole, but it should be avoided during first and third trimester. But according to Cochrane review, it is seen that one-day regime, that is phosphomycin, is not that effective, or it is less effective than 7 days regime. So how would you do the follow-up? In asymptomatic bacteria in pregnancy, we should have periodic screening after the therapy, as 1/3 of them will experience recurrence. Follow-up culture in 1 to 2 weeks after the treatment and repeat them every month. Subsequent treatment courses are given until the bacterial count becomes non-significant, and women on antibiotic prophylaxis, follow-up urine culture should be done at the beginning of third trimester, and according to culture report, we must treat them. What would you do to prevent infection? Postcoital prophylaxis should be considered in pregnant women with history of frequent urinary tract infection before pregnancy. According to Cochrane review, close monitoring and daily dose of nitrofurantoin combined with high clinical attendance rate was associated with significant reduction. So NFT is a drug of choice. Non-pharmacological interventions like cranberry juice, cranberry tablets, acupuncture, probiotics, and behavioral modification also should be offered, and tell them to not have excessive water or less amount of fluid intake and maintain hygiene. So how do you do the follow-up? Do follow-up cultures once a week after completing the course, and when you suspect acute cystitis in pregnancy, when she transformed from asymptomatic bacteria to when she starts having urinary frequency, urgency, dysuria, bacteria without fever, and costovertebral angle tenderness. And sometimes you may see that they start having gross hematuria as well. And in pregnant women suspected to have acute uncomplicated cystitis, we must do culture sensitivity of their midstream clean catch sample. And if you do not have a culture sensitivity facility, then what you can offer is a presence of significant pyuria, that is more than 8 pus cells in uncentrifuged urine sample, or more than 5 pus cells in centrifuged urine sample, or a positive leukocyte estrase or nitrate test. So when one thing is not available, we have to somehow help the patient by offering these methods. And I think in every corners of India, at least we can offer her to have routine centrifuge sample and estimate of pyogenic bacteria seen in the simple slide method. Treatment of acute cystitis in pregnancy should be instituted immediately to prevent the spread of infection further to the kidneys. And what you do, same as the E. coli are the most common, that nitrofurantoin is the treatment of choice. As I have already mentioned previously, these are the treatment options: nitrofurantoin, cephalexin, then fosfomycin, amoxiclav, and cotrimoxazole. But you have to make sure that cotrimoxazole and nitrofurantoin should not be offered in third trimester, and also cotrimoxazole should not be offered in first trimester as well. Sometimes you may offer them a 7-day course rather than fosfomycin in 1-day course. In the absence of urine culture sensitivity, one can start empirical treatment, antibiotic treatment, based on local susceptibility. And most commonly, you are suspecting her to have a E. coli infection. And once, in case where there is a result of urine culture which shows that organisms are resistant, but patient is clinically improving, there are circumstances when you see such things, right? So should the antibiotic be changed, or you should continue with the same, or change it to according to susceptibility? So one option is adjust the antibiotic according to culture sensitivity, or you can repeat the culture, and if culture is sterile, then continue the same antibiotic. But if the culture shows the same bacteria, then switch according to culture sensitivity. So don't get confused, rather continue or change it to other according to repeat culture. And post-treatment urine culture should be obtained to confirm the eradication. That is not recommended very strongly because the level of evidence is grade C. Pregnant patient, and in India, of course, we cannot afford, our patients cannot afford the repeat culture again and again. So according to her betterment or course of illness, you can tell her to get infection, means culture test done again or not. If the pregnant patient with pyelonephritis, recurrent UTI, concurrent gestational diabetes, and concurrent nephrolithiasis or urolithiasis and preeclampsia, they all should be monitored at monthly interval until delivery to ensure that urine remains sterile. And when you will suspect acute pyelonephritis, when the same patient starts having chills, fever, flank pain, nausea, vomiting, with or without signs and symptoms of lower urinary tract infection, and physical finding of costovertebral angle tenderness, she should be rather admitted. You have to see the urine analysis, more than 5 WBC counts, and bacteria of more than 10,000 colony of the uropathogen per ml of urine. Then you must suspect acute pyelonephritis. And what would you do? Gram stain of uncentrifuged urine is recommended to differentiate gram positive from gram negative. So you can start empirical treatment according to gram positivity or gram negativity. And once you receive the culture, it should be performed, and then you have to look into the options available according to the culture sensitivity and start the antimicrobial agent, because of the potential sequel which can be serious for the patient as well as baby. And blood cultures are not routinely recommended for these patients, and all pregnant women with acute pyelonephritis should be hospitalized, and immediate antimicrobial therapy should be instituted, and the treatment should be given for at least 10 to 14 days. And any of the antibiotics for acute uncomplicated pyelonephritis can be used except fluoroquinolones and aminoglycosides, which are relatively contraindicated in pregnancy, and in absence of urine culture and sensitivity, empiric treatment can be started according to geographical predisposition. And for pregnant patient with no sign and symptoms of sepsis, and if you're able to take medication by mouth, she can be offered to have a outpatient treatment as well. Post-treatment urine culture again should be done to make sure that the infection is eradicated. Thank you so much for patient hearing. And if there's any question, you can ask. Yes, sir.
Hello. Madam, you just said that according to Cochrane review 2011, fosfomycin is not much effective, but my experience is something different. Maybe the patients, obstetrics patients especially, they are getting increased frequency of the maturation, and that's why they may not be getting the proper effect of fosfomycin. So what I do in my practice, I recommend these alkaline mixtures and anti-inflammatory drugs for 2 or 3 days, and later on after 2 or 3 days, then I advise them to take the fosfomycin, and they should try to avoid the voiding of urine for the maximum time. 4 to 5 hours. 100% fosfomycin is one of the very magical drugs.
One more thing I would like to add here is add lactobacilli, because many of the fosfomycin taking patients do complain of diarrhea.
Exactly.
So the compliance is then reduced if we have to repeat the dose after 3 days.
Right.
Sometimes if there's a recurrence or you feel that the symptoms are not completely gone, you can repeat the dose after 3 days. Same dose, single dose at night to be taken after voiding in 100 ml of water, and restrict the fluid intake from 7 p.m.
Exactly.
So these are the basic instruction you pass on. And I think fosfomycin being a new drug, there is a gradual evolution happening.
Right.
And maybe the patients and doctors are getting used to it.
Yeah, and combination of nitrofurantoin with this fosfomycin is
wonderful. Yeah. Sometimes you would give fosfomycin as first choice and then continue nitrofurantoin as a OD dose for chemoprophylaxis. That is also another option.
Yeah, thank you.
Yeah. Yes.
Maybe some irrelevant thing, but the Septilin, which is an Ayurvedic drug, is also useful. I find it in my practice.
Which one?
Septilin from Himalaya company.
Yeah, Himalayas,
Immunity booster.
Yes, sir. Yes.
Ma'am, what should be our approach if a patient comes to us with retention of the urine with frequent UTI? With frequent urine.
So you have to find out first why she retains, the reason. Acute antiversion of uterus during pregnancy in initial years can be, a reason for till the uterus becomes an abdominal organ. So it is little acutely antiverted, and that's how, or maybe the retroverted gravid uterus, which is kinking the urethra. That can be the reason. So you can advise her the positional change while voiding.
So, yes, ma'am, that is a common cause we have ruled out. But I've seen 2 cases. A patient lady comes to us with retention of the urine because of the UTI, and in culture sensitivity also it was found the culture was positive. We have given him therapy depending based on that culture sensitivity. But again, after 2 to 3 months, she came back with retention of urine because of that UTI. So
that's why I suggested the literature suggests, not me, that you have to do the repeat culture every month and advise her chemoprophylaxis as well. So nitrofurantoin 1 OD at bedtime can do the job, and she can be avoided having repeated acute flare-up of the infection, and as you say, must be having cystitis. So you have to treat her at least for 7 to 10 days initially, if whatever is the drug of choice according to culture. Okay. Yeah. Yes, ma'am. Not as frequent, like the way it is prescribed, because the alkalizer can be sometimes even harmful. So alkalizer should not be prescribed in all the patients. No literature suggests the use of alkalizer.
Can I comment on the doctors, young doctors,
Yes, sir.
Doctor?
Yes, ma'am.
See, whenever you say that retention and urinary tract infection, they can never go together. Usually urinary tract infection has a frequency of micturition. So when there is a retention, you have to find out what is the cause of the retention. Then only you can say that it is with that. Other urinary infection is always with the frequency. And secondly, what I do in a practice is that at least you give, if patient is having repeated urinary tract infection after doing culture, instead of doing culture every month, I do the 3 doses, 10 doses of, 10 days doses of 3 monthly, consecutively month. And they really work well.
Work well, yeah. So that would be an empirical treatment, what madam was suggesting, that just you give. But one more thing I would like to tell is that if there is a retention, that means she is having dysfunctional voiding. So you have to find out the cause of, maybe she is contracting because of that pain she is getting during micturition. So she is contracting her pelvic muscles, and that's why she is not passing off completely, and that's why she is retaining. And so you must treat her how to void, without doing a Valsalva. Usually, ideally one should relax the pelvic floor and then void. Rather, they, in fear of getting pain, contract and then they void with a pressure. They obtain abdominal pressure. So advise them, and if you find them that they are doing that, then you have to correct them. Yes, sir.
Recurrent urinary tract infection can long-term lead to stricture of the urethra.
Yes,
that
sir.
also should be kept in
Yes.
mind. So there is surgical requirement.
Yes, sir. Thank you, sir.
Thank you very much, Neeta ma'am. UTI is one of the very unsung culprit in abortions as well as preterm labor pain. Many a times we see recurrent preterms and ultimately find that it was a case of asymptomatic bacteriuria.
Bacteria, yes.
One beautiful thing that I learned today, or rather I am carrying with me, is that you can give nitrofurantoin and phosphomycin very freely in pregnancy. Many a times the thing that is there in our mind, if pregnancy is there, give amoxicillin, uske bhai dete raho, cephalosporins pe aate raho. But this thing has to be kept in mind that go for phosphomycin, don't worry about other things.
Yes.
Suspect pyelonephritis whenever patient comes with fever, pain and chills, and of course the rib side pain. Don't take it otherwise. One beautiful thing, go for urine routine micro. If more than 5 pus cells are there in urine routine micro, keep UTI in your mind. And antibiotic should be given for minimum 7 days in lower UTI and for minimum 14 days for upper UTI. These are the beautiful messages that I am carrying today. Thank you very much, ma'am.
Thank you, Dr. Khatri. I could see that you were attentive during the lecture. Thank you so much. Yeah.
Thank you, Chairpersons, for making the session so lively. Requesting all the speakers and the Chairpersons for a picture on dais, please.
Later on, all the delegates also. UTI should be a keynote address because it is because most of the patients they belong to this category. So, madam, next time keynote address, huh? Next time keynote address.
Girish, one more is here. So we have to go back.
नहीं लोग सभी लोग पता पहुंच कितने लोग थे
इसको तो वैसे टेक करेंगे, मैन बिहाइंड ICCOB. रिलीज करेंगे ये फोटो को रिलीज.
सेंटर को फोकस करो.
जूम करके भी ले
So now we have the oration.
स्टेज को छोड़ो थोड़ा.
Thank you.
ओके मैम.
खाली अनाउन्स कर
चौघींचा आहे ना मागून फोटो काढायला पाहिजे बघ.
हाँ जी.
माझ्या बायकोसाठी तुमच्या चौघींचा मागून फोटो
हो,
काढायचा
चला
मला.
काढा
तिकडे
ना.
तुमचं.
की मी असे मुलींना बघत नव्हतो, मागूनच बघत होतो.
काय करू वॉक करू आणि त्यांना काढू.
म्हणजे या मुलींना मागून बघत होतो, अशी बघत नव्हतो.
ठीक है, हो रहा है? हाँ, क्या करना है?
अपना कुछ पीछे.
I welcome you all yet again to this post-lunch session, and I know that everybody is quite sleepy through the day, hectic academic feast, but we have eminent speakers present amongst us, and we would like to acknowledge their presence and honor them because they have traveled all the way in these trying times. So we'll start our session for today on prematurity, the biggest challenge. And to chair this session, I would like to invite up on stage Dr. Manju Shukla ma'am, Dr. Manju Shukla ma'am, Dr. Shampat Kumari ma'am, and Dr. Kashyap Seth ma'am. Can we have Dr. Manju Shukla, Dr. Shampat Kumari ma'am? Ma'am, please. I think two chairpersons are not there with us. So we are the first speaker. Yes, ma'am. Dr. Manju Shukla ma'am is a retired professor OBGYN KGMU Lucknow, and she's the president Lucknow OBGYN Society and chief editor general of UPCOG. She's a national assessor quality Lakshya Kayakalp NRHM and organized many national and state level conferences as organizing secretary and co-chairperson. Welcome ma'am to this esteemed session. I would like to invite our first speaker, Dr. Kavita Vapat ma'am, for her pertinent topic, emergent management of preterm delivery. Ma'am, over to you.
इसको स्टार्ट कर दो ना. आई एम फीलिंग सो गुड.
बस ना संपत, it's okay. It's okay. Yes.
क्या नाम है आपको?
कविता बापट.
So Vice President of Foxy.
Thank you.
So single word.
Thank you.
आगे पीछे.
हाँ, ये आगे ना. ये चालू हुआ बेटा इस पे. Hi, good afternoon. I'm so happy. Dr. Munshi is there, Dr. Ramni is there, Dr. Anita Singh is there, Dr. Sampath is there, Dr. Prem. I'm so, I can name the audience. And a young girl from Indore, Divya, no? Huh? Bhavya is from Indore. And my organizing secretary, Dr. Archana Baser is there. The topic is really nice. I won't take much time because there is nobody to listen and all of you know the management. So I'm just going through my slides, just how to say what the continuous education is between and after the 20 weeks and 37 weeks. And we again subcategorized it, early preterm labor, prior to 33 weeks, and late preterm labor, 34 to 36 weeks. So the point is, again, these are the definitions which are from nowadays they call about. It occurs between the 20 weeks to 36 weeks and further categorized into the early preterm and the late preterm. That's all. But the major problem which we face about the preterm labor is the morbidity to the neonates is a very, very troublesome and a very boring point. I don't know why it's not moving. So there are so many etiological factors, right from stress, and I think Dr. Archana Baser is going to cover all the points: infection, placental abruption, previa, substance use, history of preterm birth and abortion. Really, I'm privileged to having most of the vice presidents over here, Sarji. All vice presidents are there to listening me. Past vice president Anita ji, Ramni ji, future Alka ji, Sampad madam, future one. Another is then. So this is a vice president conference over here. I'm so happy. I'm not taking much more time. I'm just going through my slides like this. Nothing to teach you and nothing to talk about. It's good, no? Kya batana hai? Aap sab teacher ho bade bade. So these are the environmental factors and other causes for the premature rupture of membranes, maybe short cervical length, second and third trimester bleeding, low BMI, low socioeconomic status, smoking, illicit drug use, and many more things. But what we main concern about the prematurity is about the complication of the respiratory distress. We should consider the sepsis, intraventricular hemorrhage, necrotizing enterocolitis, and the prompt intrauterine inflammation can lead to the neurodevelopment impairment. So whenever we talk about the prematurity or the stillbirths or the morbidity, prematurity ranks the first, and it's really till date a very, very important topic. So the early membrane rupture has an associated with increased risk of neonatal white matter damage. Infection and umbilical cord accidents contribute to number 1 to 2% of the antenatal fetal demise after the preterm prom. So these are the problem. Now why it happens? Only 3 things are there. One is cervical change. Number 2 is a persistent uterine contraction. And number 3 is activation of decidua and membranes. So the difference between the labor at term and the preterm is the former occurs via normal physiology, while the latter occurs because of the pathological things are there. So this is the pathophysiology, and the key point is there is a FIRS, that's a fetal inflammatory response syndrome, which involves a systemic inflammation, elevation of the fetal plasma, interleukin 6, and a signal to the fetal hypothalamus leading to the secretion of CRH, and this ACTH, therefore the cortisol production from the fetal adrenal glands, and the triggers the pathway to activate. I think we all need a good photograph together and a prematurity ko rehne dete hain. Still I am continuing it. So the history is also important. The previous history is important. Mind science, fetal heart rate, assessment of the contraction, all are important. And how to assess that this is a labor is firmness, abdominal tenderness, fetal size, position, cervical examination can identify the asymptomatic cervical dilatation and effacement. Symptoms include regular and contraction, lower back pain is also very, very important things. So physical examination to say someone that she is having in a labor is very, very important. Cervical dilatation 2 to 3 centimeter at 34 weeks,
Patient is highly delayed to deliver the preterm. Another indicator, short cervix. Normal length is 35 to 48. And definition of short cervix in a cervical length is less than 25. Transvaginal ultrasound can help in distinguishing the cervical effacement. I think मेरा बहुत सारा mood चला गया है because audience is not there. We'll have a photograph together and that's all. No, promise. There's diagnosis involves speculum examination, Fern and pH testing, pooled vaginal secretion, but it's a false negative are much more over there. And pH of the amniotic fluid is also important. So the evaluation is we can do the fibronectin test also, not specific, but a sensitive test, and result negative is strongly indicative of intact membrane, but if positive does not mean that the premature of rupture of the membranes are there. Another evaluation, finally the laboratory can assess the eliciting, include the rectovaginal group streptococcal culture, not we do in regularly, but it's very, very important. So antibiotic is needed or not. Then the urine culture is also important. History of substance use, we may link it. Fetal fibronectin testing is for the woman less than 34 weeks, and cervical dilatation less than 3 centimeter with cervical length 2 to 3 millimeter, and the transvaginal ultrasound is very, very important. Now the management, I'm just given a topic that the management of preeclampsia. The management is implemented based on the gestational age at which the mother presents at the hospital. Number one, if it's less than 34 weeks, mother presents with the preterm labor, she is admitted. After the observation of 4 to 6 hours, if she does not have progressive cervical dilatation and effacement, she should be, and the fetal being is noted, and a reactive non-stress test, no complication of pregnancy is there. मंजू मैडम आ जाओ स्टेज पे, आप मेरे साथ हो. She can be sent home with instruction follow-up in 1 to 2 weeks. Written of this additional signs and symptoms preterm labor of the pregnancy concerns, and the management part again. If she is presenting less than 34 weeks, the preterm labor and hospitalized. If preterm labor with the intact membranes, tocolytic drugs up to 48 hours are used to inhibit labor, and the guidelines for the tocolytic drugs are very, very important. Typically, the tocolytics are consideration between the 24 to 34 weeks of gestational age, only when there is no contraindication. Other drugs which we can class about the calcium channel blockers, beta adrenergic, co-inhibitors, the nitric oxide donors, then there is a weaker tocolytic drugs. Atosiban has gained a very, very importance since last few years. It's very important. Magnesium sulfate has got its more important role and commonly used in the drugs as a preterm labor. Glycerin trinitrate is another one. These are the classes, and these are the contraindications for the tocolytic drug if there is already preeclampsia, intrauterine fetal demise, lethal fetal anomaly, chorioamnitis, hemorrhage, significant maternal cardiac diseases. So there is not way. Once the membrane have ruptured, pregnancy cannot typically prolonged enough further for the growth and maturation. They should reduce the neonatal morbidity and mortality. The theme is transfer the mother to the hospital with advanced obstetric care and a neonatal capabilities for the care. Administrating appropriate antibiotic to prevent infection. Antenatal administration of steroid to the mother to reduce morbidity and mortality of the fetus and secondary to the respiratory distress. Interventricular hemorrhage is also very, very important. Necrotizing enterocolitis is important. PDA is another important thing for the prematurity, and administration of the magnesium sulfate in the preterm labor before 34 weeks for the neuroprotection is another thing. If the contraction occurs despite the tocolytic therapy, clinician must assess the patient's amniotic infection, fetal compromise, then the possible abruption, questions where the cervix is still changing. In some instances, preterm labor induction may necessary, and the intraembryonic infection in this case, and fetal growth restriction, oligohydramnios. These are the indications for induction of the labor in a preterm cases. Elevated blood pressure secondary to preeclampsia and eclampsia. So the fetus is monitored similarly as the term of the fetus via heart tracings. Monitoring is very, very important. Intrapartum death and neonatal seizures are important. There should be a neonatal care team informed to the status of the patient. It would be mentioning after the birth, delayed cord clamping is very, very important. They are giving much more importance to the delayed cord clamping, and it has associated with higher hematocrits, higher diastolic blood pressure, higher circulating blood volume, lower resuscitation. Now these are the complications Maternal complications, I never knew. I just read it through it and I found out the mother who are having the preterm labors, there are increased risk of cardiovascular mortality and morbidity in them for the mothers. And typically the years after the delivery is unclear. The moment I read it, I also found out because I have delivered a 27-weeker. And I thought this is the reason I can die because of maternal complication like that. So I was worried about infant combination. A mother can understand who has a 27-weeker child, you know. So the reading all those things, it's made me really, really upset. And there are things which I think I am lucky that he doesn't have any cognitive abilities, no motor defects, no palsy, and vision and hearing loss. So these are the really, so much bad things can happen to the premature child. And there can be issues of anxiety, depression, autism, and ADHD associated with the preterm labor. So these are another neonatal complication: enterocolitis, intraventricular hemorrhage, dysplasia, retinopathy, immaturity, weak growth. So these are the things. And again, the management is more than 34 weeks. The preterm labor, admit and observation for the 4 to 6 hours, no progression, cervical dilation and effacement, fetal being shows a reactive non-stress test, complication of pregnancy have been evaluated. And we need an enhancing medical team for this. Role of cerclage is there, they say about. Lastly, I think the color has gone. It is used, plays a vital role in preventing preterm birth. It is used prophylactically in the women with a history of recurrent mid-trimestral losses, diagnosed cervical efficiency, identified with a short cervix. Lastly, the rescue treatment of incompetent cervix and threatened preterm labor is also important. Now, the use of progesterone, the people write so many progesterone, but it has got the role to prevent the preterm birth. Benefit only had a history of prior single-term preterm birth, those with a short cervix. And under normal circumstances, progesterone levels fall before the onset of the labor and it triggers the parturition. So administration of the progesterone promotes uterine conscious and which may block the preterm labor. So this is the another study for the treatment and the regime for including magnesium sulfate and the preterm birth, and they found out it's a very, very good for the preterm birth. So the take-home message is very, very simple. Only two messages which I always love to like. The routine antibiotic administration of the antibiotics in the premature labor without premature rupture of the membranes is not recommended. And the another most, there is no evidence that the bed rest actually lowers the preterm births. So thank you so much for the patient listening, and I am very happy today that the most of the vice presidents are there to listen me. So it's my proud and privilege, and I like to have photograph with all of you at this place. And I welcome each and everyone who is over there, hardly 15 people, but whatever, the message should go. Welcome to Indore, AICOG 2022 from 9 January to thank. And thank you, chairpersons, for being with me. More
Thank you,
audience.
Kavita. Only you can make it so simple. Next we will have a, do you want photos?
will take one photo. कौन सा expressway है? Expressway to Indore.
रमनी मैडम आओ. अजमत सर आ जाओ. और प्रसन्न पास. अच्छा समय बच गया बिल्कुल. अरे आप तो मत तुम्हारे लेकर
प्लीज मैडम मैं तो हुई नहीं
also join so Divya can take Divya. चंद्रवती मैडम तुम जीना नहीं चढ़ा पा रहे हो. आओगे? वहीं ठीक वहीं. हाँ मैं समझ.
Come to Indore. You will be announcing. Ma'am, Chairpersons address.
Very much.
He has ended over.
मैंने already.
Okay.
बोल दो ना मेरा lecture लगाने को. मैम का लगा.
Thank you very much, Dr. Kavita, and now I invite Dr. Archana, Consultant Obstetrician and Gynecologist Director at Akash Hospital, Indore. She is a Vice President FOXY 2020 and Organizing Secretary of AICOG 2021, Indore. Fellow Representative of AICC RCOG West Zone and Emerging Scientific Committee Chairperson of SAFOC. She has held lot many past positions, like she was a chairperson of Fox Imaging Science Committee 2015 to 17 and organizing secretary of ISAR 2006. She is a managing 2016, sorry, and she is a managing committee member ISAR 2018 to 20, IH 2018-19 and ICOG 2017 and 19. I welcome you, Dr. Archana.
It's okay. All right. Hi, good afternoon, everyone. At the outset, let me thank Dr. Alpesh Gandhi, our president of our tenure, for inviting us to this conference and giving us an opportunity to meet my co-vice presidents whom I had not met during the tenure. So it is really a very good opportunity to me to see all of them. So respected chairpersons, I will begin with my talk. I know Kavita spoke quite a bit about preterm labor. What happens when there's a theme, I think there will be some overlaps which you have to bear with. What topic I'm addressing here is prediction and prevention of preterm delivery. Why it is very important that we talk about preventing the preterm delivery? Because what we know that treating established preterm labor is unsuccessful and prevention is the key. If you look at epidemiology, where do we stand in terms of the preterm? In India, out of 27 million babies born every year, 3.5 million babies born are premature. And why we are so much worried about the prematurity? Because it's a significant public health problem all across the world because of associated neonatal mortality and short and long-term morbidity and disability in later life. And according to World Health Organization, every year 15 million babies are born premature around the world, and that is more than 1 in 10 of all babies born globally. So it is an alarming number, and it is something which we really seriously should be worried about and thinking of preventing it. So what are the steps to prevent, predict, and diagnose? The history holds it all. If you take a proper history, I mean, there's a past obstetric history, current symptoms. So this will be all included in my talk. History, physical examination, investigations, monitoring of uterine contractions, transvaginal ultrasound, which I'll be focusing on, and assessment of cervical fetal fibronectin levels. So what are the risk factors of preterm labor in history? If you have a mother who comes from low socioeconomic group, her age is less than 80 or more than 40, and she has low pregnancy weight, which we have learned during our PG days, underweight mother produces underweight babies, and underweight in those days means small babies or even the premature babies. Now we can differentiate between FGR and premature because of the sonography. And smoking, substance abuse, you would be surprised. You might be thinking that it is not that common in India, but now in modern India, substance abuse is coming and it is increasingly becoming a problem in a particular segment of women. And multiparity. In the past obstetric history, if you have a previous history of preterm delivery, previous history of second trimester abortion, and in uterine factors, if you have increased uterine distension, polyhydramnios, multiple gestation, uterine anomalies, trauma, and infection. Complications seen in the preterm babies. I mean,
you can name it and you have it. So in neonatal complications, you have respiratory distress syndrome, you have intraventricular hemorrhage, periventricular leukomalacia, PDA, and in the short term, there will be feeding problems. Every day we have, like you deliver preterm, mother will all the time will be crying that I can't feed my baby because the baby is premature, can't suck, mother's breasts are not well developed, and there is a lot of hue and cry that baby is not feeding, and neurodevelopment difficulties, there is a transient dystonia, retinopathy. So these are all of the problems which are short-term problems, and if you look at the long-term problems, they still struggle, the preterm babies, with this. Sometimes there can be cerebral palsy, there is a sensory deficit, incomplete growth catch-up, cognitive impairment, behavioral abnormalities, and chronic lung diseases. So what we have to do is we have to do prediction for prevention. So as I have already mentioned, and I'm again going to re-emphasize it, that each year 15 million babies are born preterm. Many may look forward to a normal life, as Kavita has already said that, you know, there was no disability, but others may die or live a life of disability. So effective and accurate prediction has to be the first step for implementing preventive strategies, and proper patient selection is the key for efficiency of preventive strategies. So there are several causes of preterm labor, but you have to identify what are the predictable causes of preterm labor. You cannot always predict all the causes of preterm. So these are the five main predictable causes of preterm. Number one, past history of PTL. Because patient is going to tell you uterine anomalies by ultrasonography, or if she has conceived after fertility treatment, you would know. There can be cervical abnormalities, advanced maternal age, and the new thing is assisted reproductive technology. That's one where you can really predict preterm labor. Are we successful in predicting preterm labor by history alone? Unfortunately not. Because if you look at this slide, delivery before 34 weeks, 2/3 of the deliveries are spontaneous and 1/3 are iatrogenic because of the maternal indication or the fetal indications which we have to do. Out of 2/3 spontaneous preterm, only 15% women will give a history of previous preterm birth, and 85% will have no previous preterm birth. So this is the area where we have to focus our energy and prevent preterm delivery. So is there any way we can really do something more in this area? I think we have several measures. One of them is the fibronectin, like fetal fibronectin in women who have positive fibronectin, and you measure the cervical length. I am going to focus on cervical length by ultrasound. If it is less than 25 millimeters, 65% of chances of having preterm delivery, and if it is more than 35 millimeter, then 25% chance. And if the fibronectin negative, and it is, you know, inversely proportional to cervical length. If it is more than 35 millimeter, only 7%. If it is less than 25 millimeter, 25% women will have will end up in preterm delivery. This is my area of really interest, and which I teach when I take ultrasound sessions for FOXY and for the classes, for the students who come. This is a very much doable thing, and this can be easily learned to do cervical length measurement. I mean, as an obstetrician, if you have your own ultrasound machine, I mean, you can make it a part of your routine ultrasound examination. If you are sending it even to your ultrasonologist, just in every sonography report, it should be mentioned the cervical length. Cervical length should be mentioned, because then you can predict. So how really you can do the cervical length measurement? One has to know that cervical length measurement in the first trimester, second trimester, and third trimester is slightly different. Whenever you are doing a transvaginal, you can do transabdominal, you can do transvaginal, but in transabdominal you have to have the full bladder, and full bladder lengthens the cervix, so there will be a wrong interpretation. So transvaginal sonography is the gold standard, and in transvaginal ultrasonography, you don't have to press your probe hard. transvaginal probe has to be kept just close touching the cervix. How do you know that I'm measuring the cervix right? There is a way to know that the cervix measurement is right. This is the, I think I just moved the slide. Yeah, so if you see here, your anterior lip and the posterior lip should be equal. If you are pressing too much, then your anterior and posterior lip measurements will be different. You have to identify the external os, which is very well denoted in every case by triangular area of echo density here, and then you can see your external os as well. And not only the length of cervix is important, it is the curve of the cervix is important. If it is straight, sooner or later it is going to become short. So it is the curvature which is also important. So this can really be done, and this is very helpful as all the studies and all the treatment are based on the cervical length. You can do internal examination by per vaginal examination, but that's a very, very subjective thing. So there are several studies which have compared the vaginal examination, digital examination, as well as by ultrasound and ultrasonographic examination is very superior, and inter-observer error in the examination is also very less. So when you talk there, I mean, this is a very, favorite slide of the examiners also. The shapes of cervical funnel, like funneling of the cervix, whenever you are doing a digital examination, you cannot feel the internal os. While with the sonography, you can see the internal os as well. So it's a T-shaped, means just cervix has started to dilate, and Y-shaped means there's a funneling. V means it is quite open, and U means it's like impending premature delivery. So these are the certain pictures of the cervical length. Like on the right side you see it's kind of a U-shaped cervix which is about to like open, but if depending on the gestation you can do the rescue cerclage. I think there is a talk on rescue cerclage, so I'm not going to talk about that, but yes, we have similar cases where we could salvage the pregnancy by doing the rescue cerclage. And here again, you can see the cervical length is very short. It is only 15 millimeter is the cervical length. Here is the chorion, amnion, and a lot of sludge is there. So learn to do cervical length assessment is my, message that everyone should learn to do cervical length assessment. And this is a picture of short cervical length. So now the question is, should all pregnant women be screened for cervical length? When we know there is a strong evidence that progesterone treatment may prevent preterm birth in women shown to have a short cervix on ultrasound imaging in mid-pregnancy. Well, if progesterone is so effective in preventing preterm birth, women with a short cervix in mid-pregnancy, should all pregnant women be screened for cervical length at this time? And this question is of great importance and remains controversial because we are working in low resource setting. I mean, having all said and done, it's very good to talk about measuring the cervical length, but in low resource setting, it is not always possible. So you really have to identify the high risk and then you can subject them to the cervical length assessment. And there are several studies which have shown that if you measure cervical length and in short cervix 10 to 20 millimeter between 19 weeks and 33 weeks, 6 days to receive either vaginal progesterone gel or placebo daily, and preterm birth and major complications of prematurity were halved by the treatment. So intervention to prevent preterm. In recent decades, advances in newborn care have resulted in improved outcome for a large number of children who have been born too early. But this progress has not been matched by similar advances in our ability to prevent preterm birth. That's the irony. I mean, the old problem, new challenges. And we now have increasing evidence that a variety of interventions have potential to significantly and safely prevent a meaningful proportion of preterm birth. So intervention involve strategies to prevent non-medically indicated preterm birth, use of maternal progesterone supplementation, surgical closure of cervix with cerclage, prevention of exposure of pregnant women to cigarette smoking, and judicious use of fertility treatment,
and dedicated preterm birth prevention clinic. So I'm going to be focusing on dedicated preterm birth prevention clinics, because progesterone supplementation, all of us know, and I think my previous speaker Kavita has already touched upon it. So just going to, in one slide, progesterone beneficial effects. Progesterone works on cervix, decreases cervical stromal degradation. On myometrium, it reduces contraction frequency. Decidual and fetal membrane, it accentuates response to hemorrhage and infection. And in placenta, it decreases prostaglandin synthesis and reduces apoptosis. And in fetus, it alters fetal endocrine mediated effects. So route of administration can be transvaginal, oral, and injectables. And these are the hormones which people have been using. Does the length of cervix matters when you are deciding to use the progesterone? Yes, it does matter. Shorter the cervix, lesser the beneficial effect of progesterone. So you must have a cervical length assessment properly done, because it is not that whether you will be able to prevent. It is important to do the counseling of the patient, that yes, these are the data, and we are comparing. If 1.25 millimeter, your chances are only like 15%. So that's how it will be of help. And there's a pessary also available, which can be used when there is a preterm birth with a preterm labor which is established. Cervical cerclage, I mean, it has been done in since ages, and we have been doing it. And one should know the indication of doing the cervical cerclage as well. And the most important slide is here, judicious use of fertility treatment. The advent of fertility assistance has contributed to a significant increase in the rate of preterm birth, and central to this contribution has been an increase in the incidence of multiple pregnancy. So we are in some way responsible for increasing the incidence of preterm birth. There are several guidelines, like NICE guideline. There are recommendation of NICE guidelines that how really you can prevent preterm, like prophylactic vaginal progesterone, magnesium sulfate, antibiotics and all. FIGO guidelines also again on the similar line, use progesterone judiciously, don't use it for all. And this is the important thing, dedicated preterm birth prevention clinics. In recent years, many health regions and hospitals have developed dedicated preterm birth prevention clinics, and these clinics and their associated services have employed a wide variety of criteria outlining who should attend and the protocol for management. And the first large-scale attempt to determine the effectiveness of such a program was the West Los Angeles preterm birth prevention project, in which 8 prenatal county clinics in California were allocated at random to be experimental or control clinics. So what are they focusing on? So these dedicated preterm birth prevention clinics have focused on newer diagnostic and therapeutic intervention, assessment of vaginal microbiology, fibronectin testing, ultrasound detection of shortened cervix, antibiotic use, progesterone therapy, cervical cerclage, and Arabian cervical pessaries. And strategies which promise but require more research: treatment of intrauterine infection, nutritional interventions to underweight women, amelioration of maternal stress, treatment of periodontal diseases, and prevention of surgical treatment for cervical intraepithelial neoplasia. To summarize, in most countries, the rate of preterm birth has risen in recent decades. I mean, this is so like one time we are saying that, maternal mortality is decreasing, and then we are doing very well. We have good tertiary care, NICUs, but this is an area where we really have not created any dent. So that's the area which really all obstetricians should be worried about, and thinking that how really in our own clinics and in our own setups we can prevent or at least predict preterm, so that in time transfer of the babies, in utero transfer can happen. And worldwide now represents the largest cause of neonatal death and second largest direct cause of death in children up to 5 years of age. And one of the highest priorities in contemporary healthcare is to prevent and predict the preterm birth. So thank you very much. I wish you all a Merry Christmas and a Happy New Year. And I invite you all to AICOG 2022 at Indore from 9th to 13th of January. Please do come and enjoy the hospitality and good scientific program at AICOG Indore. Thank you very much for patience listening.
Thank you very much, Dr. Archana. It was a very nice and elaborative lecture. Two important things, of course, prediction, most important. Second one is assessment of the cervical length. And very importantly, because most of the babies, they do succumb because of lack of tertiary care. So I think very important step which has been put forward by our Prime Minister PM Modi, that you have a particular card that is called PM Jai card, or what we call as an Ayushman card. And with this card, I think so many babies, they can be survived because the treatment is totally free. So I think I would like to add on this particular point also, that PM Jai Yojana is very good. Most of the babies can get a very important tertiary care treatment without spending any money. Thank you very much for your
Very
lecture.
good point you brought out, doctor. The important thing is many of us even don't know the government yojanas. So I think it is very important for, as a obstetrician, as a leaders, we are all leaders, because people look upon us as leaders. So leaders should know what are the government, because not, as I already mentioned, that we sometimes are working in the low resource setups, and not everybody can afford tertiary neonatal care. So those can be identified, and I think government has identified the good hospitals where these neonates can be transferred or mother can be transferred. So I'm really happy that our governments are doing very well, and we have to be aware to make people aware. Like, as I said, you have to first find out what you can predict to prevent. So it's the same thing. So thank you very much for patience listening. If any questions, I'm happy to answer.
Thank you.
Well, I think it depends on, basically the vaginal route is the best route because it is directly access to the area and it is the less side effect. But having said that, in our kind of setups, women are not very comfortable using the vaginal pessaries. So they prefer oral. So I think it will be very much individual. I mean, if you compare vis-a-vis, of course, I would advise transvaginal route, and it will be the women's preference and the obstetrician's preference. How do they want to give? Because evidences are there that vaginal route is definitely better. So we have evidence, but it is the practice. It depends on the practice. There are, like, I did skip those slides because I thought that's like, there will be repetition, but 17-hydroxyprogesterone caproate, people are using it. It is very effective. I think there are, Dr. Sharma and all there. I'm sure those, in those days when micronized progesterone was not available, even dydrogesterone was not available, that was the mainstay of treatment, was 70-hydroxyprogesterone, known as, like, and I'm not taking the brand name here, but Proliton Depot, and I think even everybody was aware of that name, and it still works. It works. What you want to comment on that?
No. I'm just, we have used Proluton in large number of cases.
I know, yeah.
And since micronized progesterone has come, we are using that. Yes, vaginal route is quite effective, but patients are not willing to.
I said that it depends on, because in our
Thank
kind
you,
of setup,
thank you,
women are not
Archana.
comfortable. Thank you so much for your comments and patience listening.
Now, as we know that the predictive value of cervical length and everything, Dr. Mahesh Gupta, he is going to talk on emergent cervical encerclage. Dr. Mahesh Gupta is MD, high risk obstetric consultant, Pushpam Hospital. He is a recipient of many gold medals in undergraduate and as well as postgraduate, presented many papers in international conference, developed and patented technique to control PPH, COMOC-MG operation endorsed by RCOG. US patent applied for COMOC-MG suture. MG is Mahesh Gupta suture. recipient of Times of India Health Icon of Ahmedabad City for high-risk pregnancy, having 50-bed multi-speciality hospital at Ahmedabad, editorial board member in World Journal of Anemia, President Ahmedabad OBGY Society 2013, and honorary convener of State Organization of Societies of Obstetrician and Gynecologist of Gujarat. Invited as guest faculty across in India and abroad. Dr. Mahesh Gupta, he is having very good theatre and all. So he is going to talk on emergent cervical encirclage.
Madam, specify theater. People will understand the operation theater.
अरे theatre तरह तरह का होता है ना.
So, thank you very much for the nice word, madam. It's a good afternoon to everyone. Yeah.
Yes. Can I call her? Technical problem.
So since Dr. Mankesh is, wait.
So, I'm going to speak on rescue encirclage or emergency encirclage. But when there is a cervical dilatation and when we think that now this fetus is going to abort, when there's a dilatation and even fetal parts are also out from the cervix, in those cases we did a cervical encirclage and we got the results. So for that I am giving you some thought-provoking ideas for this rescue encirclage. So you should not think that this patient will definitely going to abort. If you perform this procedure, you may get a result 35 to 40%, and our one of the chairperson has evidenced this procedure in his hospital. So incidence of cervical incompetence will complicate anywhere from 0.1% to 2% of all pregnancies, and it is thought to be responsible for approximately 15% of the habitual immature deliveries between 16 and 28 weeks of the gestation. So we'll talk about only emergency cerclage or urgent cerclage, no prophylactic cerclage and no other cerclage. An emergency cerclage that refers to the replacement of the cerclage in the setting of significant cervical dilatation and effacement prior to 28 weeks of the gestation and in absence of labor. Now, because of the good neonatal services, if we can prolong the pregnancy for 2-3 weeks, if it is a 22-23 weeks, and if we can prolong the pregnancy for 3-4 weeks, then the age of viability for the fetus will be achieved. So this emergency cerclage many times cannot pull the pregnancy till term, but it can prolong the pregnancies for 2 weeks, 3 weeks, 4 weeks or 5 weeks, and then we can achieve a fetal viability. So mind well, it is a surgical procedure without proven benefit, but if you will start doing it, then you will find it's very helpful. As such, until adequate clinical trials are not available, because if you find from Google about the rescue encerclage, you will not find a large data, you will not find a large Cochrane study, you will not find a enough number of cases to be published. But we had now enough number of cases and still we have not published it. So, but our experience in my hospital and in Gujarat and many places in Gujarat, the people are doing now this emergency circulage and getting results. Now, what are the contraindications for this emergency circulage? They are the persistent uterine contraction. Now, with the help of this atosiban is available freely now, and atosiban is a receptor-specific drug which can quiescence the uterus. So now, with the help of atosiban, we can control the uterine contraction for time being. Then second is uterine bleeding. If there is a persistent uterine bleeding, we should avoid this procedure. If there is a presence of infection or chorioamnionitis, we should avoid this procedure. And naturally, if there is a rupture of membrane or fetal anomaly, then we should not do it. Now, the complications are most of the time, they are the infection, and then pain and dilatation. This was the case in 2009 where the fetal leg was outside. This is the cervix and fetal leg is outside the cervix and it is in the vagina and bag of membrane in the vagina. That we did first in 2009 and then we did many cases. I'll show you the procedure is like this and I'll show you one unedited video for that. So the case is same where the cervix is dilated and membrane is bulging like this. The fetal parts is in the membrane. Here the full general anesthesia with muscle relaxant is to be given, not scoline, but we prefer to give a atracurium. So intratracheal anesthesia is must, that is one thing. Second thing, more than 30-degree tender ligament position is must. The standard lithotomy position is again also must, not knee resting, but it is a lithotomy position. And then we start the procedure. If you feel that the membranes are bulging, here the one physiological or technical thing I want to tell you that the full dilatation doesn't mean that the full dilatation means cervix is totally effaced. The full dilatation to full-term baby is different and full dilatation to 22 weeks, 20 weeks or 24 weeks baby is different. Because for 20 weeks baby full dilatation is 3 or 4 centimeter. For full-term baby full dilatation is 10 centimeter. So if there is, and in premature or in early weeks of gestation, the dilatation first occurs and then effacement occur. While in case of full-term pregnancy, first effacement occur and then dilatation occur. So at 20 weeks, 18 weeks or 22 weeks, cervical lip is always there. If it is a full dilatation to that particular gestational age, then also you will find a cervical lip. So here, just with a normal saline dip gauze, I am putting in the cervix and we can find out the thin cervical lip like this. So we need to have a 4-5 long Alice's forceps for this. So once we catch the cervix like this with 4-5 Alice's forceps, then we can take out the swab which is very well soaked in the normal saline. Then we take a large bore Foley's catheter, maybe 18 or maybe 20 if available. Then we put a Foley's catheter at the mouth of the cervix and inflate the bulb and then push the bulb inside like this. And once the Foley's bulb is well placed inside the, this is an unedited video, that's what I am showing you. This Foley's catheter is placed inside and inflated the bulb and then we push the bulb in the cervix and then again inflate the bulb. So membrane will not be in the suturing. So accidentally we cannot rupture the membrane while suturing the cervix. Now once you place the Foley's catheter in the cervix, you press the bulb like this. So now the bulb is in the lower portion of the isthmus and standard McDonald procedure you can do either with the 1 number nylon, or you can do with a Marcelin tap, that is a 0.5 centimeter Marcelin tap, 30 centimeter, available with the both the side needle now. That also can be used. And after placing this Follis catheter inside, you can take the standard McDonald suture. Here the bladder also should be empty before you proceed for that. And then the things will become easy. And then routinely we give tocolytics in the form of either atosiban, or when the atosiban was not available, we used to give a terbutaline. Terbutaline was the best uterine relaxant in those days. And now terbutaline is not available, but the atosiban is available. And when we put on oral, then we put a patient on an nifedipine that orally we can give. And we give antibiotic for a longer time in this case. Higher antibiotic for at least 7 days, and then on oral antibiotics for at least 15 days or 20 days or a month. So that gives a good result. Until that we get a result almost about the 40% to 35 weeks. And in many cases, 50-60% of the cases, we pull on the pregnancy for 28 weeks or 29 weeks. Then suddenly if the membrane rupture, then we can take out the baby, but the age of the viability we can easily achieve if we can cross the 28-29 weeks pregnancy in our setup in Ahmedabad. Because in Ahmedabad, the neonatal services, we are sure that if the baby will cross the 28 weeks of pregnancy, we can have a viable baby. So this is about the emergency and circulation. So, and when we tie this knot, then slowly we deflate the bulb, and once we tie the knot, we are pulling out the catheter. So like this. And the results are very encouraging, and since we are doing since now 10-11 years, and at the various places in the Gujarat, many of my friends gynecologists are doing this technique and getting very good results. So that was all about the salvage cerclage or the rescue and cerclage. And this is a new thing which I wanted to share with you. So that's why I'm putting this presentation to you. So thank you very much, madam.
Thank you very much, Dr. Gupta. In fact, I do have a pleasure of working with you. By 3 years or 4 years, we have done at least 7 such surgeries.
Yeah.
And let me tell you very honestly that my carry home rate is at least 4 of them have pulled on the pregnancy till 35 weeks. So
Yeah.
indeed, it is very, very good and very innovative. You have really mastered the art. Thank you very much. In fact, it is a good procedure which everyone should learn.
So it's when the Kashyap Seth is speaking, because I did 6-7 surgeries to his place, and since last in 3-4 years, and we get a good results. And Kashyap Bhai and his son were were little against and afraid of doing this surgery initially. But once we started doing these surgeries, now they are very happy. So like him, there are many gynecologists in Gujarat who are doing this technique, and they are getting good results also.
We had one workshop in Chennai also with you.
Yeah.
Yes. If no questions, we can go to the next speaker, I think. Any questions? Thank you, sir.
Yes, sir. Yeah. See, Sirotka require little dissection. So here the time constraint is there. So our aim is to just control the uterine contraction and to close the cervix. And McDonald is very easy, because in case of Sirotker, in such a cases, the dissection may not be that easy, because there is a very thin lip of the cervix. If you pull the cervix and if you push the bladder up, there may be tearing of the cervix. So that's why we avoid. It is better to take a Marcelin tap if you want.
Hello, sir.
Yeah, sir.
It was a nice talk, and we are also doing this emergency cerclages for now many years now. So certain points which have difference or certain suggestions is that when the cervix is too much dilated, Marcelin tape is not an ideal thing because it starts tearing off, 1 point. Second point is that as more than 3 centimeters, sir.
What is the thickness of Marcelin tape you are using?
No, the normal muslin tape which you get with the needles.
No,
Johnson.
initially it was available 1
Johnson.
centimeter thick. Now it is available 0.5 centimeter.
0.5 centimeter also, but it gets tear off. It's a minor points as it dilates. Cervix will be very thin. So when you try to hold itself, then the next point is that when you hold the cervix itself, you tell your assistant should not pull anything on that. See, when very lightly. See, if you pull it, cervix will tear. Once it is torn, it is very difficult. So all the alices, there will be too many alices. Sometimes what happens is that you will be only seeing the membrane. Most of the time, cervix would have been 2 centimeter or 3 centimeter, but the membrane would have come out like this. Okay. So what you do is that side of the membrane, you just palpate the membrane. Don't push anything. Side of the membrane, you pass the follis. To make this another problem, what I felt is that the follis will be wobbling like this. So what you do is that inside the follis, put a long sound inside. So what I have done is that I have, from the urology, they have the ureteric catheter long. They are not using it. Steel, that is with the metal ureteric catheter, it's this much long. So I insert it into the follis, just small suggestions, insert it into this follis catheter so that it becomes steady, like this. So it goes inside and keep it like this. Once you inflate it, you pull it out. So it remains there itself. So if you can go through the side and do it also. Even if it looks like full dilatation, but if you do a scan properly, most of the time has shown that
lip is there, always
there will be, you will get the, so once that follis goes inside, and one more thing suggestion is that when it is too much dilated, after 3 centimeter, I use 2, 3, 4 like that catheters I use. I also have the video, but lack of time, I'm not putting it. So 3, 4 catheters, one side this catheter can be put, one side another catheter and top. So 3 catheters goes inside, it goes inside actually. So it's a wonderful technique what sir is telling, and so many, at least you are able to push it to 28 weeks, you will get the baby.
Yes.
Results are very encouraging. So we have done a study of more than 100 cases, published it also, more than 100 cases of emergency cerclage, more than 3 centimeter. Results is almost 40% success rate. So more than 100 cases I have done. In this last 10, 15 years. So many, that is why so many, and one more thing, tocolytic patient has to be admitted in the ward. Patient foot and elevation, I use 2 tocolytics actually. 2 tocol minimum, as atosiban has come now, plus 1 tocolytic, and throughout, even if we say that in preterm labor, madam would have told, there is no role for after 48 hours tocolytic and all. In this case, continuous tocolytic, continuous antibiotics. See, one thing what happens in this case is that it is due to rupture of the membrane that happens. See, you would have done a proper cerclage, then what happens sometimes is that due to infection, after some time the membrane ruptures. So clean the vagina with betadine, saline, then only touch the membrane. Once the membrane has been, infection goes inside, even if you do a cerclage after 1 week, the membrane will rupture, and again you may have to remove the stitches. These are so many points, these are some of the points. Tocolytic I continue actually whenever throughout, see it is not advisable or whatever you say, I continue whatever with my experience, tocolytic, and then first 1 week IV antibiotics, then I put on different antibiotics actually. So
we generally put on either erythromycin or linezolidine.
And one more
non-traditional antibiotic for 1 week, higher antibiotic,
and then like erythromycin has to be continued. That is what
erythromycin you can give for a long time.
Long time. This is what usually is done.
So
besides the role of besides so many antibiotics and your surgical skill, do not forget the role of anesthetist.
That is
priority.
All patients,
because we have experience.
Then another
so
thing what we do is
the
that
role of anesthetist.
One more
By
thing.
chance patient coughs, membrane would come out, it would burst, and you will fail the case.
Full GA, sir has correctly
just
told.
before 1 month, we were doing the same surgery in his place. I told anesthetist, you just see. And meantime, the patient started coughing and membrane and everything was
full GA, Tenderberg with tube,
with long acting,
full maximum. Then one more thing, you can to decrease it. What you do is that sometimes I tap from above. So I remove about 10 to 20 ml of amniotic fluid from above, so then it comes down. So you have to be very patient. This surgery takes time. No hurry, not like cerclage, we did it for 5 minutes. It takes about half an hour properly if you want to do. Very patient, and then one more thing, the uterine contraction has to be abolished before you take. That means if patient comes, you cannot take it like that when there is a contraction. You cannot, nobody can fight against a contracted uterus. So first you have to put, contraction has to go and then take it. Contraction does not go, then the results are not good. So these are some of the finer points which has...
No, Ashwath, still 1 minute to go.
I can tell about...
Still 1 minute to go.
No,
just a minute. Ashwath, regarding your this multiple Foley's catheter, I would like to tell you that if you give a full anesthesia, intratracheal anesthesia with a long-acting this muscle relaxant and 30-degree Trendelenburg, and if the uterus is quiescent, you can easily push the membrane inside the uterus.
That is correct.
With a normal saline sock mop. Now about your betadine wash in the vagina. Initially we were used to do a betadine wash, but by thinking retrograde manner, that why to just stimulate or irritate the vagina or uterus by a chemical. So that's how we are stopped doing the betadine. We are just giving a liberal normal saline wash. Liberal.
You want to see
with a bottle, a plastic bottle. Our one assistant will hold and will push the normal saline in the vagina to just clean the vagina, but no chemicals in the vagina before
this is because this is another thing is the last point is that, see, you can once it may give way. Okay, it may after 1 week you can try again. It is not that it is, you should not lose. Anyway, you are trying to, nothing will happen. Then you will be able to, once it, the only thing what happens is sometimes the cervix will be torn away. Membrane. See, sir, what was multiple Foley's, which no time, otherwise I can show the video how it is done. I am telling a membrane, I will show you a membrane bulging out of the vagina like this with the fetus inside, what 10 centimeters for considered to be the full dilatation. So even to that extent you can
I am telling you, the full dilatation doesn't mean a complete dilatation of the cervix.
Ashwath, actually you and Mahesh all are worried about membrane and cervix. What is happening to the fetus inside?
Fetus will be able to say, madam, a baby is alive, madam, and at least we are able to see.
Baby should be alive before you are going for the procedure.
Madam, I will tell you one small incident. That is that one.
And now time is...
Yes, Mahesh bhai, we are also doing same things, but we are doing under caudal anesthesia.
Yes.
So in caudal anesthesia, you give some time and you can give more Trendelenburg position in caudal anesthesia. So we have done also that under this regional anesthesia also.
Thank you. Sir.
So it's a personal choice. But
so everyone should try about the emergency circlage. The take home message
You
is
have
that.
created emergency and lot of discussion.
Discussion, yes.
Everybody.
You must try, nothing to lose.
Exactly.
Yes, thank you. Okay. Next we will go to the next speaker, Dr. Atul Munshi. He will be talking on PPROM. He is an ex-professor GCS at NHL Medical College, Ahmedabad, and IMS representative to Asia Pacific Menopause Federation 21 to 22, IMS representative to International Menopause Society 2017 to 2018, Academic Governing Council member 2015 to 2017, Foxy representative to SAFAC. He was chairperson ICCOB in 2014, President IMS 2010, Vice President Foxy 2007, past President of Ahmedabad Society, on editorial board Pediatric On-Call Journal and Journal of Midlife Health. Back to Dr. Atul sir. Topic is PPROM.
Thank you, Dr. Sampath Kumari, Dr. Manjula, and my friend Dr. Kashyap. It's nice to see thin presence, but it's quite good, because when we started, there are hardly 10 people. After talking too much about sparing the membranes, I'm going to talk about things where patient has already ruptured the membrane and she has come to you. So PPROM, it's a problem which we are facing almost every day, not every day at least, once or twice in a week, or sometimes in a big busy OPD earlier also. As soon as patient comes in the middle of night also, I am leaking or I burst my membranes, and what next? That is the important part. Let's see what we can do. It's a practical thing. I'm going to talk only about practical aspect of it. Greetings from Ahmedabad. So many people have come from outside. There are less Ahmedabadi over here than people coming from outside. Welcome, and we welcome you all for Christmas to come and the conference next at Indore. We are going to talk about introduction, symptoms and signs, investigation, treatment and summary. We'll discuss only clinical aspect. The problem which mostly comes is, my water is broke, but I am not in labor. What to do? Let's see what we can do. Spontaneous rupture of membranes before the onset of labor is called the pre-labor rupture of membranes, PROM. We are talking about PROM quite commonly, and we do amniotomy purposefully also to augment labor later on. Patient comes to you and later in labor. When rupture of membranes occurs before 37 complete labor, it is termed as a premature PROM. Gestational age makes a lot of difference as far as management is concerned and prognosis is concerned. Is it nice to classify, because we know that gestational age plays a very important role. PPROM before 24 weeks is considered pre-viable PPROM. At 24 weeks, we like to wait for as far as possible to 26 weeks, 27 weeks, because these babies can be survived with a good neonatal care, and we call it an intact baby. It's not necessary that previously we thought that oxygen deficiency might lead to various problems, and later on baby is likely to be problems, neonatal problems throughout life also. Between 24 to 33 weeks, that is important thing. Early premature rupture of membranes, with the incidence about 2 to 5%. By 34 to 36 weeks, very common. Nearly about 3 to 8% of patients will come to you. Why it is important to discuss PPROM in this audience? Because 2 to 20% of all deliveries, PPROM is responsible for 25 to 30% of all preterm births. From last 1 hour, we are talking about preterm birth. This is one of the commonest cause of preterm birth, and which can be preventable if possible. Preterm birth will lead to neonatal complications, which have already been mentioned. Maternal complications, chorioamnitis, abruptio placentae, endometritis, and sepsis, which is very dangerous if you do not act in time. Long-term complications, we are not going to discuss now. Days of Aarti, most of the patients are dealing with high-risk pregnancies and high-risk patients. Subfertile group of patients, older age group of patients, changing lifestyles, and no disease in a member of preterm births or PRM. They are actually more, and they are more worried about it also, because twin pregnancy is also very common in this patient. So special considerations required in management of these cases. You have to be careful about that. As far as causes is concerned, why PPRM occurs, majority of cases we are not sure why it has occurred. The possible causes are increased fragility of the membranes, decreased tensile strength of the membranes. The causes we'll see. Polyhydramnios is very common cause. Cervical incompetence, we talked a lot about cervical incompetence. Multifetal pregnancy, infection is very common cause. Not only chorioamnitis, but vaginal infection is also, bacterial vaginosis is very common part of it. Cervical length, we already mentioned about it, less than 2.5 centimeters. Prior preterm birth, you have to be careful about that. And low BMI, and sometimes very high fat level is also important for this. As far as etiology goes, uterine overdistension, choriodecidal infection, PPROM is common, and programmed cell death normally occurs at full term, because we want to have labor pains to start. For that, programmed cell death is there. By chance it occurs earlier, and then there is a possibility of PPROM, early labor. Symptoms are very common. Vaginal discharge, commonly gush of fluid, but very small leaking of seepage can occur. It's difficult to find out what is that. Oligoanhydramnios is there in sonographic examination. Cramping, contractions are later part. Back pain, fever suggests there's a premature labor has started. We want to prevent it. It is important to know the differential diagnosis. So many times patients are already PROM or patient's relative is having something, they will always worried about it and they will come to us, urinary incontinence, increased cervical discharge, normal vaginal secretions of pregnancy, increased sweat, moisture around perineum, vesicovaginal fistula, which is not very common, and loss of mucus plug, and some discharge comes. So they will, middle of night, they will say something is coming out of that. You have to be careful because important to rule out exact true cause of PPRM or leaking. Early and accurate diagnosis would allow us for gestational age-specific obstetric intervention. False positive diagnosis of preterm PRM may lead to unnecessary obstetric interventions. In the middle of night, your residence tells that this patient has come to this, you start various types of investigations. It's better to see, wait for some time and find out whether it is correct or not. A timely and accurate diagnosis of PPRM is critical to optimize the pregnancy outcome. An assessment also requires, it's not a single assessment. A combination of clinical assessment, maternal blood test and fetal heart rate should be used to diagnose and chorioamnitis, which is the commonest complication of PPRM. If RCOG guideline and green top guideline shows that the diagnosis of spontaneous rupture of membranes is made by maternal history, that is first part, and speculum exam is the second part of it. And the role of ultrasound according to RCOG is not very useful, but we nowadays know that it will first thing which we normally like to do when we are not want to do PV examination. Sterile speculum examination is first thing when today we want to do it. Free flow of fluid from cervical legs. Nitrogen test was done routinely when we were students. Nowadays not done, but it is still useful when you things are not available to you. Microscopic fund testing is also important. Fetal fibrinometry, lot of things have been done, but that is mainly not to find out PPRM. It is mainly to find out whether labor is likely to be initiated or not. Active or amniture, it's a recent test I am going to show you. Ultrasonography has definitive role, and transabdominal indigo dye indication that was done long back. Nobody does it now, just to find out whether it's a true leaking or not. Why not to do a digital examination? That's a common thing. Most of the people who are studying now, or first year, second year, third year, they don't like to do PV examination. And for normal patients or for gynec patients, as we all know, they likely directly go for sonography or vaginal sonography, but that is not correct. But here there is a definitive contraindication because latency period between onset of labor becomes earlier and infection on the part. So avoid repeated PV examination. Then comes speculum examination. It was not again routinely done, but sterile speculum examination is very important. No lubricating jelly should be used. Cooling of fluid in the posterior fornix. Free flow from fluid from the cervix can be seen. Cervical dilatation, whether it is there or not, and collect slide for the fun pattern as well as for various other testing. Nitrazine paper, that is one thing which we used to do, and even today also can be done very easily. Normal pH is 3.8 to 4.5 of vagina. A pH of amniotic fluid is about 7.1 to 7.3. So it can be taken, but the false positive are likely to be there when there is urine, blood, semen, or trichomonas is there. You see fun, there is a difference between the fun pattern of the cervix because we see funning in the cervical mucus also. Here the cervical mucus and this funning is different. Other things which can be done, which is done routinely is fetal fibronectin, then insulin-like growth factor, which is done routinely nowadays and very bedside it can be done, and placental alpha microprotein. This will definitively diagnose that there is a leaking when there is a seepage and not exactly. What is the new taste of alpha fetoglobulin monoclonic body that we'll see? The things are very easily available these days. You have to take out the things, then you put the things which come out of it, and vaginal speculum is put and the sample is collected on the smear which is already been given. You sampling, you counsel the patient that we are not going to harm you, we are not going to, you have to be as gentle as possible. Collect the sample with or without speculum. This can be collected very gently. The swab is soft and it's now put it in the vagina that collects about 3 to 5 millimeter of the liquid which can be there. The test procedure is like this. You have to just open the specimen, put the thing inside the solution tube, wait for about 3 to 5 minutes. Swab is vigorously done inside, then take it out and then put your test, just like your urine pregnancy test type kit is there, just put it inside and wait for 3 to 5 minutes. The test is positive, you will get 2 lines. The test is negative, you will get 1 line. This is that simple. Negative results should be read in 5 minutes, and the positive test can be read in about 3 to 7 minutes. So it's a simple bed-tight test and can be done. The first reliable method for detection of the premature rupture of the fetal membranes measures the optimal biomarker, insulin-like growth factor, highly specific for amniotic fluid, blood, semen, urine. Unlike the nitrogen test, this doesn't come in the way. Only amniotic fluid will show. So it will 70 to 80% will say that it is because of amniotic fluid only. Next. Actin PRM rapid test is based on highly specific and unique monoclonal antibodies that bind to insulin-like growth factor binding protein 1, which is present in the amniotic fluid throughout pregnancy. It exists in large amount in amniotic fluid, highly specific biomarker producing residual cells and secretes into amniotic fluid. So this is a very good test and which can be done with bedside, easily available. Cost is about 50 to 100 rupees only. Role of ultrasonography, that is also important part. Though RCOG said it's not very important. 50 to 70% of women with PRM has amniotic fluid volume less than normal. My deduction requires further investigation. Rule out other causes like renal agenesis, uteropresent insufficient, obstructive uteropathy. So these are cases where there is amniotic fluid itself is less, not because of leaking. So that you have to be careful. Measure for pockets of fluid and quantity amniotic fluid volume and AFI. Most important tool for today. How do you manage this patient? You diagnose this patient is already having an amniotic fluid leakage or seepage or PPROM. Preliminary work is important. Gestational age, availability of NICU, fetal presentation, FHI present, and she is in labor or not. So there is a general treatment as well as obstetric treatment. You have to be careful about that part. General treatment, hospitalization, all patients will not agree for hospitalization, but it's better if you can keep in the hospital. Bed rest with bathroom privilege. Bed rest has no importance as far as prevention of premature, but there is a definitely role to prevention of the fluid which is drained out. Curing of clean vulval pad is important. You will see whether there is any infection part of it or blood has come out of it. Broad spectrum antibiotics is a must. Counseling of mother and relatives, that is important because you have to finding some time. And if you are giving expected line of treatment, you have to be careful about that also. Maternal monitoring and fetal monitoring plays a very important role when you are in expected line. Typical for gestation age 32 weeks or less. Antibiotics, tocolytic if indicated for lung maturity, fetal surveillance and majority inpatient observation will be required. Benefits of expectant management of you all know, mature lung profile, advancing gestational age. In few weeks are going to be important for this, the question of life and death. The disadvantage is when you are waiting, there is a chorioamnitis, cord prolapse might occur, abruptio might occur. So to be careful and constant monitoring is required. Management principle is maternal surveillance, fetal surveillance. That is very important and which you are doing every day. So this learned audience, I don't think it will require. NST 39%, not very sensitive at earlier age. PPP 25%, again not routinely done. Abnormalities are predictive of fetal infection, umbilical cord, competent oligohydramnios. Frequent monitoring for oligohydramnios is a must. It becomes too less than it is important. Amnio infusion, which was practiced one time in quite large amount, one abdominal amnio infusion and sometimes vaginal also. Precious pregnancy, patients willing to go for conservative management. Amnio infusion for prolonging latency for few days also. In tertiary care, important there. You have to explain the patient that these things can happen and possible increase in latency from 9 to 21 days and possible decrease in delivery within 7 days, 70 days. This is from Green Top guidelines. So important, not very routinely used, but you have to be careful and all facilities should be available for that. Role of corticosteroids is a very hot topic and everybody has discussed about it. I'll just say a few things. In PPRM, 30 weeks, less than 30 weeks is highly beneficial. 44% less RDS, 53% less ventricular hemorrhage. Necrotizing enterocolitis can also be reduced and less incidence of neonatal death. This is again according to Green Crop guidelines. Betamethasone, what drugs to be used? Betamethasone, dexamethasone. Unfortunately, ideal drug is betamethasone sulfate, which is not available. All things are done in trials in Western countries are with sulfate. We do not have sulfate. We have got other salts is available, so we are not using betamethasone. So people believe that you give betamethasone, both are same. No role of weekly. Some people they give weekly, which is also not important. Not overall. The possible drawbacks are no overall improvement, shorter latency, higher risk of chorioamnitis and neonatal sepsis. Again, antenatal corticosteroid has been approved by ICCOB guidelines and Green-Top guidelines also, and evidence is B and A. Number of trials have shown that they reduce incidence of neonatal mortality, RDS, IVH in neck. Cochrane meta-analysis, a single course of antenatal corticosteroid should be considered, and rescue steroid as a role. If it is more than 6 weeks, then you can give it repeatedly. Role of tocolysis, again, many things have been said. Tocolysis may be used for or equal to 48 hours within concurrent administration of antibiotic and corticosteroid. Useful for transfer of patient to tertiary care. It's not used for very long time. As Dr. Singh has mentioned, don't use it for very, very long time unless you're going to circle adjuvant to prevent it. Role of antibiotic, again, there is a definitive role. Evidence benefits are there. 43% less chorioamnitis and prolongation of pregnancy to a lot of times. The drug which are ampicillin, which is commonly used, erythromycin is another group of drug, ampicillin. The combination of clavulanic acid with amoxicillin should be avoided because it increases necrotizing colitis. Specific is to do culture and sensitivity, give accordingly. Neuroprotection, which is also important these days. ICCOB guidelines says that women with preterm PROM before 32 weeks of gestation who are thought to be at risk of immediate delivery should be considered candidate for fetal neuroprotection. The dose given is, loading dose is 4 gram and gradually 2 gram for another next 12 hours. This is also important. There is a definitive role for this. So all neonatalists nowadays says. What will happen in multifetal pregnancy? Perinatal outcome in worse in multifetal pregnancy than singleton pregnancy, high incidence of infection, short latency period, increased maternal complications with tocolysis and glucocorticoids. One leaking might occur if there is a binovariate twins, leaking might occur in one and the second twin may be normal, but infection can go to both. Higher incidence of cesarean delivery, management is same as well as singleton, so there is no change. Delivery indications, maternal fetal infection, abruptio or cord prolapse, you have to act immediately. Mode of delivery should not be altered only because of PPROM. Malpresentation is more common. Site of tertiary center is also there. Anesthesia, no specific choice, but can be used. You have to be expert anesthesia should be there. Individualized care is important by according to availability of neonatologist or anesthesiologist. Cesarean section. We are always now resorting to cesarean section. More than 36 hours leaking, you do a cesarean section. But that is true or not. For obstetric indications, a gestation age with reasonable perinatal outcome at the attached neonatal unit. That is important. Difficulties you can encounter in the premature babies are thick, uninformed lower segment, uterus retracted or fetus. So you have to be careful while delivering the baby. Extension can occur, bleeding can occur, and adherent placenta is also common because of long-standing leaking. Use of small forceps to prevent slipping of the small size aid is also important. Some people are using vacuum also. But CS better to do early than too late. Don't keep on waiting because baby is slightly premature. Neonatal care is very important. Neonatal center should be there and expert neonatologists should always be there. Sometimes they guide us what time to deliver, how to deliver, especially in Ahmedabad at 26, 27, 28 weeks, we are taking advantage. What are the future pregnancies? There is an increase of recurrent PROM, preterm birth. So you have to be consider cervical length thing, progesterone can also be started. So extra care will be required in next pregnancy when patient comes to you with the previous history of PPRO. In a nutshell, when you want to say confirmed diagnosis, if the things are waiting, then you can wait, otherwise you deliver the patient. I'll finish in a minute. So in summarizing, PPRM is a leading cause of prematurity. Preterm birth is a major contributor to perinatal morbidity and mortality. Accurate diagnosis and knowledge of gestational age are crucial to determining management of the PRM. Gestational age dictates the management. And the key to reducing the adverse effect of PPRM is to make a prompt diagnosis, admission and start by deliver in time. Timely delivery is also important. Thank you very much. The bird will also say thank you. The patient will also say thank you if you can save a baby. Thank you very much.
Thank you very much, Dr. Atul Bhai sir. It was in fact like a legend talking in a legendary hall of Praful Munshi. We all,
Thank you, Kashyap.
thank you
It's not
very much,
necessary.
sir.
You are a legend over here as far as delivery is concerned.
Thank you very much for your excellent talk. And I think I thank the organizers for allowing us to chair the session. Thank you very much again.
Thank you, our all chairpersons, for chairing a wonderful session. Now I request our speakers and chairpersons to please join for a group photograph. Rajesh Desai next. कविता मुझे इसका चाहिए सीवी चाहिए नहीं मेरा नहीं है मैं अभी वो कंपेयरिंग के लिए आई हूँ इंट्रोड्यूस करना
तो सब चेक है आओ सर
Yeah, already. So Kapita ma'am is already left, and even the Archana Basar ma'am. Also. Now I would like to start our next session, session 6, on obstetrics hemorrhage. For this, I would like to invite our chairperson for the session. Our first chairperson is Dr. Chamila. Ma'am, please. Dr. Chamila is ICOG Governing Council member between 2021 to 23, ex-chairman Clinical Research Committee, FOXY 2016-18, National Coordinator UNICEF FOXY PCA, and the National Coordinator MEDHA FOXY PG program. Welcome, ma'am. So our next chairperson is Dr. Yamini Trivedi. Ma'am is a professor and head at AMC NET Medical College, Ahmedabad. Welcome, ma'am. Our next chairperson is Dr. Charulata Bapai. Is a National Coordinator of Breast Committee FOXY, Director James Medical College Endoscopy Center, Pune, and the recipient of the Dr. Smita Jog Award for the exemplary work in adolescent health 2019. Welcome, ma'am. Now I would request our all chairperson to please introduce our first speaker. Professor Ajay Desai, sir.
Good afternoon. With lot of pride and honor, I would like to introduce Dr. Rajesh Desai. I have worked with him for 4 years as assistant professor, and besides anything, whatever may be his designation or whatever, he is a very dedicated, very sincere, and excellent teacher for all the students. Whoever, I think Ashwath, so many students of him might be here in the hall, here or some other hall, and they will agree with me that he is an excellent teacher. Welcome, sir.
Thank you. First of all, I'm thanking the organizers for giving me this opportunity. I'm supposed to talk on HELP syndrome, and it's going to take a very long session. But this morning we have seen that a lot of discussion occurring on HELP syndrome in various halls, also in some of the panel discussions. A lot of controversies have been discussed. So today I'm going to give you the crux of the management based on my experience and what is available in the literature. Friends, this is one of the conditions where we are worried about maternal mortality. This is one of the conditions which mimics so many other conditions, and it is very difficult to differentiate those conditions. And if we are not able to conclude and go for a reasonable differential diagnosis, probably we are going to end up in maternal mortality or morbidity. So that based on that assumption, I'm going to give you some information which is useful to you in your clinical practice. The topic given to me was managing HELLP syndrome, early diagnosis makes difference. Based on this, I'm going to talk today, rather than going into details of crux of the micromanagement of this condition. As you know, H stands for hemolysis, elevated liver enzymes, and low platelet. Evidence of hemolysis in spite of patients not suffering from anemia is very important when you are coming across a patient where you are suspecting HELLP syndrome. So first sign, even if the patient has got good hemoglobin level, if you find there is abnormal peripheral blood smear, bilirubin levels elevated more than 1.2 gram per DL, low serum haptoglobin level, and increased LDH level, especially twice the normal limit, that is more than 600 IU per L. If these are the findings in your patient, probably you are dealing with a case of hemolysis. Together, if you have elevated liver enzymes, where the levels are more than 72 units per IL, or platelet count less than 1 lakh, you are probably taking care of a health patient. Now, what basically this importance of this peripheral blood smear? I'll talk about this peripheral blood smear in details in the later slides. This picture is very important, that having spikes on the RBC, and you also find fragmented RBC, which are known as cystocytes, which are typical of this particular condition. And many times, if you are suspecting HELLP and patient is not suffering from anemia, a simple, good peripheral blood smear will help us to identify that you are probably dealing with a case of HELLP due to presence of these two types of cells. When we talk about the incidence, in oral pregnancy, the incidence is 0.2 to 0.6%. But when you are discussing the conditions among preeclampsia, the incidence is 4 to 12%. While we find that most of the HELLP occurs in the later part of the second and third trimester, while 10% of the cases occur before 27 weeks of pregnancy, one of the major cause of contributing towards preterm birth, as discussed by previous speakers. 70% usually they present between 27 to 37 weeks of pregnancy, and 20% beyond 37 weeks of pregnancy, and few of them even after postpartum. In postpartum period, HELLP usually develops within 48 hours in women, but especially in preeclampsia, but this manifestations can delay right up to 7 days. So if you are suspecting a case of HELLP, you need to follow that patient up to 7 days rather than going for early discharge, which is a trend in private practice, and you may get that patient readmitted in a severe condition. Although variable, the onset of HELLP syndrome is usually very rapid, and that's why it is important. Early diagnosis and proper monitoring will prevent mortality and morbidity in this particular condition. We have two classifications of HELLP. One is Mississippi's classification, where it divides the HELLP into class 1, class 2, and class 3 based on the platelet count. And there is another classification, Tennessee's classification, where you have a complete HELLP syndrome and incomplete HELLP syndrome. In complete HELLP syndrome, all the three parameters are abnormal: the liver enzymes, LDH levels, and platelet. While in incomplete HELLP syndrome, you may come across one or two abnormal parameters. Now, these two classifications are very important for a clinician because they help us to understand the level of the severity of HELLP syndrome. It helps us to understand the prognostication. It helps us to understand whether we should go for conservative management or whether we should go for immediate termination of pregnancy based on the situation where you are working, based on the ICCU or neonatal setup. Maternal complications, maternal and perinatal mortality and morbidity occur more frequently in complete HELLP syndrome as compared to incomplete HELLP syndrome. So as a clinical practice, you need to classify whether it is incomplete or complete HELLP syndrome. And when you are tackling incomplete HELLP syndrome, you are likely to delay the diagnosis because all the features are not present. So suspicion is a key for managing this type of patient. Now, why this is important, why it has been discussed too much? Because 15%, 10 to 15% of the patient will develop abruptio placenta and DIC, while 6 to 8% of the patient will develop pulmonary edema and renal failure. 1 to 2% will end up in ICCU with adult RDS, and we expect 1% maternal mortality, and most of these cases may fall into category of abruptio placenta, DIC, abruptio placenta with DIC, acute renal failure, and pulmonary edema. So they are patients of HDU or obstetric ICU, and therefore they are not the patients to be managed in a non-tertiary care setup. The perinatal mortality and morbidity again are associated with this condition, like prematurity, growth restriction, and absorption of placenta are major causes of adverse perinatal outcome. The rate of preterm birth is as high as 70% because 20% of cases are before 27 weeks of pregnancy and majority are before 35 weeks of pregnancy. 15% will occur before 28 weeks of pregnancy as far as deliveries are concerned in HELLP syndrome. The perinatal mortality changes with gestational age may vary from 7% to 30%. If your HELLP has developed late in pregnancy, probably the outcome is better. The frequency again of neonatal complications like respiratory distress syndrome, intracranial hemorrhage, enterocolitis, and bronchopulmonary dysplasia are also more because of increased incidence of prematurity. Now, what is more important is the manifestation of HELLP syndrome. It is so variable. Most of the time, you always look at the platelet count to diagnose HELLP syndrome, but it is not like that. You are going to, if you focus on platelet count for diagnosis of HELLP syndrome, probably you are going to end up in delay in diagnosis of HELLP syndrome, and probably you may end up in morbidity and mortality. 90% of the patients of HELLP syndrome become present with themselves with general malaise. So any patient is second trimester, late second trimester, suffering from general malaise, it is your duty to carry out a platelet count to identify that it does not fall into that HELLP syndrome category. 65% suffer from epigastric pain, 30% suffer from nausea and vomiting, 31% may suffer from headache, while 90% will have right upper quadrant pain, 30% will have swelling, and hypertension may be mild or may be severe. So if you go through this incidence of manifestations, it is very easy to miss this condition if you go for try to look for standard manifestations of HELLP syndrome. So it is necessary that any of these symptoms, especially general malaise and right upper quadrant pain, you need to evaluate the patient for HELLP syndrome, even though the patient is not suffering from hypertension, because HELLPs can develop without hypertension in 20% of the cases. So it is necessary that we diagnose this condition as early as possible. Because of variable nature of the clinical presentation, the diagnosis of HELLP syndrome is generally delayed for an average 8 days. Not all patients present with preeclampsia. Many women with this syndrome are initially misdiagnosed with other disorders such as cholecystitis, esophagitis, gastritis, hepatitis, or idiopathic thrombocytopenia. So there are a lot of differential diagnoses, and you may think of some conditions other because it is not a classical picture of HELLP. In one of the retrospective studies, what they observed was out of 14 patients which were referred to the tertiary care center, only 2 were correctly diagnosed as HELLP. Means in all referred patients, they are delayed diagnosed. They are admitted without the diagnosis of HELLP, and at your level also it is possible that you may not suspect HELLP because the presentation is not classical. The management is very simple. If it is 34 and beyond 35 weeks of pregnancy, terminate that pregnancy. If the pregnancy is below 35 weeks of pregnancy, right, and if it is suffering from incomplete HELLP syndrome, based on your clinical setup, you may go for conservative management and continue till 35 weeks of pregnancy if the patient remains stable. Below 37 weeks also you can go for conservative management in incomplete HELLP syndrome and continue till the patient is stable. However, whenever there is deterioration of this condition or whenever the patient reaches 35 weeks of pregnancy, it is necessary to terminate this pregnancy because the condition is rapidly progressive and condition is associated with high maternal mortality and morbidity. What is the place of vaginal delivery? In the morning we had a discussion, a panel discussion where one went for a cesarean section below 27 weeks of pregnancy, and other person discussed about giving a conservative management to prolong the life to get a better neonatal outcome based on your setup. But the standard pattern is that if you go for vaginal delivery, it is only considered the cervix is wide, the gestational age is greater than 32 weeks of pregnancy, FHS are reactive, and there are no indications of cesarean section. Now, if you go for vaginal delivery, it is necessary that you may achieve that vaginal delivery within 12 hours. So, delay in vaginal delivery because you are opting for vaginal delivery may lead to adverse maternal outcome. Otherwise, in all cases of complete HELLP syndrome, if the cervix is not favorable, you should go for elective LSCS. Now, some of the important aspects of the HELLP management, platelet count, as you know, that below 50,000 platelet count, you need platelet transfusion. It may have a single donor transfusion, or it may have pooled donor transfusion. If you are using a pooled donor, usually that is available in our tertiary government setup. One unit will increase the level of 10,000 millimeter cube. The survival time of the transfused platelet in these patients depends on the non-immunized recipient, will depend on the severity of the disease, right? So if your disease is mild, probably the count which increases because of this platelet transfusion will stay for a longer time as compared to the patient suffering from a severe disease. The response. Now, if after delivery helps, what do you expect? You expect that within 48 hours, the platelet count should stable, and within 4 days, you may find rising platelet count. Now, here there is a point to be remembered. If after 48 hours, in the case of HELLP syndrome, if you don't find the platelet count rising or platelet count deteriorating, this is a place where you are supposed to suspect two other conditions, and that is TMA, thrombotic microangiopathies, especially TTS and hemolytic uremic syndrome. All these three conditions are have same type of presentation, variable incidence of laboratory parameter dysfunctions, but the two conditions, TTS and HUS, if you have diagnosed them as HELLP syndrome and you have missed them, you will go for high maternal mortality and morbidity. And the other two conditions require multidisciplinary approach, while HELLP has to be managed by an obstetrician. Now, what is the role of OB-ICU? The large majority of patients of HELLP syndrome, when diagnosed correctly, do not require central venous pressure measurements or Swan's-Ganz catheters to monitor their hemodynamics. Careful monitoring of their input-output, pulse oximetry, and periodic auscultation of lungs is all that is necessary to assess the pulmonary and renal situations. The role of steroids. People have given steroids in this group of patients in severe HELLP, and they have recorded improvement. However, the use of dexamethasone to improve clinical course and accelerate the recovery of women with HELLP syndrome has been recommended on basis of uncontrolled observation and clinical trials without adequate power. At present, the corticosteroids are not recommended for treatment of HELLP based on the current evidence available in the literature. Another very important thing is that usually what we are worried when we tackle with HELLP syndrome is disseminated intravascular coagulation. We feel that there is always a coagulopathy when we are tackling with HELLP syndrome. But here there is a controversy. Some believe that DIC is a complication of HELLP. Some believe that DIC does not occur in HELLP. Some believe that in some cases of HELLP, DIC, there is a hidden coagulopathy. So what is the observations of different studies? That whether DIC occurs in HELLP syndrome has controversial. People have accepted it. HELLP syndrome is not a variant of DIC, and all coagulation parameters are usually normal in patients of HELLP syndrome. Some people believe that patients who develop DIC generally do so in complete HELLP syndrome, not in incomplete HELLP syndrome. All patients with HELLP syndrome may have underlying coagulopathy that is usually undetectable. That is observation of some of the other studies. DIC should be suspected if plasma fibrinogen level falls below 300 milligram BL and laboratory abnormalities are also present. So if you have a patient with elevated liver enzymes and you have fibrinogen count less than 300 milligram, probably you are likely to see DIC as a complication of this HELLP syndrome. A positive D-dimer test is in the setting of preeclampsia has recently been reported to be predictive of patients who develop HELLP syndrome. So patients of preeclampsia, 15% chances of HELLP syndrome. You may go for D-dimer, elevated D-dimer, you may suspect that this is the patient who is likely to go for HELLP syndrome, and you may be watchful and you may prevent delayed diagnosis of HELLP. The D-dimer is more sensitive indicator of subclinical coagulopathy and may be positive before coagulation studies are normal. So it is one of the important tests which has to be done in patients of preeclampsia for monitoring and for suspecting HELLP syndrome and for understanding the coagulation abnormalities undertaking in this group of patients. Another important severe condition is hepatic rupture. 90% of the cases of HELLP in physical findings may have right upper quadrant tenderness or pain. In all these cases, you are supposed to go for imaging and to identify whether there is a subcapsular hematoma is present or not. If undiagnosed, these patients can have circulatory collapse and we may have end up in mortality. If at all you are able to diagnose HELLP syndrome with this subcapsular hematoma, or then you have to terminate that pregnancy, and when you open the abdomen, you are supposed to put gel forms and pack that site rather than attempting resuturing of this tear. Because if you attempt resuturing or if you try to touch those areas of liver, subdiaphragmatic areas of liver, you are going to increase the tear, and most of the time you will come out of the, before you close the abdomen, the patient will collapse on the table. So put gauze, gel foam, and above gel foam, pack that area with roller gauze and keep that roller gauze outside. And after 48 hours, we will be able to remove them. And that is how it has to be remembered. So once in a while, I have not encountered any case of hepatic rupture, but it is possible that I have lost patients because of hepatic rupture, which I have not diagnosed. Management and role of plasmapheresis. People say that in severe HELLP syndrome, deteriorating patients of HELLP syndrome, where the patient is likely to have mortality, plasmapheresis is the answer. That you go for plasmapheresis, the patients have recovered from OB-ICCU. But these conditions are also useful. This plasmapheresis or plasma exchange is also helpful if you are suspecting HELLP syndrome with TTS and HUS. You do not know whether the patient is suffering from TTS, HUS or HELLP syndrome. The pictures is mixed up. So in those cases, if the patient is deteriorating, you may go for plasmapheresis to see the better outcome. So the controversies there still remains dexamethasone, which I have already discussed. There is also controversy in conservative management of HELLP. The reasonable guideline is incomplete HELLP. You may continue with conservative management by administration of steroids for 35 weeks of pregnancy and then terminate. DIC as a part of process of HELLP still is controversial and there is among the researchers. So the message was that diagnosis can be delayed due to variable presentation. Malaise or any pregnant woman with platelet count less than 1,50,000, you should always monitor the patient for HELLP. Termination of pregnancy in complete syndrome irrespective of gestational age. Conservative approach in incomplete HELLP. Conservative approach in incomplete HELLP till 34 weeks of pregnancy. Postpartum monitoring for reversal of laboratory parameters should be ensured. Otherwise, you will end up in deteriorating HELLP syndrome and mortality because of delayed diagnosis. HELLP can develop postpartum and manifestation can be delayed till 7 days, as I already told you. What is more important is cystocytes percentage in sustained and deteriorating cases of HELLP. So if you find a patient of HELLP who have delivered and who is not improving, what you are supposed to do, which is a simple diagnostic test available in our setup, is go for cystocyte percentage. Now, what is the importance of cystocyte percentage, right? So what you do is that you count 1,000 RBCs in high power field and identify what is the percentage of cystocyte. Or what you normally expect in HELLP syndrome is 1 or 2 cystocytes may be present in 50% magnification in high power field. So if you carry out, measure that percentage, and if you find that the percentage of cystocytes is more than 8%, probably you are dealing with a case of hemolytic uremic syndrome or TTS, and probably you have now, it becomes a multidisciplinary approach. You are going to encounter maternal mortality. You may encounter, the patient may require hemodialysis. For this, patient becomes a multidisciplinary approach management and with poor prognosis. So if you go for when patients who have recovered, after have recovered within 48 hours, the median cystocyte count was 0.5%. While patients who have not recovered after 48 hours, the median cystocyte count was 5.5%. Patients who have died because of this HELLP syndrome, the median cystocyte count was 39, as compared to patients who have survived, which was only 0.5. So prognostication, do cystocyte percentage count, and you know where you stand. The patient is deteriorating post-delivery when you have suspected HELLP syndrome. The sensitivity and specificity of prediction of TTP, which is an important indication for maternal mortality, it was 80% and 98.7% respectively when cystocyte count was greater than 1.9%. Similarly, the sensitivity and specificity of maternal mortality was 100% and 95.9% when cystocyte count was more than 8.2%. So doing cystocyte count, you know where you stand. You can expect the maternal mortality, you can expect whether multiple delivery approach has to be done. You can expect whether now this is the case of HUS or TT or thrombocytic thrombotic purpura. Yes, there is a test available, ADAM-TS, to differentiate, to confirm these conditions of TTP and HUS, but most of the time, these tests are not available in our setup, and still they are at research level. So early diagnosis and appropriate management is necessary to prevent maternal and perinatal mortality and morbidity in HELLP syndrome. That is what I wanted to say. Thank you.
Thank you very much, sir. That was a wonderful talk. Actually, there is one advance that can help in the management of HELLP, and that's thromboelastography.
Yes,
TEG, if you use, you can actually give the components correctly and bring her out much faster. And that controversy of a conservative management of HELP, I don't think I will agree with that, because sometimes the morbidity becomes much more when you wait on a HELP syndrome and prolong it till 34 weeks, which usually never happens. So how was your experience on that?
See, I do agree with you, but the conservative management is associated with strict monitoring. So you can wait till the patient condition is stable. As you find that laboratory parameters are not improving, or you find the patient is not remaining stable, you may have to terminate the pregnancy. Whether it may be a 28 weeks, 32 weeks, 30 weeks, does not matter. But beyond 34 weeks or 35, 4 weeks of pregnancy, it is not necessary to go for conservative management. Now, this is very important because most of the setup where these patients are coming are government setup. And you have an ICU available with you. And you have an ICU where you have some data that 1 kg baby weight is, the survival rates are good. So we may have that particular moment, we may take a decision to delay the pregnancy for 7 or to 10 days or whatever possible without compromising the maternal and neonatal outcome.
Strict surveillance should be in place.
Optimizing the outcome, both mother and the fetus. But then it has to be individualized, it has to be customized also. And the place where you are working.
And it's supposed to be a complement-mediated disease. So the usage of probably the immune modulators may be the future for this disease, because it's coming much into the picture now.
Yeah, you are right. You see, when such type of conference, when we are discussing such type of conditions which are very common, and which has been faced by so many private practitioners in rural sectors also. So we usually focus on things which are available, which they are able to do. You understand? Because I want them to remember only those conditions which they are able to manage their patients in a better way, because the ultimate goal, our goal is to reduce the maternal mortality. And in our state, we are supposed to push now below 7, it is already 71, we are supposed to go to 50 and match with Kerala. So every help is important for us to prevent mortality. So safe management and what is available, we
do the best.
That was my focus of the talk.
And you put up a very practical point on the imitators of HELP syndrome. And that's the moment you deliver, you think everything is fine, but actually it's not. So monitor the patient for at least 72 hours, because these imitators will cause problems, both HUS and TTP, and plasmapheresis definitely helps. I had a patient with catastrophic APLA, who her platelets dropped, and she had hematuria. With plasmapheresis, we could totally bring her out. So plasmapheresis is very good for all those 3 conditions.
I particularly mention this because in private sector also they are managing health now. And they are supposed to shift the patient as soon as after 48 hours they find that the patient is deteriorating. But most of the time in the private practice in rural sector, they discharge the patient early.
Yes, that you should never do.
If they are managing these patients, they should wait for 7 days.
Yes.
Before discharging those patients.
HELP does not stop with the delivery of the baby. It goes on for a long time. Thank you so much, sir. Thank you so much.
Sir, you have proved my saying that he is a very good teacher by detailed explanation in this subject. Thank you very much, sir.
So our next speaker for the afternoon is Dr. Alka Pandey, madam, who is an MD PhD. She is the Associate Professor, Department of OBGYN, Patna Medical College. She has been the Joint Organizing Secretary of AICOG 2014, Organizing Chairperson of BOGSCON 2014. She is most importantly the Vice President-elect FOXY 2022. She's a member Governing Council ICOG. She has been the Chairperson Practical Obstetric Committee FOXY 2015 to 17, and she is the National Corresponding Editor of JOGI 2020 to 2023. So what better speaker we could have than Madam to talk about safeguarding interests of mother and the fetus. Welcome, ma'am.
Thank you, madam, for your kind words. And first of all, I extend my heartfelt thanks to Dr. Alpesh Gandhi and ICCOB team for giving me this opportunity. And esteemed chairpersons and august gathering, a very good evening. I have to talk on APH, safeguarding interest of mother and the fetus. So, APH is defined as bleeding from or into the genital tract occurring from 24th week of pregnancy and prior to birth of the baby. It complicates 3 to 5% of pregnancies and is the leading cause of maternal and perinatal mortality and morbidity. 1/5 of very preterm babies are born in association with APH. Now, the causes of APH are placental causes, extraplacental causes, and unexplained. The placental causes form the bulk, that is 70%, placenta previa, abruptio placentae, and extraplacental causes, cervical polyp, carcinoma cervix, varicose vein, local trauma, and vasa previa. So what are the risk factors for abruptio placentae and what is abruptio placentae? Premature separation of normally situated placenta is abruptio placentae, and the risk factors are multiparity, advanced maternal age, low socio-economic condition, smoking and drug abuse, hypertension in pregnancy, trauma, sudden uterine decompression, short cord, circumvallate placenta, folic acid deficiency, hyperhomocystinemia, placenta over a septum or a submucous fibroid, thrombophilias, and prior abruption. So premature placental separation is initiated by hemorrhage into the decidua basalis. Thrombin generated following decidual hemorrhage triggers the action of matrix metalloproteinases, inflammatory cytokines, and the coagulation cascade. Now, types of accidental hemorrhage or abruptio placentae are revealed, where blood insinuates downwards between the membranes and the decidua, concealed, where the blood collects behind the separated placenta or collects in between the membranes and decidua, and then there is the mixed type. So, clinical classification of abruptio placentae: grade 0, where the clinical features may be absent; grade 1, where the vaginal bleeding is slight, uterine tenderness may be minimal or absent, maternal BP and fibrinogen levels are unaffected, FHS is good. Grade 2, vaginal bleeding is mild to moderate, uterine tenderness is always present, maternal pulse is raised, BP is maintained, fibrinogen levels may be decreased, shock is absent, fetal distress or even fetal death occurs. And in grade 3, bleeding is moderate to severe, uterine tenderness is marked, shock is pronounced, fetal death is there, and associated coagulation defects or anuria is present. So complications of accidental hemorrhage in the mother may be is of course hemorrhage, shock, blood coagulation disorders, oliguria and uria, PPH and puerperal sepsis. And in the fetus, the fetal death ranges from 25% to 100% due to prematurity and anoxia due to placental separation. Now, management, prevention of known factors, that is early detection and treatment of hypertension, avoidance of trauma, then avoidance of sudden decompression of the uterus, then avoid supine hypotensive syndrome, and routine administration of folic acid should be done. Now, treatment, the patient should be shifted to a well-equipped maternity unit, and we have to assess the case well regarding the amount of blood loss, maturity of the fetus, patient is in labor or not, presence of any complication, type and grade of the placental abruption. So, management options are immediate delivery, management of complications, and expectant management. So the emergency measures which we have to take is blood is immediately sent for hemoglobin and coagulation profile, that is fibrinogen level, FDP, prothrombin time, activated partial prothrombin time, and platelets, ABO and RH grouping, urine for detection of protein. Then Ringer solution is started with a wide bore cannula and arrangement of blood transfusion is made, and close monitoring of the maternal and fetal condition should be done. Vaginal delivery is favored in cases with limited placental abruption, facilities for continuous fetal monitoring, fetal heart rate tracing should be assuring, and prospect of vaginal delivery is soon. So induction of labor is done by low rupture of membranes followed by oxytocin drip. Now, what are the advantages of amniotomy? It initiates myometrial contractions and labor process, better compression of spiral artery to arrest the hemorrhage, then reduces entry of thromboplastin into maternal circulation and reduces the risk of renal cortical necrosis and DIC. When you have to do a cesarean section, what should be the indications? Severe abruption with live fetus, amniotomy could not be done, prospect of immediate vaginal delivery despite amniotomy is remote, amniotomy fails to control bleeding, and appearance of adverse features. What should be the anesthesia? Regional anesthesia is generally avoided when there is significant hemorrhage. Now, expectant management. In cases of chronic abruption, where bleeding is slight and has stopped, fetus is reactive and remote from term, continuous EFM can be obtained, betamethasone is given to accelerate fetal lung maturity, tocolysis with magnesium sulfate may reduce further separation, and further separation of placenta at any moment may cause fetal death or maternal complications, and this is the major risk of conservative management. Now, management of complications. Hypovolemia should be corrected early. At least 1 liter of blood transfusion should be minimum when diagnosis of concealed accidental hemorrhage is made. Patient is monitored by CVP. Hematocrit should be at least 30% and urinary output more than 30 ml per hour. And DIC is to be managed with FFP, cryoprecipitate, platelets, PRBC are used to correct the DIC. And anti-D is given 300 microgram to combat feto-maternal hemorrhage in Rh negative women. Now, placenta previa. When the placenta is implanted partially or completely over the lower uterine segment, it is called placenta previa. What we used to study was type 1, low-lying, lower margin of the placenta encroaches onto the lower segment, but not to the os. Type 2, marginal. The placenta reaches the margin of internal os when closed but does not cover it. Type 3, incomplete or partial placenta previa. The placenta covers the internal os partially. And type 4 is central or complete. Placenta completely covers the internal os even after it is fully dilated. Now, the revised classification is that low-lying placenta is placenta lies within 2 centimeters of the internal os but does not cover it, and placenta previa is placenta covers the internal os. Now, what is dangerous placenta previa? That is type 2b. Major thickness of the placenta overlies the sacral promontory, thereby diminishing the AP diameter of inlet and prevents engagement of the presenting part. This hinders effective compression of the separated placenta to stop bleeding. Placenta is more likely to be compressed if vaginal delivery is allowed, and more chance of cord compression or cord prolapse is there. Now, what is the cause of bleeding? Placental growth slows down in later months and lower segment progressively dilates. The inelastic placenta is shed off the wall of the lower segment, and this leads to opening up of the uteroplacental vessels. Symptoms are the sudden onset, painless, causeless and recurrent bleeding, and signs are that size of the uterus is proportionate to the period of gestation, uterus is relaxed without any area of tenderness, malpresentations are common, then the head is floating and fetal heart sound is usually present. Slowing of the fetal heart rate on pressing the head into the pelvis, which soon recovers promptly as the pressure is released, is known as the Stallworthy sign, and vaginal examination must not be done. Diagnosis is by ultrasound, and ultrasound for fetal anomaly scan is the initial procedure. Now, monitoring of the placental position. Follow-up TVS is indicated when the placenta covers or is less than 2 centimeters from the internal os at 32 weeks. If the placental edge is more than 2 centimeters from the internal os, the placental position is reported as normal. Color Doppler examinations are useful to confirm the position of the placental edge and rule out placenta previa, vasa previa. And if the placental edge covers or is less than 2 centimeters from the internal os, a follow-up TVS should be done at 36 weeks. At 36 weeks, if the placental edge covers the internal os, cesarean birth is scheduled. And if the placental edge does not cover the os, but is less than 2 centimeters from the os, Risks and benefits of trial of labor should be discussed with the patient. Now, excluding the placenta accreta spectrum. Ultrasound findings of placenta accreta are multiple vascular lacunae within the placenta, loss of normal hypoechoic zone between the placenta and the myometrium, decreased retroplacental myometrial thickness less than 1 mm, abnormalities of uterine serosa bladder interface, extension of placenta into the myometrium serosa of bladder, turbulent lacunar blood flow is most common finding of placenta accreta spectrum on color Doppler imaging, and MRI is not very important to diagnose this placenta accreta, but it is important to diagnose posterior placenta previa to assess the depth of invasion in suspected percreta. So, to differentiate between concealed type of accidental hemorrhage and placenta previa, we know that there may be the shock and bleeding may be out of proportion. The anemia and the shock may be out of proportion to the visible blood loss in the concealed or mixed variety of abruptio, whereas it is not in cases of placenta previa, and the uterus is board-like, has become very rigid, and fetal heart sound may be absent in cases of accidental hemorrhage, whereas in cases of placenta previa, the height of the uterus is proportionate to the gestational age, the uterus is soft and relaxed, malpresentations are common, and usually FHS is there. The complications of placenta previa may be that there may be high maternal and fetal morbidity and mortality, and maternal complications are APH with varying degrees of shock, malpresentations, premature labor and early rupture of membranes, intrapartum hemorrhage, increased incidence of operative interference, then PPH due to imperfect retraction, large surface area of the placenta with atonic uterus and placenta accreta, death may occur due to massive hemorrhage, there may be retained placenta, and during puerperium, sepsis, subinvolution and embolism. Fetal complications may be preterm labor, fetal growth restriction, asphyxia, IUD, birth injuries and congenital malformations. So how do we manage? Reducing the risk of bleeding, digital cervical examination should be avoided. Avoid any sexual activity that may lead to orgasm or direct trauma. Avoid moderate and strenuous exercise, heavy lifting or standing for a prolonged period of time. Then inpatient versus outpatient monitoring of patients of placenta previa. Most of these patients can be managed on an outpatient basis until vaginal bleeding occurs or until admission for scheduled CS is planned. Patient-specific risk factors need to be taken into account, such as when the cervical length is less than 25 mm, the patient is at increased risk for preterm labor. Hospitalization is recommended if cervical length is less than 15 millimeter, then rapid cervical shortening that is more than 10 millimeter over a 1 to 2 week period, inability to get to the hospital within approximately 20 minutes, and lack of home support, and patients with 1 or 2 episodes, bleeding episodes can be discharged, but patients with 3 or more bleeding episodes need hospitalization till delivery. A course of corticosteroids should be given 48 hours before planned cesarean section, less than 37 weeks of gestation. And cesarean section should be performed at 36 plus 0 to 37 plus 6 weeks of gestation in uncomplicated placenta previa. And acute care of bleeding patients, maternal and fetal assessment, maternal BP, heart rate, respiratory rate, O2 saturation and urine output are closely monitored. Fetal heart rate is monitored continuously for patterns suggestive of hypoxemia and anemia. Blood loss is quantified. CBC, ABO grouping, RH typing, cross matching, 2 to 4 units of PRBC should be ready when bleeding is heavy or delivery is likely, and evaluation for coagulopathy should be done. Stabilization is by IV access and giving crystalloids in a bolus. 1 or 2 large bore intravenous lines are inserted and crystalloid is infused to achieve and maintain hemodynamic stability and adequate urine output. Now transfusion. Transfusion of blood products in patients with active bleeding should be guided by the volume of blood loss over time, changes in hemodynamic parameters, coagulation studies, and hemoglobin level. A failure to rapidly correct tachycardia or hypotension with a normal saline bolus or a hemoglobin value less than 10 gram per dl should prompt immediate transfusion. 2 to 4 unit of cross-matched RBC without FFP or platelets as long as fibrinogen level is more than 250 milligram per dl and platelet count is more than 1 lakh per microliter. Goal is to achieve hemoglobin more than 10 gram per dl. If the patient fails to stabilize, we initiate a massive transfusion protocol, and if not available, or negative blood can be given. If the patient continues to bleed, 1:1:1 ratio of PRBC, FFP, platelet should be given. Tranexamic acid is generally not administered before delivery because it freely crosses the placenta. But this is controversial, I think. Now, expectant management. Vital prerequisites are availability of BT whenever required and facilities for cesarean section round the clock. Selection of cases. Maternal hemoglobin should be more than 10 gram, pregnancy less than 37 weeks, no active vaginal bleeding, and fetal well-being is assured. Expectant treatment is by giving bed rest, hemoglobin, supplementary hematinics, then gentle speculum examination, tocolysis. If uterine contraction, to give steroids for 48 hours only, and sucklage is not helpful to prolong pregnancy. Now, indications for delivery. CS is indicated for active labor, non-reassuring fetal heart rate, severe and persistent vaginal bleeding. Max self for neuroprotection is a common practice for pregnancies less than 32 weeks, and anesthesia is for scheduled CS birth. Regional anesthesia is preferred. In actively bleeding patient or who require an emergency cesarean, general anesthesia can be given. Now, cesarean delivery should be done at a tertiary care center with an adult and neonatal ICU, multidisciplinary team, senior obstetrician, anesthetist, midwife. Then counseling should be done. Consent for CS, anesthesia, BT, organ removal should be taken. 2 to 4 units of PRBC should be available. Engorged vessels on the anterior lower segment bleed profusely when they are cut. In anteriorly situated placenta, the placenta has to be cut or separated to deliver the baby. Umbilical cord should be clamped immediately to prevent neonatal hypovolemia and anemia. And once the placenta is separated and delivered, the lower segment should be inspected for oozing. Then management of placenta. Preoperative or intraoperative sonographic localization is helpful in determining the position for the hysterotomy incision. And if the placenta covers the cervix, a transverse or a vertical incision may be possible. Management of PPH is by pharmacotherapy, that is oxytocin, methargine, carboprost, misoprostol, carbetocin. Tourniquets can be tied tightly around the uterus as low as possible to occlude the uterine vessels, and treat focal bleeding if present by hemostatic square sutures, application of Monsell solution, placental site injection of vasopressin, and placement of fibrin glue or patch over the area of oozing, ligation of uterine and utero-ovarian arteries, intrauterine balloon tamponade, and uterine compression sutures. In refractory patients, internal iliac ligation, arterial embolization, and hysterectomy might have to be done. In placenta accreta, during cesarean section, the incision is made away from placenta. Baby is delivered without placental separation, and in MAP without bleeding, placenta may be left in situ. Any attempt of placental separation may cause massive hemorrhage, which may lead to hysterectomy. Methotrexate has not been found to be useful. Controversial is placement of ureteric stent with noted bladder involvement and placement of balloon into the pelvic arteries. In cases of heavy bleeding where uterus is to be preserved, internal iliac ligation, arterial embolization, pelvic packing, or balloon tamponade can help. And some people have reported that removal of placenta en bloc by surgical, 1 minute please, by surgical excision followed by repair of the defect, hysteroscopic resection of placenta, and high intensity focused ultrasonography also has been tried, and antifibrinolytic therapy, then cryoprecipitate, fibrinogen concentrate and factor 7A, antibiotics, intensive hemodynamic monitoring in postoperative period, and continued vigilance for ongoing bleeding, renal failure, liver failure, unrecognized bowel bladder, urethral injury and pulmonary edema. And one thing what I wanted to focus was management of unexpected placenta accreta spectrum. If you suspect that you have opened a case of placenta accreta, then the case should be temporarily paused till optimal surgical expertise arrives, and stabilize the patient and transfer if there are inadequate facilities. And vasa previa, this is the last slide. The unsupported umbilical vessels in filamentous placenta lie below the presenting part and run across the cervical os. These vessels are torn either spontaneously or during rupture of the membranes. Color Doppler is helpful for diagnosis. Antenatal admission should be done at 28 to 32 weeks of gestation. Delivery should be by cesarean section, and BT may be needed. So, thank you very much.
Thank you so much, madam. That was indeed an exhaustive presentation. Obstetric hemorrhage is indeed a nightmare for each and every obstetrician, and you have covered it intensely. I would just like to make one point about the visual assessment of blood loss, because we can go very wrong in that. And so, you know, you have these charts which can be put up in your labor room. And nowadays,
we have drapes also.
Weighing machines also can be kept in your
labor
room.
We have a drape, which has been devised by Dr. Devdas and in Kerala also.
Fantastic.
And the blood is collected in that drape to approximately give a correct estimation of blood loss.
Absolutely.
Wonderfully talked as always, Salka ma'am. Actually, one slide I saw on short cervix. You have a short cervix and a placenta previa. What option you have? Because if you suffered a previous preterm delivery.
So you don't have any option. You can't give any this cerclage. So you have to keep in the hospital, monitor the woman and her fetus, and when it comes out, you have to refer it into the ICU.
Any progesterones?
Progesterone, we are giving.
Something to try.
Yes.
Thank you so much, ma'am. Thank you. It's my honor to introduce the next speaker, Dr. Ashwath Kumar, a very passionate obstetrician. He's done so much good work as a Foxy chairperson of the quiz committee in 2012 to 2015. He is presently the ICOG Governing Council member. He's doing tremendous work in the PG program, the MEDA Foxy program. He's the main coordinator for that. He was the vice president of Foxy in 2019. And he has won so many awards, the DC Datta Prize for Best Publication in 2019, the CS Dawn Prize for Best Presentation All India in 2006. And he has authored so many books, and he is a great teacher and a great academician. And we are waiting for his talk on ectopic pregnancy, the usage of blood there. Thank you so much.
Good evening, everybody. Respected chairpersons, I am very happy and fortunate that Alper sir is here to listen to my talk. And in front of, it is actually, it is my coming back to my home. It is like Ahmedabad. I studied in BJ Medical College, did my fellowship from GCRI. So my teacher, I am the student of Ajay and Yamini madam here. So my one teacher is my chairperson, and other teacher is my co-speaker. So very proud to be standing in this podium. And my friends Kasi, Nitin, all are here to encourage me to speak. So thank you all for coming for the meeting, and Charmila, Charlie, everybody are my friends only. So first of all, see, ectopic pregnancy, the patient is coming in shock. See, first 2-3 slides we will be going fast because nothing is there to diagnose. First case is a very simple case. I will be very practical going through cases which I have seen. Okay, in different types of ectopic pregnancy which has come in shock. So first case, if you see, she is a 41-year-old, came with giddiness and she fall at work actually. She had UPT positive, she was a third gravida, and she was for 11 months amenorrheic. And she had pallor, extremities were cold, pulse rate was 122, 30 pulse, and the BP was, when she reached the hospital, BP emergency BP was 86/40. Respiratory rate was high, 22 per minute. SpO2 was maintained, afebrile. Abdomen as usual was distended, umbilicus central. And on palpation, tenderness in the right iliac fossa, there was some guarding was there. No mass was, left iliac fossa, sorry, mass was palpable. Speculum, there was uterus appeared soft, but there was cervical motion, tenderness, and there was fullness. See, these are all normal ruptured ectopic, what will you see? So initial, you check the mentation, you check the skin perfusion, pulse, BP, pulse pressure. We will come to it as it's a, I thought it's a case of obstetric hemorrhage. I immediately added few slides on shock actually. While Charmala was asking on TEG and all, I thought I will add some few slides which will be beneficial for you all. So urine output was measured. Naturally, emergency, they took hemoglobin, hematocrit, pH, lactate, base deficit, and just ABG was done basically. And it was sent for ROTM. We will come to it. ROTM sample, cross-matching was done. USG was in emergency, showed hemoperitoneum. Naturally, 2 wide-bore needles were, crystalloids were, RL was started, fast-tracked, massive transfusion, like my president ran to the transfusion department to bring 3 pints of blood, platelet and FFP. Okay, so immediately the scan was done in the, scan showed ruptured left tubal ectopic, and there was a hematoma with moderate hemoperitoneum was there. Patient was taken for, I'm a laparoscopic surgeon, I can do laparoscopy as fast as laparotomy. So laparoscopy was taken, patient left salpingectomy was done, 1.5 liter, 3-pint blood transfusion was done. Play the video. Play the video. Okay, so this was what when the laparoscope was put. This is what massive hemoperitoneum all around, and naturally you can see. I will go little fast forward. So you can see the blood was being sucked inside. So all, and you can see the left tubal ectopic. Why this is dark is that naturally when there is a bleeding inside, the whole appears to be dark, and you have lifted it. So, and finally salpingectomy was done, and you can see the materials. Basic principle of surgery is that you have to go inside fast and controlled. Once you cut it, you would have all seen that once you cut that tube, ruptured tube, immediately everything comes to normal. So whichever you are comfortable, you do laparotomy or laparoscopy. So this clinical triad and all these things we will just skip, which we told how the patient presents. And see, one thing about if you don't have an access to the ultrasound, may not be there everywhere it is there, then there is some role for cultosynthesis. Otherwise, there is no role for cultosynthesis. In our postgraduate days, we would have done 18-gauge cannula was put into the pouch of Douglas, just to say that the fluid was tapped out, and it say that, okay, it is hemorrhage. Nowadays, ultrasound is there. So please, why the ultrasound is important in ruptured ectopic is not that you have to keep in mind of something called heterotopic pregnancy. That is why for the postgraduate sitting here, anybody is there just to, for them, how do you differentiate between a gestational sac, and you have to know this because gestational sac is usually towards in the below the midline, that is below towards the end, it is not in the center. Gestational sac will be always round, double ring. On the other side, maybe ovoid and a single ring. We say double ring sign and all due to decidua. And the color flow, if you put, it will be high, and the other pseudo sac, it will be avascular. These small things you should know. Then we will come to points actually for you. See, in the emergency department, there is something called POCUS, point of care ultrasound in shock. So this is a portable machine which have to be there in ultrasound. So what here, there are different types of machines are there. See, what we use is a rush, that is rapid USG in shock, to know that, okay, there is fluid inside hepatorenal pouch, there is fluid, and that is what is called a rush. Focus is a cardiac function and access. So basically what you see is that, one, there is fluid or not, two, you have to see the IVC collapsed or not. These are the 2 points you see. It will be, if you are trained, it's not difficult. As you are doing a lot of scans, it is not difficult at all. Another point which you have to remember is that you have to remember about the differential diagnosis of a ruptured corpus luteal cyst. So whenever a patient comes with ectopic amenorrhea, not ectopic, shock with hemoperitoneum, always there is a condition called corpus luteum can bleed. So patient has to be asked about all the anticoagulant drugs he is taking or not. All these things are very specific. Many times a patient taking anticoagulant can come with bleeding from a corpus luteal cyst, and it exactly mimics like an ectopic pregnancy. So you have to rupture chocolate cyst in pregnancy. All these things has to be torsion. All these things have to be kept in mind when the patient comes in shock. You have to because the topic is shock, and something I will tell you about the anti-shock treatment. So here IV line is made. You put crystalloids are started immediately, as madam was telling, grouping, and Foley's catheter. Initial assessment we will come to it. See, basically when you have a patient in shock, what are your things you have to be careful? You have to do an intravascular volume resuscitation, ensure adequate oxygenation, that is ABC, what you mean. Then you have to do a lactate, ABG, cross-match, monitor with non-invasive monitoring is enough. You don't have to go for invasive monitoring in a ruptured ectopic in shock. Fluid warmer, forced air, hot air blanket you can put over the patient. Maintain the systolic BP between 80 to 90. It doesn't mean that everybody should know that in shock and obstetric shock or any shock, there is nothing like you have to make the systolic BP normal. You have to maintain it between 80 to 90, fluid therapy. And all of you know that nowadays dopamine has come down. We use noradrenaline. So noradrenaline, see, everything is simple. One ampule, you put it inside 1 pint of 5% dextrose and run it at a rate of microdrops that you will be having 20 drops per minute. Nothing is there. So that is what, then comes adrenaline, and then only comes dopamine. So noradrenaline, the advantage is that it doesn't cause tachycardia. So that is why very safe, please, international guidelines, everything has changed from, so if you are using dopamine, you will not see dopamine in my labor room or ICU. It is the next level only you may. So this is how you maintain, I told you. This is just a classification of shock for the postgraduate sitting here. This is pasted in our labor room just to know that looking at it, suddenly you know that, okay, patient is serious or not. That is what this classification is. Nothing much is there. So another point which you have to see, conscious of the patient. Patient is disoriented in shock means it's something serious. Okay. So the patient is telling irrelevant things. That is what you have to be see. Then something called capillary refill, what you can see, but it's not a reliable measure. But if you see, if it is normal, is less than 2 seconds. If it is waiting, it is a simple thing. Then systolic BP drop is a late sign. So don't wait for systolic BP drop. It's a late sign. So narrow pulse pressure suggests a significant blood loss. So this, why in postgraduate exams they ask you why there is a narrow pulse pressure is important. The simple thing is that with the diastolic, whenever there is a shock, there is increased diastole from compensatory increase in catecholamine release. This is just for the postgraduates. Okay, you have different types of things. You have the shock index. These are all simple. It's heart rate by systolic BP is what is shock index. So you can have, it is more than 0.9 predicts that acute hypovolemia even in the presence of a normal heart rate and a BP. ROP means nothing. It's you divide the pulse rate by pulse pressure. So if it is more than 3, it had a positive, and less than 3 had negative predictive value of a decompensated shock. So finally, you are monitoring a patient in shock. Urine output less than 0.5, cold peripheries, capillary fill more than 2. There is confusion, patient is having confusion, systolic BP less than 80, mean arterial pressure less than 30, and cardiac index is nothing, cardiac output by body surface area. So usually you know that 4 is the cardiac output, means body surface area it comes. So it is always it should not be below 2.5 is the normal value. It comes 5 by 2.5. So if it comes below that, below 2, it's considered to be. So why you want to measure the cardiac index when you are given vasopressors and all, you can adjust the dose according to that. And left ventricular end-diastolic pressure more than. So why ABG? 1 point you see for the acidosis, base deficit and lactate. Lactate is only an indirect measure of hypoperfusion. So anyway, these are things are done very fast. That is why. Then you come to see whatever you have done, platelet or INR, or these are not thromboplastin time, may not be effective in coagulopathy. There comes the advantage of TEG or ROTAM. There comes the advantage of TEG or ROTAM. See, if you get results in fast, TEG is nothing, it's a thromboelastography. There are only certain things which have been clotting time. It's a clot formation. There's a clot stability that I measure. You get the results very fast, and what is the advantage of using TEG or ROTAM? All of you should know is that, see, otherwise you do massive transfusion without any control. Here the advantage is that massive transfusion, there are many problems. You cannot give FFP like what you want. 10 FFP, it can cause pulmonary edema as well as TRALI. So that is the reason why this comes. Most of the cities have this. So don't say that most of the hospitals are buying this machine and they are used to it. So don't say that it's not available. You are not used to it, that is the only thing. So be used to it. They will give you correct assessment that, okay, patient needs only, though here comes the advantage of cryo. See, I sat in a panel with the person who has introduced TEG from Germany. So I sat in a ROTAM with him. So he was telling that we don't do any platelet transfusion nowadays, unnecessary. And we don't give FOP, only what we give is a cryo. So unless each clotting factor you will be able to know. Only one thing what you may have to add is the factor 7. That when comes, then that is the only thing. So it's a very wonderful, just for take home you can have. So these things we will go to certain few cases and we will finish. So here you know that in ruptured ectopic it is a laparotomy. Leave. 5 cases I will tell you and we will finish. Okay. This is another interesting case. 35-year-old woman, 13 weeks pregnancy with history of 2 previous section and 1 ectopic for which salpingectomy was done. She complained of lower abdominal pain radiating to right shoulder, giddiness, and she had a fall in the bathroom on the previous day. Bedside USG showed a live fetus and moderate free fluid in the abdomen. In the hospital where she was, she had fever also. They suspected septic shock actually. Imagine. Sepsis and antibiotics was started, her urine output was decreasing, her shock was worsening, so she came to our hospital. Very sad case. In the emergency, USG was done. USG also they told placenta is separated, something abnormal in the lower segment, and there is moderate hemoperitoneum. You took the patient for laparotomy. Laparotomy was done. We are seeing it was a scar ectopic which has ruptured and the placenta is coming out. Removed that, sutured it. By the time when you separating the bladder got injured, I sutured the bladder. Sad thing is that after doing all these things, while coming out, patient had a cardiac arrest and patient expired. So only thing what I want to tell you is that scar ectopic is something, as the cesarean rates are increasing, how many times we say that decrease cesarean rate, decrease cesarean rates are going to increase only. So as the cesarean rates are increasing, naturally all these things has to be careful. Cesarean scar pregnancy you are going to see. So you have to know. This is for postgraduates. Just say cesarean carbon is 2 type, endogenic and exogenic. Just once goes inside and once goes outside. So ultrasound is a main important thing. Please, when you do an ultrasound, do it properly, which you yourself look for all these things. You see inside, and the most important is the thin or absent myometrial layer between the gestational sac and the bladder. You see that, and see all these things. What are other things are there, which will be. So whenever you have, it's a ruptured case, you have to go for excision, and sometimes you may have to go for hysterectomy. But unruptured cases you can manage accordingly. You can excise laparoscopically also very easily. You can manage. Only thing you give vasopressin, ligate the uterine artery, go and cut it, and finally you can suture it and come out. So this is another Cornwall pregnancy due to lack of time. This is another case. We have a video. Video here. Lack of time. I will just skip through the video. This is a Cornwall pregnancy which came ruptured. So see, you can see the whole sac is out, the patient was in shock. Laparoscopy was done. Luckily, my anesthetist is very cooperative. That is why. So the full sac uterus is, fetus inside the sac is there. Almost it was. So it was removed and then it was sutured properly. Cornea, whenever it is done, it should be sutured properly. And it is, every specimen was taken through the pouch of Douglas and sutured. This was another rudimentary horn pregnancy, which was ruptured, and the patient was, here also you can see, not moving, you can see vasopressin was injected. Finally, you can see the rudimentary horn is being, initially before excising it, I have put a suture around the rudimentary horn, and then only I cut it, and then suture it. So a suture is tied so that the vascularity, otherwise it will be very vascular. And properly you have to suture it. You do through the laparoscope or laparotomy, you have to suture it, otherwise cornea next time. So you can see here how tight, so it become, the whole, it has become avascular, vasopressin, this, and the right lateral side I had already cut that so that the blood supply to the lateral wall is not there. So we go, this is enough actually, the lack of time. Then the next case, it's a very interesting case. 36-year-old, 28 weeks, referred from a local hospital, decreased vital movement, they were telling. Coming here, I was not getting any, pallor was there, patient was in shock, pallor was there, vague mass, 12 into 12 centimeter below, and the uterus palpable, fetal parts are palpable. Uterine cavity was empty, was fetus lying inside, 22 weeks with absent fetal heart. See, here what to take emergency, the first, only 2 cases in my life, last 20 years I have seen. This was an abdominal pregnancy. 16 weeks, there was a rent over 4 centimeter, dead fetus in the sigmoid mesentery, and full of tortuosomental vessels attached over the fetus and placenta. And the fetus, you can see, rent was fundus, rent was excised and freshened up, and 3 layers was. Previously, I had seen one case in which we could not see, never try to pull the placenta if the placenta in abdominal pregnancy is outside. If you try to pull the placenta, it will bleed like anything. So what we did, we are finishing. What we did, we removed cut it, left the placenta inside. And I was every week, I used to call the patient, see the scan. And most important thing is that infection. Okay, so patient was asked to report. Luckily, after 6 months, still 6 months, almost every week I used to do scan myself, because I was afraid that I have left something inside, it would have gone. Nothing happened actually. Later she did not become pregnant or anything. Later it went on and she is fine. Patient is now also under follow-up. So that is 15 years back actually. After that I saw this 2 months back. So this is after. Then the last case. I'll leave all this thing. Last case is that a previous cesarean admitted in the family planning ward in a hospital where MTB was tried at 8 weeks pregnancy. That doctor attempts to dilate the cervix, bleeding start, patient goes in for shock. So from the hospital, doctor with the whole team came to, I was standing in the casualty. Never in my life, PPH I have seen this much bleeding. I have full that from the ambulance itself, it was full blood on the trolley everywhere. So I was not knowing what a perforation will not cause this much bleeding. So just put the scan, I saw it was a cervical pregnancy. So imagine a cervical pregnancy can bleed. The classical feature of a cervical pregnancy is classical feature of a cervical pregnancy is the internal os will be closed. Okay, only one sign you see, internal os will be closed, like hourglass pattern and all these things we say, internal os will be closed and the pregnancy will be below the internal os. What I did was that I tried Foley's catheter, I tried packing of the cervix, after nothing worked, and finally hysterectomy was done. But if you have a facility of uterine artery embolization, this is my last slide, uterine artery embolization, it's an ideal case if you could detect a cervical pregnancy, uterine embolization. We have tried in other cases, if the patient, you are able to detect early, you can give mifepristone, you can give methotrexate, all these things are available. But this is that. So this is the last slide. Thank you. I could share some of my views with you.
Thank you so much, Dr. Ashwath. Suppose you have a person who just comes with maternal tachycardia and you suspect an ectopic. You think it's a tubal abortion. How will you wait on the tachycardia? Will you wait and see, or you will rush and do a lap and see what's happening?
No.
Only
Tachycardia alone doesn't matter at all. We see the other things. See how much bleeding has occurred.
There's no evidence of rupture or anything like that. It's
Nothing.
just
You wait. Nothing. You wait, and the tachycardia persists. It may come down. Usually, it doesn't go. If whatever bleeding has occurred, only tachycardia doesn't have to bother at all. All the other signs. Then your tachypnea is there. You do the ABG. ABG values are abnormal. Then only you can try with a methotrexate. You can wait. You can give a shot of methotrexate. See the beta HCG level. That's what we do.
Will it cause repercussions later on, like infertility or something like that? Because you leave that.
Nothing. We have seen patients becoming pregnant afterwards also. So methotrexate is an excellent drug. So in a case of unruptured ectopic, but you have to admit the patient naturally. See, to that extent, my share as you about everybody don't think that methotrexate is a safe drug. When I was doing post-graduation here, I used to go back. I always like to visit my medical college. So it is the funniest incident which I had. First time I visited, so from here I go there. My madam used to discuss there, medical college students will be, I have come from Ahmedabad, what is the management there? So I have to take class to them. How wound is managed in BJ Medical College, how PPH is managed, all these things I share to them. So when I went there, I saw a patient who's fully bald, very nice, good-looking patient, but I thought that she has shaved her. Then madam told that this is a case of ectopic pregnancy, which we had given methotrexate last week, and she has gone for aplastic anemia. Everything is below 1000. Okay, and full hair was lost. She was there for 1 month. She recovered. Same patient next year. You will not believe. Next year in a holiday when I went. Madam was in the OT, entering the OT. I was called into the OT. Madam, you come inside, change and come inside. Same patient lying on the table with a ruptured ectopic, and this is for the first time I saw what is autotransfusion. I had not seen autotransfusion because massive and no other way that patient was having that anesthetist who was a very senior anesthetist. So what they used to do is that the blood was and the gauze was kept. It was over the gauze and it was a bottle, glass bottle poured and it was given. Nothing happened to the patient. 3 pints of blood like that auto transfusion was done. So that is the first time I saw, and the patient was saved. Then I passed from BJ Medical College and I joined Jubilee Medical College then the patient came there and she delivered. So all these things are, life methotrexate, don't think that it is till then I thought that methotrexate, what is it? Give methotrexate. So once I saw a patient, that patient would have died actually. Everything was below 1000 actually. Counts were all below 1000. And platelet was 10,000, less than 8,000 or 6,000. Every factor was below. So all these things, and then we give method. Then she had children. She had 2 children. After that, also she became madam's patient.
No, I'm saying not for a tubal abortion. You never give methotrexate.
No. If there is persisting tubal abortion, you give. When is that? You monitor the beta HCG, and beta HCG levels are still high or going high. Whatever your same criteria, we can give a shot of methotrexate. So even you do a salpingostomy nowadays. We don't encourage too much salpingostomy. You have to monitor beta HCG, and if I do salpingostomy, I give a shot of methotrexate. Okay. Yeah, so I am safe, and I do regular. See to it that the follow-up is done regularly. If I am doing salpingectomy, it doesn't matter at all.
Thank you so much.
Thank you.
Thank you so much. Very nice explanation. Now it's my honor to introduce the next speaker, Dr. Dipesh Dholakia sir. He is one of the pioneer in NDVH. When nobody knew NDVH, nobody could think NDVH can be done. He was doing an excellent NDVH, and many people might have learned NDVH from him. Welcome, sir. He was organizing chairperson in AICOG 2017, and he has a lot of academic interest also. Welcome, sir.
Thank you, Chairperson, for a kind words. Though I am a vaginal surgeon, here I am for abdominal surgery.
Actually, sir, I wanted to add, whenever anybody is in stress, they remember you. So you are here today for this topic.
So today's topic for me is obstetric hysterectomy. By definition, emergency obstetric hysterectomy is defined as extirpation of the uterus either at the time of cesarean section or following vaginal delivery or within the puerperal period. It is usually performed in the face of unrelenting and life-threatening obstetric hemorrhage. It's a final weapon. Removal of uterus after delivery or at the CS or performed within the 24 hours of a delivery. Obstetric hysterectomy synonym is caesarean hysterectomy or peripartum hysterectomy. Obstetric hysterectomy, by history, the first documented hysterectomy on a patient at caesarean section was performed in United States by Horatio Storer in 1869. Although the uterus was removed successfully, the patient died in 68 hours after surgery. The Eduardo Porro, the head of midwifery school in Milan, in 1876, this Porro has described the first caesarean hysterectomy in which both mother and baby survived and the mortality decreased to 60% when there was a mortality of 100%. So in Primiparous dwarf, Julia Cavallini, after CS, instrument called centrus constrictor passed over the neck of the uterus and the wire was sufficiently tightened to control the hemorrhage and the uterus was then cut away. The stump was brought out through the abdominal wound which was closed with sutures or silver wire, and modifications of these techniques was done by Godson in 1884 and Lawson-Tate in 1890. So we all know the common indications: emergency obstetric hysterectomy in atonic PPH, rupture uterus, secondary PPH due to sepsis, abruptio placentae, vesico-uterine rupture, inversion of the uterus, and elective obstetric hysterectomy in the cases of placenta accreta syndrome, carcinoma of the cervix, choriocarcinoma, and some elective obstetric hysterectomy in the cases of big fibroid with pregnancy. So good obstetric care, can it reduce the hysterectomy?
So I'm extremely sorry to interrupt you, sir. There's no synchrony between the slide here and what sir is talking on. The one slide ahead you're going on actually. I'm sorry to interrupt. The console has to. One slide ahead sir is going.
So same, તો 11 પેજ જ આવ્યું છે.
The page bolna. Don't use this. Use this up and down key. Okay. Down key for next, up key for previous.
So by incidence, I sorry for the interruption. Good obstetric care, can it reduce the hysterectomy, whether antepartum, intrapartum or postpartum? Increase in the incidence of peripartum hysterectomy between 1997 and 98 and 2005, there is a rising incidence of the obstetric hysterectomy. Decision for the hysterectomy. All medical measures have failed. It's as a last resort. Only experienced one can arrive at proper decision of conservatism or radicalism. Proceed. to save the life, early start of DIC, when blood and blood products are not or less available, when still general condition is stable, try one surgical measure, and that is hysterectomy. Surgery early rather than late. Hysterectomy is early rather than late to save the morbidity and mortality of the patient. Time is very critical. Every second, every minute is counted. Hysterectomy should not be performed too early or too late. Obstetric hysterectomy for PPH. Obstetric hysterectomy saves lives in catastrophic rupture of the uterus or intractable primary postpartum hemorrhage. Nisupriya et al. In his study claims out of 24,213 deliveries and 16 obstetric hysterectomies, 56.25% of emergency hysterectomies were done for atonic PPH, which followed 31.25% for rupture uterus. The PPH is the most common indication for obstetric hysterectomy in the study of Kant Anita et al. And Dr. Raghunathan Bhattacharya et al. Obstetric hysterectomy for morbidly adherent placenta. Nowadays, this becomes more common to do obstetric hysterectomy. This indication, we have to do more and more hysterectomies. A morbidly adherent placenta conditions together constitutes approximately 1 in 2,500 pregnancy. Kastner et al. And Parnaswari et al. And Bhavna Sharma et al. In a study claim that morbidly adherent placenta is the most common indication for obstetric hysterectomy. In a study of Marwaha Parvin et al., morbidly adherent placenta was the second most common indication in 6 women. Obstetric hysterectomy for uterine rupture, though this becomes now less common. Uterine rupture is a serious complication, is threatening the pregnant woman and her fetus. In a study by Marwaha Parvin et al., rupture uterus was the most common indication for cesarean hysterectomy, particularly in the rural obstetrics. Also, rupture uterus is the most common indication in the study by Sirotkar SD et al., accounting for 36.58% of the cases. Now, preparatory steps for the obstetric hysterectomy. Consent is must after explaining each and every consequences after hysterectomy. Adequate blood and blood products should be available. It's arranged so full antibiotic coverage. Expert anesthetics team is ready, and it's a multidisciplinary team including physician, intensivist, vascular surgeon, neurosurgeon, and emergency medical team must be on call. Now the types of the obstetric hysterectomy. It is not always possible to do total abdominal hysterectomy as the patient general condition is often poor. In a study conducted in Sirotkar et al., in 62% of the all patients, subtotal hysterectomy was performed. In the study by Jairam et al., 80.7% underwent total abdominal hysterectomy and 19.3% underwent subtotal abdominal hysterectomy. Same way, Clark et al. And Zorlu et al. Has found that there is no difference in blood loss and operating time on comparing total hysterectomy with subtotal hysterectomy. So we should try as total hysterectomy all the times. Operative difficulties. What are the operative? It is not gynec hysterectomy, it's a obstetric hysterectomy. So the factors you have to keep in mind: uterus is very enlarged, there is thick vascular pedicles, pelvic tissues are edematous, friable, risk of loose nodes and cut through of the cervix. Full dilatation, difficult to identify the margins of the cervix and vagina. Separation of the bladder, particularly in the cases of the previous cesarean section and adherent placenta, it is difficult. Pelvic vascular changes. Uterine is 5 times enlarged, veins are engorged and tortuous, and collateral vessels have emerged. So in advanced labor, there is a necrosis and devitalized tissue cut through when you suture. Planes are easier, but the pedicles get separated from the uterus. Pedicles are very soft and cut through of the pedicles is commonly occurs. So let us make this procedure easy by some tips. We all have performed this. Now you know the Safety tips in the obstetric hysterectomy. Midline vertical incision, uterus is exteriorized, clamp, cut and drop technique, which is described by Mikkel and Plauchi, that when there is a time is the matter, you have to go as fast as possible. You just clamp, cut and drop and get the uterus out as quick as possible. All pedicles ligated as close to the uterus and cervix as possible. It's a sliding off technique. You have to just slide your pedicles and just remove the uterus. Keep adequate size of the stem so the pedicles is not squeezed. Round ligaments should separately ligated. So particularly these are the young patients. So you round ligaments should be as close as to uterus. So you don't take the ovaries in your next clamp. Cornual and vascular pedicles are ligated doubly, proximal simple ligation and distal transfixation. Clamps on the vascular pedicle should be manipulated as little, otherwise the tear of the tissue and more bleeding can occur. Remain in midline while dissecting the bladder, in particularly in primary Perez patient, and laterally, particularly in the cases of the previous cesarean section. Laterally there is a dilated venous plexus of Santorini that may bleed and give more bleeding. Adhesions of the bladder in lower uterine segment requires a sharp dissection all the times. Define the lower limit of the cervix, making an incision in the lower segment or through the lower segment cesarean section incision. Uterosacral should always be excised and sutured as a separate pedicles, not in the single pedicles. When tying last cardinal ligaments, take angle of friable and edematous vagina in it to prevent the angle bleeding. So my dear friends, always angles in obstetrics should be respected like angels. So you should be very careful to taking angles in every surgery. This is the schematic representation of the obstetric hysterectomy. This is a transection of the tubo-ovarian ligament. We always try to preserve the ovaries because they are the young patient. So don't take ovary in your pedicles. Transection of the uterines, this is very important. Uterines are very tortuous, very vascular, and always apply 2 clamps and remain as close to the uterus. Cardinal ligaments is very important, it is very vascular, and you always take separate clamp for the cardinal ligaments and uterosacral ligaments. If cervix is fully dilated, palpate the upper vagina and pinch it to the cervix with your hand, one hand in the lower uterine segment. You just pinch the cervix and vaginal wall and hooking the finger between cervical rim and vaginal wall through the cesarean incision. Bolt closure. So after completing the hysterectomy, bolt closure is very important. It's very vascular things. Each of the lateral vaginal fornices should be secured with uterosacral ligaments and cardinal ligaments. Hemostasis by continuous locking suture. Intraperitoneal drain, we are putting usually 2 drains. So this is a method of bolt closure. Sometimes we are keeping the bolt open. We are taking the continuous suture, locking suture on the anterior and posterior vaginal wall separately and keep one drain vaginally also. Safety of the bladder. In such cases, bladder wall is very edematous. Protect it. Keep one mob between the bladder and Doyen's rectector. Bladder is a very forgiving organ, but still always think of that bladder is a wife and ureter is our girlfriend. The bladder is at risk in previous cesarean section. The ureters can be clamped, suture or stitched where they pass under the uterine vessels at the lateral aspect of the lower segment. The incidence of urological injuries with the peripartum hysterectomy is between 1.6% to 8.5% in various studies. So before closure of the abdomen, inspect pedicles carefully. Hemostasis is very important. No peritonization. Keep the pedicles open. Keep the pedicles clean in the abdominal cavity. Keep always 2 drains, one deep in the pelvis and one superficial. And the important thing, count mopes in these medico-legal eras. Don't forget to count of the mopes. Otherwise, you have done everything fine. But if you have forget mopes, you have to fight in the court for the medico-legal purpose. And check for vaginal bleeding. I always see, before closing the abdomen, I always see from below. If there is any vaginal bleeding is there or not. If you confirm there is no more vaginal bleeding, then and then you close the abdomen. I want some answer from you people. No? Clues is dying. The answer is this.
69.
So uterus 69 babies can be delivered from the uterus. So uterus is very important organ for the female, but still for the life-saving procedure, you have to chop out the uterus to save the life of the mother. Now, what about subtotal? Whether subtotal hysterectomy or total hysterectomy? Leaving the cervix for secretions, moist vagina and no dyspareunia. It's a simple, safe, quick and less blood loss. Avoid injury to the bladder and ureter. Subtotal hysterectomy not advised when there is a placenta previa accreta, there is a tear extending in the lower uterine segment, cervical tear, vaginal tears, bleeding from the cervical stump or tissues lower down may continue, and then there is further more bleeding and you have to explore it again. Future risks of cervical stump carcinoma, keep in mind that may require pap smear regularly later on. PPH can be from more than one causes. This you should not do subtotal hysterectomy. Complication, all of you know, maternal morbidity, there is a high morbidity, it's a long time surgery, there is anemia, acute renal failure, puerperal sepsis, paralytic ileus, wound disruption, urinary tract infection, prolonged hospital stay, pulmonary embolism, sometimes maternal mortality due to DIC, multi-organ failure and ARDS. BT-related complication, blood transfusion is the most common adjunct therapy and therefore increases the risk of blood transmitted disease such as hepatitis B and C and HIV. So in conclusion, it's a most effective in persistent uterine atony, morbidly adherent placenta, badly damaged rupture of the uterus. It should not be delayed until the patient is in extremes. Delay in carrying out the procedure, it's more dangerous to the patient than the procedure itself. So what you need to do, prompt restoration of circulating volume, blood bank, obstetric ICU backup should be there, experienced obstetrician and anesthetist team should be there, but do not forbid patient and her relatives for perfect counseling and explaining what is going on inside the operation theater. So obstetrician on the spot is the real judge and one should be cared for saving life rather than criticized for tackling the situation by performing the peripartum hysterectomy. किसी को भी बोलना बहुत easy है कि ये क्यों किया hysterectomy, but the person who has done that hysterectomy, he is the final authority to do that hysterectomy. Diagnose placenta previa accreta, MRI, elective and semi-elective peripartum hysterectomy in modern obstetrics. Residents in the obstetrics must be adequately trained to perform these difficult but life-saving procedures. Obstetric hysterectomy has always been a nightmare scenario for most of the obstetricians because this procedure is an end of the road measure. It is necessary to be 100% sure that obstetric hysterectomy is the only answer before going for it. The improvement in modern obstetrics and newer modalities of treatment for PPH and conservative management of morbidly adherent placenta has decreased the incidence of obstetric hysterectomy. Obstetric hysterectomy will never disappear completely from the practice of the obstetrics because new techniques are not guaranteed to be successful in all the cases. Thanking you all for the kind attention. This poem, when one has undergone the obstetric hysterectomy, there is no womb in my pelvis for clots, cramps or pain. Goodbye, troubled uterus, you were driving my brain. I will miss your bloating and bouts of mood swings. I will miss your cramping and clots as big as duckling. Goodbye, little uterus, your job has now been done and I am free to live my life and have some well-earned fun. Thank you very much for the kind listening.
Thank you so much, sir. Thank you. Actually, we wanted to make a comment. If the bladder is the wife and the girlfriend is a ureter,
yeah, definitely,
the
madam.
mop should be the mother-in-law. Be very careful about the mother-in-law when you're doing an obstetric hysterectomy. And what Dr. Ashwat said makes sense here. Like your Barkett's classification becomes very important here. When you're going to class 2 hemorrhage, keep your theater ready. You will have to go for a conservative procedure to stop that bleeding. Class 3 hysterectomy should be done. Do not cross class 3, then you will not get blood enough to save that patient. Thank you so much for a practical talk, sir. Thank you so much for that. And we would like to thank Dr. Alpesh Gandhi, sir, for the opportunity and my co-chairpersons.
Thank you so much.
Dr. Trivedi and Dr. Charulata. Thank you so much.
And can we have a group photo of all the speakers, please?
Medical college is a problem.
Nice, huh?
So coming to the last session, miscellaneous. It is a mixed bag of topics here. I'd like to invite the chairperson for it, Dr. Sushma Bakshi Madam. Madam has come from Baroda and she's the chairman, Fertility and Aging Committee of IMS. She's a patron member of PCOS Society of India, past president of ICCOB, past teacher at Baroda Medical College, and she's a WHO fellow at Harvard, Boston also. Welcome, madam. Next, we have Dr. Ritu Joshi. She's a senior consultant at Fortis Escort and Surya Hospital at Jaipur. Vice President Foxy in the year 2014. She's also the chairperson Family Welfare Committee of Foxy from 2009 to 2012. She's been a faculty at various national and international conferences. And Dr. Anshu Raina. She comes all the way from Noida and she also holds various responsible posts in our society and is a very active member of FOXY. Welcome, madam.
अरे तू चेयर कर रही है, तू कहाँ है?
Handing over to you, chairpersons.
Now I would like to call our first speaker, Dr. Sapna Sa. She is going to talk on the compression of the uterus. And she is a professor at SVP IMSR Srimati NHL Municipal Medical College, Ahmedabad. Dr. PP Seth Gold Medal awarded by Srimati NHL Municipal Medical College. And she is a Dr. CS Dawn Prize for a best presentation of the paper at 44th AICOG held at Ahmedabad in year 2000. Achieved a Member of the Year award for year 2000 and 2009 for the outstanding effort of activities in the professional field presented by AOGS and special interest in high-risk obstetrics, USG and the endoscopy. So please, ma'am.
Thank you, chairpersons. Thank you, madam. At the offset, I am very much thankful to Dr. Alpesh Bhai and team for giving me this opportunity, and same time I congratulate him for excellent workshop and conference. This is my hospital where I am working since last 30 years. My talk is on uterine compression sutures, and all of us know that PPH is the most common cause of maternal mortality, and more than 500,000 deaths mostly occur due to PPH within 24 hours of delivery each year. You can see the maternal mortality ratio, and in India 2016 to 18 it is 113, and you can see the European countries where it is in single digit, and the goal of WHO to reduce maternal mortality in 2030 is 70 per 1 lakh live birth, and in any country at any cost it should not be more than 140. All of us know that active management of the third stage of labor prevents PPH by 40 to 50%, and this is the standard definition according to book. But whatever the amount of the blood loss which is more than the expectancy of the obstetrician, he or she should be vigilant. There should be pulse in 2 digits and blood pressure in 3 digits. So blood pressure should not be less than 100, pulse should not be more than 100. That is very simple, basic. Now what we miss exact estimation of the blood loss, and that will cause delay in the diagnosis and delay in the treatment. Now another important thing, we miss 4 stages of the labor that we have to watch strictly, and the level of consciousness, pulse, BP, SpO2, uterine tone and urine output. The earliest sign is tachycardia. Whenever there is a hypotension, you are little late. Yesterday we listened oration, and this is the first response bundle for the PPH. Simultaneous use of oxytocin, isotonic crystalloids, tranexamic acid and uterine massage. If PPH is refractory to this primary treatment or first bundle, give aortic or bimanual compression, use anti-shock garment and intrauterine balloon tamponade. This is not only important to shift patient from private or periphery to institute, but also important in institute for shifting patient from labor room to OT. Still bleeding continues, go for laparotomy, and don't hesitate to open the abdomen within time and do conservative surgery, selective devascularization or uterine compression suture, and if possible, it's fine. Otherwise, patient is still bleeding, go for radical surgery, that is the obstetric hysterectomy. Now, all of us know the Billings-Chaw and Hammond sutures. It is particularly useful as it is simple in application. Even any resident can do it. But the selection of the case is very, very important. It has a life-saving potential, relatively safe, and has capacity to preserve the uterus and future fertility. If the how we select the cases? If you do bimanual compression of the uterus and if bleeding stops, your suture will work. Even in DIC, we can, during surgery, if there is coagulation failure, so along with this, bimanual compression will stop the bleeding, so you can apply the suture, but it doesn't replace the medical management. Now, I am not going to discuss how to apply, but the 2-3 important points. The right-handed surgeon should start Billinge from left side, left-handed surgeon should start from right side. Second important point, with each puncture, you have to pull the thread. Don't pull the threads simultaneously after puncturing all the things, otherwise the tissue is soft, it will get cut through. Third important point, whether to close uterus first or tie Billinge first. Practical point is you have to tie Billinge first. After tying, see that the bleeding has stopped. But sometimes it is difficult to take angle. So secure angle before tying Billinge and then suture the hysterectomy wound. Once properly applied Billinge, there will be control of bleeding. Which suture material will you use? Chromic catgut was preferred by Billinge when he started it. Then he shifted to monocryl number 1. Vicryl should never be used because there are chances of, as it is delayed absorbable fluid, there are chances of intestinal adhesions or intestinal obstructions. Now, how it acts? It acts by causing continuous vertical compression on the uterine vascular system, and maximum suture tension lasts for 24 to 48 hours. Meanwhile, bleeding stops. So even though suture gets loose due to involution, no problem at all. Now, most important thing, compression suture after vaginal delivery. Now, once you open the abdomen, whether you will open the cavity or not. If you don't want to open the cavity, that is the Hammond suture you can take. But it is better to open the cavity, explore uterine cavity, remove any placental tissue if it is there, any clot is there, evacuate it. You can diagnose any abnormal site of placentation, or if there is any decidual tear or damage, that can be taken care of. If you open the cavity, there will be a proper placement of compression sutures, and also you can avoid the occlusion of cervical canal that may lead to hematometra, pyometra and its related morbidity. Now, what is the place of prophylactic uterine compression suture? Especially when there is a multiple pregnancy, triplet, quadruplet, undue enlargement of abdomen. You can take it, and Billinge has taken prophylactic suture in triplet. But most important thing is careful counseling and pros and cons of this suture. Now, when Billinge will take care of upper segment bleeding, but sometimes there is an implantation of placenta in the lower segment. So for that lower segment, vertical compression, transverse compression sutures can be taken, or you can take, if there is any bleeding from sinus from anterior wall or posterior wall, you can take individual anterior wall compression suture, posterior wall compression suture, or anterior and posterior lower segment together. Even lower segment bleeding can be taken care of with associated intrauterine balloon. Now, this is a study of 2012 where all over world almost 1,800 procedures were carried out, and failure rate was only 32 out of them, which may be due to wrong selection of case. One case had placenta percreta. There was uncontrolled DIC. No preoperative test was done and not properly applied, and delayed application. Most important, you have to act in time. That is very important. Now in this slide, you can see the normal endometrium and myometrium in the MRI in longitudinal sagittal section and as well as the transverse section. And this patient is delivered after 2 years vaginally. The success rate is 98%, and RCOG and Cochrane is recommended this uterine compression sutures. So it's invaluable, cost effective, and you can use therapeutic as well as prophylactically. Now, Cho has done little bit modification, and he innovated multiple square sutures or the postal stem suture in 2000. The devising, innovating this suture, the principle was that he was believing that entire cavity, when it is occluded, the drainage is compromised and proper compression is also not taking place. Suppose there is a placental sinus tumor bleeding. So only one jaw suture can take care of. There is no need to compress whole upper segment. That is the advantage of the jaw suture. Suppose there is a focal placenta accreta. There is a passage of vigorous DNC and the placenta is adherent only on anterior portion or near cornu. You can take only one jaw suture and you can treat the condition. Cho has performed 23 cases and he found pyometra in one case, Asherman in one case, and because of multiple puncture of the uterus, this is a foreign body, so there is an inflammatory reaction sepsis, and he found necrosis in one case. I'm not going to discuss the technique, how to take. Again, same, you have to pull the thread with each puncture, and the role of assistant is very much important when you are tying either bilge or jaw or hymen. Assistant has to press uterus very carefully, and the first note should be double and it should be stepped by your assistant. So stitch should not get loose from very beginning. Now this was the case where there was bleeding from the local site where there was focal placenta accreta and single jaw has taken care. Now in hymen suture, the suture passed from anterior to the posterior aspect and one suture is taken over the uterus, another is taken, and both of them, they are tied over the fundus. And depending upon the width of the uterus, 1, 2, 3 or 4 hymen stitch can be taken. Again, this will take care of only upper segment bleeding. Suppose there is a lower segment bleeding, it will be again taken care by horizontal stitch. Now, this is very, miracle, but the most important thing is the post-operative follow-up. Suppose patient gets fever on 3rd day, 4th day, you should be careful. You should rule out sepsis. That is very, very important. So this is the case where a patient required bilge as well as Gunshila global stitch, and she had persistent pain in abdomen. There was uterine tenderness, persistent bleeding, and MRI shows anterior wall necrosis of the uterus, required laparotomy and hysterectomy. This is another case where CT scan show on day 5 there is a gas bubbles and there is a necrosis, and again end result was hysterectomy. This is the third case where after hymen there is the early ischemic changes. You can see the necrotic area, and this is after hymen stitch. So my advice is not to take 2 types of the suture at one point. The people are taking jaw, bilge at both. You take for upper segment you take a jaw or the bilge. For lower again jaw or simple uterine compression, anterior posterior wall sutures. So don't mess up 2 sutures at one site. That is very, very important. This will lead to hematometra, pyometra, then remote complications. In many cases, there is no observed uterine distortion. The endometrium is normal, myometrium is normal usually when you see with the 3D ultrasound or MRI. But still cases have been reported where there is a distortion of the uterine anatomy in form of either shape, there may be vertical groove, uterine muscular defect of varying size and depth. So this is very important. Now this case, this patient had undergone cesarean section. At that time there was primary PPH and she was managed with the bilge and jaw, and then she had 2 abortion, and then in fourth time there was elective cesarean section, and after delivery when the exteriorization of uterus was done, you can see the very large anterior wall myometrial defect of 12 by 5 centimeter, and on on this side there is a posterior wall defect. Now this can lead to rupture even in future pregnancy. So strict post-operative follow-up is must. That includes pelvic ultrasound, sonohysterography to identify the uterine wall defect as well as intrauterine adhesions. And 3D ultrasound and with or without MRI will find out the integrity of the uterine wall. When I was searching the literature, I found 3 cases of uterine rupture where primary primary surgery during first cesarean section, there was uterine compression sutures were taken, and the rupture was in next pregnancy at 20 weeks, 32 weeks, and 33 weeks. Out of them, one had also placenta percreta at that site. So this is very important, and you should counsel later on with the patient. Then one of the remote complication is the intra-abdominal adhesions after uterine compression sutures. There is no systematic review about the rate of intra-abdominal adhesions following this surgery, but there is a 7-year cohort in which they have included 28 women with a cesarean delivery, 7 had repeat cesarean section, and 3 had minimal intra-abdominal adhesions. But GHAN et al. He found statistically significant intra-abdominal adhesions after uterine compression sutures for primary postpartum hemorrhage. Another important aspect is the secondary infertility, which may be due to intrauterine synecdoche, and hysteroscopy will give good result and improve the reproductive outcome. But we had, I will discuss later on, we had 2 patients with intrauterine synecdoche in our series. This is very important. Maternal morbidity risk following uterine compression placement for the PPH management should require a hospital-based debriefing between the obstetrician and patients before discharge. Means what happened, why these stitches were taken, whether it requires 2 types of the suture, then what is the short-term consideration and what is the long-term consideration. So you have to explain everything before discharge. At our institute, from January 2007 to 2021, means last 15 years, we had 33 cases that required uterine compression sutures to manage atonic PPH or partial focal placenta accreta bleeding or placental sinus bleeding. 31 required during cesarean section and 2 cases needed after vaginal delivery. This is our standard protocol to manage the PPH. Still it has continued. Then we go for uterine compression sutures. Either we prefer O'Leary or VSGH technique of Dr. A.C. Raval for uterine artery ligation. If required, also ovarian artery ligation, not in infundibulopelvic but near the meso-ovarian. In our series, we had less febrile morbidity only in 2 cases. No, not a single case required emergency hysterectomy, and we came across intrauterine adhesions in 2 cases. 8 cases used contraception, 9 conceived, lost for follow-up 5 cases, secondary infertility in 3 cases, 2 developed intrauterine synecdoche. In 1 patient, we divided with the hysteroscope and she conceived. Second, we advised her surrogacy. Recently done 8 cases. Now this is the very much interesting case, and we have to take uterine compression sutures after twin delivery. At 12 p.m. she delivered in the OT, first baby, 12:10 minutes, second baby. After 20 minutes, 12:20, placenta delivered. Then there was torrential hemorrhage. Monitor was on. We gave all these uterotonics. We asked for blood, started crystalloid, fast. Still there was bleeding. We put intrauterine pack after bimanual compression. We put pack. Within 15 minutes, pack also soaked. Her pulse from 90 to 120. Her blood pressure from 130, 140 systolic got down to 100. I opened the abdomen in semi-lithotomy position, and to my surprise, the uterus was almost hourglass shape. There was distended lower segment. So first I opened the visceral peritoneum, pushed the bladder down. Then I did uterine artery ligation on each side with O'Leary technique. Then I asked my assistant to remove pack from vagina. There was bleeding, so again at lower level, I ligated uterine artery. Still it was bleeding, so I ligated ovarian. Then I opened the lower segment. Upper segment was flabby, but there was no clot. The lower segment was full of clots. Remove all the clots. There was some bleeding, significant bleeding from the lower segment. So I took vertical compression sutures on each side of the lower segment, involving anterior wall, posterior and anterior. So compressing the lower segment on each side. And as the upper segment was flabby, and it was a twin pregnancy. So there was, huge uterus. And it required 4 jaw sutures. Bleeding was under control. There was little oozing from the central part of the lower segment, which was taken care by putting pack. Close the uterus, and we have to pack vagina just for counter pressure. After 24 hours, I removed pack. There was no bleeding and she did well. But in such type of patient, I prefer higher antibiotics for 5 days. I don't want fever. That will cause my tachycardia. And the uterine compression sutures. So it's really highly effective, straightforward emergency procedure which conserves the uterus in the patients with atonic PPH, and it can be performed by each and every gynecologist. Most important thing, debriefing between the obstetrician and patient before discharge, what we have done for her, and strict post-operative follow-up. Thank you very much.
Thank you, ma'am, for an excellent presentation with a very interesting cases. At this point, I just want to include one thing. The things, whenever we are doing these kind of sutures, most of the time we are doing during emergency situations. Because of the pressure of all the emergencies, the tendency of taking a suture and tightening, compression is in mind. Compression is the thing which we have to do, and we just forget about how much the compression should be given. And because of that reason, the post-op complication, as you mentioned in your presentation, that thing can be happen. So it's just to keep in mind whenever we are doing this procedure, it should not be like as much as possible we can give the compression. Only we have to know how and how much we can. So again, it should be done by all the gynecologists, should know all the gynecologists, obstetrician, but how much pressure should be given, that is also to be known.
Yeah,
so
definitely. I had one patient, and she was operated in periphery. She had PPH, and she was having preeclampsia. Surgeon managed nicely. He took billing, he took jaw, and even they have ligated anterior division of internal iliac artery. She came with irreversible shock at our institute and she died within half an hour. But at that time, you are right, enough compression, the same time there should not be vaginal bleeding. Even after compression, if there is a vaginal bleeding, go for obstetric hysterectomy on same sitting. Don't reopen the patient. It is very difficult to save the patient with repeat laparotomy. So,
very true.
Same.
Whenever we are dealing with any type of obstetric hemorrhage and abdomen is open, so ask one assistant to give compression on aorta, externally only. Give compression on aorta, pulse pressure will immediately go down and it will miraculously help you in managing the patient. So this is a very good suggestion, that ask one person just to have a fist and just put firmly on the aorta. That will help.
Bilateral compression as well as aortic compression. Both of them can be given. Once you put your fist inside the anterior fornix and posterior abdominal wall, that will also cause stretch the uterine vessels. Again, yesterday that
so indirectly it helps in taking a suture in a better manner. So indirectly it helps in that.
So point well taken, certainly. Thank you, Dr. Sapna. It was interesting 33 cases of review.
Thank you, madam. Thank you so much.
I'm sure that, all these kinds of difficult cases of obstetrics and the suturing and everything would not have been possible unless we have the last speaker who generally comes first in operation theatre, Dr. Himanshu Mehta. Thank you very much for consenting to be part of this important critical care conference.
I'm happy to say that he's a senior cardiac anesthetist of more than 30 years standing, and he has done pioneering work in the field of cardiac surgery and cardiac anesthesia. And Dr. Mehta right now is associated with prestigious UN Mehta Institute of Cardiac Sciences as a senior consultant and mentor in the Department of Cardiac Anesthesia. I'm aware of his vast experience on anesthesia. I'm also hoping that you are also giving some time of yours for obstetric anesthesia also.
Good evening, everyone. I take this opportunity to thank the organizing committee of this conference to invite me to deliver this talk. At the same time, thank you, Chairman, Chairpersons, for this very generous introduction that you have given about me. This is a place where I work these days. Since about 2 years only. Previously, I was doing freelance cardiac anesthesia plus a bit of OBGY and all other practice. There are a couple of disclaimers here. There are no financial implications of this talk. At the same time, more importantly, I'm not an obstetric anesthesiologist per se, but I'm married to an obstetrician, and which has made me aware about the crisis in, as you know, obstetrics itself is a tongue twister, and obstetrician is even more so. And if you add up anesthesia to that, I'm sure the matters can really get very complicated. But still, I would like to give my insights on this topic. So apparently, I'll be talking on complications of neuraxial anesthesia, which are regional techniques, spinal and epidural anesthesia, concerns related to general anesthesia, fluid resuscitation, and emergency preparedness. As far as regional anesthesia is concerned, we all have faced these PDPH, post-dural puncture, hemorrhage, spinal cord and nerve root injuries, epidural abscess, hematomas, cardiovascular complication, extensive blocks, etc. Post-dural puncture headache is one complication which is created by an anesthesiologist and treated by the obstetrician, more often than not. We hardly ever see any patient coming to us with PDPH. Patients will turn up to you after say 3, 4, 5 days, 7 days, whatever time, and will complain, and it's a nagging pain. It's a very discomfort, a great amount of discomfort that patient faces. And then you will be treating these cases, and we have learned the art of treating this one. Basically, these days this has reduced quite a bit because we are using a smaller bore needle, like 27, and the frequency has come down to almost 3%. The type of needle is also important here. Twink needle is the one that we use these days. It has a diamond. It has a diamond tip, and the incidence is pretty low here. This is a schematic animation of CSF brain, which is a normal patient, and the one which has a spinal CSF leak. The brain is shrinking and pulling down, and patient is having pain. I have an innovation here. If you ever face a patient with PDPH, and if you are admitting that patient for rest, reassurance, IV fluids, caffeine, trifluoperazine, and blah, blah, ask your patient to lie down in prone position as much as possible. Because if patient is lying down in prone or semi-prone position, probably the leak will stop, because leak will not happen anti-gravity, and there will be a faster healing. This is my conjecture, and I have applied it in couple of, few cases, whatever I have come across, and it has worked. Maybe you can also try it, and it might really work. I have not read it anywhere though, but this is my kind of innovation. As far as neurological complications are concerned, spinal cord injuries can take place because of bigger epidural needles or even spinal needles. Nerve root injuries can take place, peripheral nerve injuries can take place here. Cauda equina syndrome is one where we hit the cauda equina choosing the higher space like L2, 3 or even L1, 2. And a patient can go for low limb pain, paresthesia, weakness, etc. Almost all of them are self-limiting, but still they are incapacitating and they can really bother you. Epidural abscess is one dreaded complication, and epidural hematoma is another one. So this is a slide of epidural, cauda equina syndrome here. The needle has touched the cauda equina, and this is a transverse section, and this is epidural abscess slide. Epidural hematoma may occur in patients who have got hemostatic abnormalities, patients on anticoagulants, or if they are on, for some reason, on LMWH. LMWH, if the patient is on, it's a relative contraindication for regional techniques. But if the platelet counts, it's about 1.5 lakh, you can safely go for regional anesthesia. But if the epidural hematoma is big enough, and if it is compressing on the cord, spinal cord too much and giving big neurological symptoms, then surgical extraction may be required. Now, hypotension during spinal anesthesia during C-section is a very commonly faced problem. As we all know, it is a sympathetic inhibition, sympatholysis, that takes place because of spinal anesthesia, and there is reduced venous return due to dilatation of resistance in capacitance vessels. And here there was an advocacy of preloading these patients with crystalloid for about 500 to 1000 ml of crystalloids. But these days, most of us practice just co-loading the patient while the C-section is going on. As if at all we have to use vasopressors to combat this problem, ephedrine is the rightest choice. It is the first line of drug. But here in India, most of us are using mefentermine. The action is almost similar with both of them. Both are beta adrenergic and alpha agonist. Phenylephrine is another wonderful drug. It is pure alpha agonist. It will cause a peripheral vasoconstriction and raise the blood pressure immediately. If nothing works, adrenaline 50 to 100 micrograms is the drug of choice. When we almost always mix adrenaline with our local anesthetic like lignocaine, and if that particular ampoule which is lying there, we can always dilute that adrenaline to 10 ml and keep it ready for a safety measure. Noradrenaline and vasopressin are reserved for future infusion if at all it is required. Bradycardia almost always takes place along with hypotension. That is again because of a decreased preload and sympathetic inhibition. Reflex initiation leads to this severe bradycardia, and atropine is a drug of choice here. At the same time, because it is always associated with hypotension, mefentermine is also being recommended. Supine hypertensive syndrome, you all are aware much more than us. The inferior vena cava getting compressed by a gravid uterus and reduced venous return. The treatment is left tilt, wedge under the right hip, and quick delivery of the fetus. The severe syncopal symptoms and with hypotension and bradycardia will be faced. Cardiac arrest, that is a nightmare. Excessive head-low position, inadvertently given by the staff or the anesthesiologist, and or maybe a higher space selection for spinal anesthesia. It causes rostral spread of local anesthetic agent, and profound sympathetic blockade will take place, which will reduce catecholamine secretion by the adrenal medulla. It warrants urgent resuscitation, including, of course, CPR and endotracheal intubation plus ventilation as long as it is required. High spinal and total spinal. High spinal anesthesia, see, it is extremely important for all of us to be communicating with the patient in the first 10 minutes of the spinal block, because this is the time when drug may be spreading rostrally and higher spinal block can take place. So you can have your one eye on the monitor watching for bradycardia and hypotension. At the same time, another eye talking to the patient, check patient's phonation, check patient's coughing, check patient's breathing, whether patient is getting unduly sedated. If these are all the things to alarm you about the high spinal. Usually the desired level is T4, that is up to nipple, but if it goes up to say from T1 to T4, patient can have cardiac symptoms like hypotension and bradycardia. If it goes even above, hands and arms can be affected. If it goes even above, diaphragm and shoulders can be affected. And finally, if it spreads even up to brainstem, slurred speech, sedation and loss of consciousness can ensue. Now, Coming to general anesthesia, in true emergencies like cord prolapse or eclampsia, or whether is no or the regional technique has failed, general anesthesia is the technique of choice here. The advantages are rapid induction, less hypotension, cardiovascular stability, and control over airway and ventilation. But there are a couple of concerns here: difficult airway, aspiration of gastric contents, awareness and drug toxicity, of course, are concerns, but not as major as to be discussed here. Difficult airway, in this modern era, we see a lot of obese parturients, and they have got a high BMI, the body contour is such, they have large breasts, double chin, limited neck movement, and they are vulnerable to hypoxia very easily because their functional residual capacity has lowered. So it is very important to oxygenate all patients, irrespective of whether they have got high spinal or no spinal or whatever. It is important to build oxygen level in all these patients priorly, so that there is an oxygen reserved with these patients. Otherwise, it can be a nightmare if you are failing to intubate and patient is getting desaturated. At the same time, we are caught unawares because of incomplete airway assessment, because we haven't seen this patient priorly as in other surgeries. Now, sometimes the questions are complicated and the answers are simple. If you are thinking of difficult airway, why don't you have these modern video laryngoscopes? They are easily available now. They are not as expensive, and they can really save lives many times. At the same time, all the OBGY clinics should have these supraglottic airway devices like laryngeal mask airway, eye gels, or combi tubes. This is a short handle of laryngoscope, and that one is the regular handle. This short handle is very useful in patients who are very obese, and the handle touches on the chest of the patient, and it is impossible to pass the blade into the mouth of the patient. While the short handle, you can easily maneuver it, and intubate this patient. And this is the blade, typical blade, which is called McCoy blade. It goes at the tip, and if you press the lever, the tip will be bent, and you can it will lift the epiglottis, and airway will be easily accessible. This is a excellent position for a difficult airway patient. Put a small pillow under the shoulder and a few towels under the head, and it will make the access very easy. Now, pulmonary aspiration. This is still a leading cause of death, leading cause of maternal deaths. It is attributable to delayed gastric emptying, as we all know, increased gastric volume during pregnancy, decreased gastric pH, which is like 2.5, decreased gastroesophageal sphincter tone also because of elevated diaphragm. Obesity and nausea and vomiting related to labor are also contributing this particular problem. You can see here the blue lines are the maternal deaths because of aspiration, while the white ones are because of rest all other causes. So almost half of them are because of aspiration pneumonitis. You can very well appreciate here how much the diaphragm has gone up because of the gravid uterus. Now, gastric volume, you can appreciate here that in pregnancy, gastric volume is almost the double than in a normal patient, and gastric pH is like 2.5 compared to 3.0 in normal population. Aspiration pneumonitis, called Mendelssohn syndrome, which is a chemical injury to the lungs caused by the inhalation of sterile acidic gastric contents, while aspiration pneumonia is ultimately getting infection and pathogenic bacteria resulting into injury to the lung. This is a schematic presentation of normal and injured alveolus. It can be prevented with 0.3 molar sodium citrate. I do not know whether it is available here in India or not. I have never seen, I have never heard about that, but I just read about it. But 0.3 molar sodium citrate, 30 ml, can be administered 30 minutes prior to anesthesia, orally of course. H2 antagonists like ranitidine, proton pump inhibitors like omeprazole, prokinetic antiemetics like metoclopramide can be given in time so that their action takes place and we can prevent regurgitation of the gastric contents into the airways. Salic maneuver is cricoid pressure applied to the cricoid cartilage while the patient is being intubated, so that there is no passive regurgitation of the gastric contents and getting aspiration into the airways. Now, if at all this happens, the treatment is tracheal suction, rigid bronchoscopy in case of aspiration of large chunks of solid particles, management of hypoxia, of course, with CPAP in non-intubated patients, or, if warranted, mechanical ventilation and supportive care. Now, atonic uterus is a nightmare of every obstetrician. Now, it causes profound blood. You have always been, I'm attending these lectures since last 1 hour, and almost everybody is talking about atonic uterus and PPH. It causes profound blood loss, hypovolemic shock, unprecedented demand of blood. You have not so great a vascular access then when it really occurs. There is limited help around in a private nursing home, in a small clinic, and there is sheer chaos and panic. I would want all of you to have these crash boxes or crash cards periodically managed, periodically checked, and replenished from time to time, so that you never end up having a running lack of all these things and eventually facing bigger problems. You should always be having airway supplies, IV supplies, pressure bag. Pressure bags are very important. If you put your pint in a pressure bag and increase the pressure, it will literally run the fluid, and you can replenish the volume in almost no time, because it is otherwise impossible for you to give fast fluids as it is bleeding. Now, this is very important. I have seen almost many times that most obstetricians will have a patient in labor, say previous evening will have a 20 gauge needle in the forearm or on the dorsum of the palm, and the labor will go on. But when the patient goes into some crisis, you can hardly give any fluid through this small pink needle. So I would rather want all of you to discard these 20 gauge needles, use at least a green one, which is a 18 gauge, or in a crisis, the 16 gauge or even a 14 gauge needle, so that you can easily give fluids fast and replenish the volume as soon as possible. Otherwise, most of the times what happens is, I'm intending to give 1 to 1.5 liters of fluids during a C-section, but with this 20 gauge needle, and which is an old one, which is not even a fresh one, hardly 500 ml of fluid would be going to the patient. And in a normal C-section, it is still okay, but in a crisis, it is really not okay. So always ask for a fresh vein, a bigger caliber vein, a bigger bore needle, a bigger bore cannula, and even anticubital. We really don't mind anticubital veins. I do not know what is the hesitancy about anticubital veins. We in cardiac anesthesia have ever used anticubital veins only, and we have not faced any problems. So it is okay to use anticubital veins, though of course patient has to nurse the baby, but still it is okay. It is just a matter of 24 hours, and then you can always choose a better vein. So don't worry about the site or size of the cannula. It can really be life-saving. This is one point I really want to insist here. Central venous access, which is one of the easiest thing to learn. Believe me, at times we fail having peripheral veins, but central venous access is one of the easiest things to learn. Maybe you can learn from your anesthesiologist. Maybe, of course, he will always be available to help you around. But if he is not there, and if you in emergency you have to learn this, or if you know the central venous access, it is so constantly there, internal jugular vein, between the two heads of sternocleidomastoid, and at the angle of 30 degree and towards ipsilateral nipple, that you can almost always cannulate this. But remember one thing, central venous cannulation is not meant for fluid resuscitation. It is only and only meant for central venous pressure measurement and giving your inotropes or vasopressors. For fluid resuscitation, a good large bore, very well taken vein, peripheral vein, which is the key. So if at all you have to give vasopressors or inotropes like adrenaline or vasopressin or ephedrine or whatever, then central venous access is required. But it is easy to learn, and you can always ask your anesthetist, at least have a drill about it. This is about avoiding common iatrogenic errors that can take place. There are look-alike and sound-alike drugs. One has to be really, really very careful while pronouncing these drugs and asking your staff who are not always as literate as you. At the same time, all drugs should be called out by the pharmacological names. They should be, the syringes must be clearly labeled, and it is better to use the same brand forever. Now, for example, oxytocin. Now you have 100 brands of oxytocin available. Now you keep on changing your brand, and your anesthetist is coming to your clinic and getting confused now which is oxytocin. I mean, whether it is methergine or whether it is oxytocin. So always, irrespective of whatever other compulsions may be, but for important drugs, do not keep on changing brands. Keep the same brands forever. And about oxytocin, I have, as I know, there are only 1 ml ampoules available. It is 5 units, right? So why don't you ask your pharma friends to have bigger ampoules, like 5 ml ampoule and 10 ml ampoules, because a lot of times you will be needing, say, 5 ml or 10 ml or whatever the doses of oxytocin you require, and you may have to break open 10 ampoules and then filling them one after the other in a chaotic situation, whether you have lack of people, and there will be real trouble over there. And resource enrichment to counter emergencies. You should always have video bronchoscope, though is okay, but video laryngoscope should always be there. Airway bougie for proper intubation. Should have syringe pumps, volume infusion pumps, USD machine. Of course, you all have adequate number of large bore IV cannula and central venous catheters. Things to make life easy: staff training and CPR. As you grow in your practice and your age, you become humble, but your staff becomes more egoistic, they become more arrogant, they become more complacent. So it is very important to keep training your staff all the while and train them in CPR also. By that token, you will also learn a proper technique of CPR. Of course, you all know, but still there is always a refreshing required. A friendly blood bank in the loop is required, and mock drills are as much important. It is said that luck is where opportunity meets preparation. So preparation is everything. One of them is an obstetrician and another one is anesthesiologist. Thank you very much.
Thank you, Dr. Himanshu. It was excellent, and some of the very important, small but practical points which you have told are really worthy remembering and listening to.
Thank you.
With this, I thank everybody. My thanks to Dr. Alpesh Bhai and the entire team, Ahmedabad OBGYN Society, and on behalf of two of us.
Excellent presentation, sir. Here I just wanted to pinpoint one thing, sir. As you mentioned nicely in your all slides, the one thing is the compression, and then there where we can use the wedge in a like patient with a like multiple pregnancy or obese patient. So precautionary, we are using wedge thing to prevent the compression of the aorta. But even after that also, in most of the time, if the patient is obese with the multiple gestation, the moment the patient is laid down, she started having the sudden fall of a BP, and that situation used to be little chaos kind of thing. So at that situation, what should be the done? All we know ki we have to take out a baby as immediately, but the thing is simultaneously the BP is that low and even the incision is not given. So what should be the ideal situation during that time?
As I mentioned, important drugs are vasoconstrictors. Oxygenate your patients with 10 liters of oxygen. Make sure that patient is well saturated, and of course IV fluids are anyway going, and the most wonderful drug here is adrenaline, I would say. So because we have wriggled out of many such problems with adrenaline, because if the patient is going through lots and lots of hypotension and bradycardia, I don't think anything else will work better.
And you already mentioned that preload, if it is done very properly, the supine hypotension can be reduced.
That is definitely to be done in all patients, the preload and everything. So your suggestion is to the anesthetist part will be covered and the obstetrician should continue
for the
course, yes.
procedure
Of course, yes.
immediately.
Of course, yes. Of course, yes.
So sometimes the few that anesthetist used to say ki just because the things are going on, the things should, but the thing is the baby should be out, then only the things will
Because
be.
it's a mechanical thing. Yeah. So it has to be taken care of.
Excellent
Thank you very
presentation,
much.
sir.
Appreciate
Thank you
it.
so much.
Thank you.
So that brings us to the end of the academic session today, and we all have to proceed towards the inauguration ceremony now. I request all the speakers, the chairpersons, as well as the audience to come for a picture, please, on the dais. Everybody together. So what? Come. Please come, let us all take a picture together. Documentation. Yes. Somebody had to hold my hand.
लास्ट सेशन में आटला सिंसियर इतना खबर पड़े Thank you.